Sad? Doing okay? I know it's kind of like a gnarly thing to start with, is electrolyte disorders early in the morning on the second day of a course. But some of you may have some electrolyte imbalances depending what you all did last night. Anybody win any money last night? Anybody willing to say you won money last night? I don't gamble anymore. I just decided that I'd rather spend my money on something I take home with me. But if you did and had fun, good for you. I'm going to talk about electrolytes. We're going to spend a half an hour talking about the things that are important to us. Again, yesterday I mentioned that nephrologists spend their whole lives talking about electrolytes and pHs and have all kinds of good times with this. There are a lot of things you can go into major depth on electrolytes, but the reality is the true emergencies come to us and we have to be facile with them. And the key to electrolytes is not to do what we call U-boxing the patient, where you make all the numbers exactly normal. The key to the electrolytes for you is to find out when they're truly an emergency that you need to do something right now about, when it's something you need to make a note of and do the right disposition, and when you need to just leave it alone. Not touch it at all. Because we can actually do more harm than good sometimes in getting overzealous in trying to make somebody's numbers normal. And we'll get into that when we talk about this. So you all know that you're just this mishmash of chemicals. You're these cations and anions that are floating around in your body. And your sodium and your potassium, your chloride, and all these things are really crucial, mainly because they're crucial on your cell membranes. They're crucial for you to be able to do action potentials to get your heart to actually beat correctly. These electrolytes, these positives and negatives that are out there, are how your body moves things around to actually make your electrical system in your heart work, to make your cells transport things in and out of cells. These are vitally important to how we function. And you basically are a bag of salt. You are basically, your total body water content is 60% of who you are. And a lot of it is salt. You're just basically a salt person walking around. And if these things get out of whack, you can affect things like how your heart works, how your muscles work. You can affect a lot of things because these are sitting at those cell membranes going in and out, helping things happen. Really, really important. That's why they're in there. They're in there to kind of transport across cell membranes and make things happen. Let's start with salt itself. Let's start with sodium, because sodium is a gigantic part of you, and it is really, we mess with this all of the time in meds that we give to people, and we can affect how people are with their sodium levels. So let's start with the concept, though, of first not doing any harm. So if a lab calls you and says, we have a sodium of 154, a critical value, sodium of 154 in your patient in bed 2, but your patient in bed 2 is just sitting there chilling, looking absolutely great, no problems at all, no meds, no reason to be that way, stand back a second. Look at that IV. Was that blood drawn from right above that normal sodium, normal saline IV that's 154 milliequivalents a liter? Stand back. First, do no harm. Remember, the patient will drive everything you do, not the number. The patient drives what you do. So treat the patient, not the number, and also fast versus slow matters. Not as far as how fast you do what you do, but how fast those numbers changed. People can tolerate things going slowly. How do people get to sugars of 1,600 and 2,000 like we talked about yesterday without completely being dead? Because their body adjusts to that over time. So a lot of these electrolyte imbalances, if it happens super fast, people get sick. If it happens more slowly, they can adapt. Think about your renal failure patients. They walk around with high potassiums all the time. They are used to that. Their body gets used to things. So fast versus slow matters. And we'll come back to that when we talk about treatments. Let's talk about hypernatremia. So the human salt lick. You've all seen these, right? The people that come in that basically have sodiums that are unbelievably high, 160, 165. My highest personal is 172. How does some human being even be alive when their salt is that high in their body? Well, the reason they're still alive is that usually these are chronic. They're usually people who don't have access to water or aren't able to get to water. So a lot of older people in nursing homes. This is the group we see most commonly with the super high elevated sodiums. The ones that come in with sepsis from a nursing home, and oh, by the way, the sodium is 159, which tends to be a chronic thing. What people will develop symptoms as you start to get over sort of the 150 range. You start to feel kind of gross. You feel kind of pasty and clammy and lethargic and kind of nauseated. And the higher it goes, the more altered mental status they get. They tend to basically get hyperreflexic, ataxic, and tremulous, and eventually they can go into a frank coma. They become truly the human salt lick. They're just a big lump of salt. The severity, again, depends on how rapidly it gets there. And if someone gets there, they're coming from a nursing home, and they're sitting there with a super high sodium, remember, yes, they're looking kind of sick right now, but it took a while to get there. We're going to talk about that in a minute. So treatment. Say somebody comes in with a sodium of 155. They're chilling, they're otherwise doing fine, but they're feeling thirsty, they're feeling a little sick to their stomach. They just feel good. Give them water. And that's what you do, by the way. If you have a soy sauce dinner, dinner where you drench it in soy sauce and you basically load yourself with sodium, the first thing that happens that you notice is you get really thirsty, right? Your mouth gets dry, you get really thirsty. Your body's like, hello, lots of sodium intake. Can you please just drink some water and let's get this thing out of our system? So give water, dilute it down, let people pee some of this thing out. So give water, that's the best thing. Oral is great. And remember, normal saline is 154 milliequivalents per liter. So if someone's sodium is 172, like the patient I took care of years ago, well, that normal saline is hypotonic to them. It's lower sodium than they are, and they're dry. So I'm going to tank them up with something like normal saline, give them some sodium back, but I'm giving them less sodium than what they have in their system. I'm diluting them out that way. So normal saline, especially if they're dry, is an absolutely fine volume expander to use that helps them perfuse better, get rid of the sodium they have. It's a fine thing to use. The key here is unless someone is truly dying or frankly comatose, you have time to bring that sodium down. There is no critical life threat really happening from that sodium per se, as long as they're breathing and they're hanging in there. What you really want to do is bring it down about 0.5 to 1 milliequivalent per liter per hour. Now, why? If someone's taken a week or two to get to that sodium of 160, that brain is also sitting at a sodium of 160. And now I dilute my serum down to, let's say, a sodium of normal, 140. My brain doesn't have time to shift that fast. I can end up with edema of my brain. So be careful with that. Any shift that's the same thing with high sugars, that's the same thing with high sodium, low sodium, we'll talk about that too. Don't shift things too fast. Your brain's got to catch up. So there's no urgency to go crazy here. They're almost always chronic. And eventually, once you've started to kind of hydrate them up and kind of get them tanked up a little bit, go to your MD Calc and calculate the free water body deficit, total body water deficit. And it'll kind of give you a formula of how to fix that. And you're going to get on the phone anyway with your intensivist or your nephrologist and sort of kind of get led down the path from there. The key is do no harm. Do not go crazy trying to drop this thing down because it takes a while to get there. We see hyponatremia way more often, way more often. And hyponatremia, I know when I was taught this back in internal medicine and medical school and emergency medicine, they talked about whether somebody was total body excess and total body dry, total euvolemic, hypovolemic. It's actually a little bit simpler than that. So let me talk about hyponatremia. So first of all, remember yesterday when we were talking about DKA and hyperosmolar state, when the sodium is super high, or the sugar is super high, the sodium is low? If that lab calls you and says, we have a sodium of 120 or 124, or whatever they call you with, the very first thing you've got to do, everyone agrees, the very first thing, step one, is to look at the sugar. You're going to look for pseudo-hyponatremia. You're going to basically calculate whether the sugar is contributing to that, it's not falsely, but basically measured low sodium. And there's formulas for this. The corrected sodium, and here's your formula here again. Go to MD Calc. Please don't memorize these things. That's what MD Calc is for, or whatever calculator you use in your smartphone. But the key here is what you're going to find, not infrequently, is that when you figure out that sugar of whatever 1600 is contributing 15 points of sodium drop, and you add it back to the sodium, you're going to find the sodium might be actually normal for that person. So you don't have to worry about low sodium. So correct it first. Low sodium in your brain, the synapse is look at the sugar, do the correction. If it's still low, and there are other things, by the way, than the sugar that does this. There are other things like super high lipids, etc. But these are rare. It's usually the sugar. So once you've calculated it, if the sugar is still low, or excuse me, the sodium is still low, if that salt is still low, now you've got some decisions to make. So let's start, though, with what you start with, which is symptoms. You're at the bedside, right? You just get this lab along the way. You're at the bedside. If the patient is seizing or in a coma, so you get called, come to bed 2, patient's seizing, comatose patient being brought into bed 2. First thing you're going to do is think about all the things that cause seizures and coma. Okay, you're going to go over to the compartment of your brain that has seizures and coma differential. You're going to go through all the things to think about. You're going to check a sugar, make sure it's not low. You're going to do anything that you can figure out if they're having a seizure and a coma from something else and fix that. So if it's something else, treat the other cause and then see if they get better. Okay, see if they get better. If they don't, though, if there's no other cause, and the only reason that they're seizing and comatose is that they have a low sodium, you're going to give them 3%. You're going to call, you're going to order it, you're going to click in your mouse, you're going to go to 3% sodium, and you're going to give them a bolus of 100 cc's. You are 100% safe to do that if they're seizing or comatose from that sodium, because if it's low enough to make them seize, it's low enough to need emergent treatment. Remember, symptoms drive, the patient drives what you do, the number doesn't. So the patient's going to drive what you do. Now, As that first 100 cc's is going in and the patient's out of it, you're going to go back now and you're going to figure out, wait a minute, how long did it take to get here? Is this a seizing child because their parent, while they had diarrhea and their parent was giving them free water replacement? So they dumped out a bunch, they're dehydrated because they've had terrible diarrhea and a rotavirus, for instance, and their parent is just giving them free water, just water for replacement, so they diluted really fast. That person I can correct quickly. I can get them back to normal quickly. Their brain hasn't had any time to adjust to that high sodium. But if it took a while, if actually it is that nursing home patient who finally got so high that they're basically seizing and comatose, but it took a while to get there, you're going to correct more carefully. You're not going to go as wild about it. Your goal, by the way, of this is not a normal sodium. Your goal is to stop the seizures and have the patient get some mental status back. Your goal is clinical, not a number. Really important to remember. Your goal is to get the patient to a point where they're no longer seizing and they actually have some mental status back. Because you can go crazy, and if you focus on the number instead and go too far, you can end up with overcorrecting them for what their brain is ready for yet. So this is where, again, you are smart people. You're at the bedside. You know, you're looking at the patient, and now they're not seizing and they're opening their eyes. Okay, I'm going to chill for a second. And now we're going to go back and we're going to look at the bigger picture. How did they get here? How did they get such a high sodium? Let's do our calculations on total body water deficit. Let's check this out, okay, or low sodium. We're going to check this out. So be careful. Don't correct too fast. You basically want the total number of, the maximum duration of treatment is about 24 hours. You're going to go about that far. So the key here is improved symptoms. Stop them from seizing and then figure out, why are they low? Why are they low? Is this a person who has cirrhosis? Okay, I know I need to worry about that. Is this a person with CHF? Okay, I'm going to go over there. Is this a person who's on a bunch of meds that might do this? Why are they low? Those are be careful with this. Get them to stop seizing and then step back and think, why are they low? Why is that here? And here is what your internal medicine colleagues are going to do. They're going to say, oh, but can you get a FeNA? Can you get a urine sodium? Can you get a urine osm? I will tell you, go ahead and click and then ignore the numbers. Because you are smarter than that. They can do that, that's fine. Your job is to figure out the clinical history. We have the history. We go and you walk to the bedside, and the person is somebody who was just started on Lasix, and they've had they've just been peeing out like crazy. It's somebody who has bad cirrhosis. I have a clinical history there. It's somebody who has lung cancer. Oh my gosh, SAIDH is what I have to worry about. You have the clinical history. So go ahead and order those labs. And it's fun and interesting to calculate out the FeNA and all that jazz. That's fine. But the reality is for you, you're going to put the patient into 3 boxes. They have too much volume. That's that cirrhotic person. That's that CHF person. They have too little volume. That's the person who's on the diuretic that we've just diuresed them down too far. There's the person with the normal blood volume where I have to worry about something else, like SIADH, like maybe it's a lung cancer thing. So you use your clinical brain. Numbers are fine, but use your clinical brain. So you're going to walk away from that person you stopped seizing because you gave a bolus of 100 cc's of 3%. You're going to walk away and you're going to say, you know, this person has a lot of body edema from CHF. I think this is a hypervolemic hyponatremic state. Boom, you're done. You figured it out. You don't need a FeNA to get there. So we know for hypovolemic, it's either renal losses because we're peeing it out with a diuretic, or extra renal losses, terrible diarrhea like those little kids can get. SIADH, for euvolemic, it's SIADH almost all the time. Then that's things like people with brain cancer or lung cancer, et cetera. Polydipsia syndrome, which is a psych problem, and rarely these are people that have the things the nephrologists get super excited about, like resetting what's called their osmostat. Don't worry about it. Their body fluid is normal. And then the hypovolemic is that CHFer, that person with cirrhosis, the person with renal failure who's really got too much fluid on board. You can do this clinically. You don't need all the fancy schmancy numbers. You absolutely do not. So the symptoms now, if you've stopped them from seizing, if they have anything else, so I'm lethargic, I have some symptoms from this hyponatremia, I'm nauseated, I have a little bit of a tremor. No, I'm not seizing and comatose, but I feel ghastly. You're going to determine their volume status, too much, too little, you know, the Goldilocks thing, and then you're going to go from there. If somebody has too much blood volume, or too much, volume overall, too much water volume, you're going to fluid restrict them. No more water. No more water. So they just don't get to drink anything. You put fluid restriction orders on their chart, and maybe give them something like Lasix. Okay, done. Easy. If they have too little fluids, they just don't, they're dry. We peed out too much sodium or they're dehydrated. We basically refill the tank with isotonic saline. Go ahead and fill the tank. Give them potassium if you need to. And remember, you don't have to go super crazy with this. It can take a while to get there. It's fine. You're not going to correct more than a half to 1 milliequivalent per hour if they're not super sick. So you have a ways to go. It's fine. Take your time. If it's just right, if it's that person who has SIADH, oh, your total body fluid looks fine to me, that's the person you're going to fluid restrict and then figure out what's wrong. It's actually really easy to approach hyponatremia. Do no harm. Correct the seizing if it's there, correct the comatose if it's there, figure out their body fluid status, and then you're either going to fluid restrict and diurese, fluid restrict alone, or maybe even tank them up a little bit. Easy peasy, really easy. The question here is disposition now. Now what do you do? Well, you know the person who's super sick stays in. The person who's super sick on presentation, who has a super low sodium, 120 or less really should stay in the hospital. It takes, to safely get them back to 135 takes a while, so hospital or OBS kind of thing. And any other reason to admit, they have some other medical problem going on. In those cases, go ahead and order all those extra labs. Order the serum osms, the urine osms, the urine sodium. That's fine, because they do need to tweak it in the in-house setting if figure out exactly what's wrong, but that's doing a favor for them. You don't base your decisions on that. And then there are patients you're going to want to not send out quite yet. So somebody who basically isn't super sick, and their sodium is sort of sitting in the 125 range, it's going to take you, remember, it's a half a milliequivalent to 1 milliequivalent per hour to get them up to the normal range. So that's a minimum of 10 hours to safely get them to the normal range. So put them in OBS. That's the kind of person you're going to want to get in OBS. And then everyone else can go home. If their sodium is 128 and you have a good reason for that, and you kind of can talk to their doctor about what to follow up with, that is somebody you might be able to send home as long as you're sure that it's going in the right direction. So it's really not hard, hyponatremia. It doesn't have to be as crazy as you may have learned in school. For us, it's pretty cut and dried. These are two slides that summarize in words what I just talked about with some pictures. So you have to take a peek at this if you want the last two slides to kind of summarize. Let's switch over to potassium. So potassium so low sodiums kill people, or high sodiums kill people, but not very often, and certainly nowhere near as potentially lethal as hyperkalemia. We are all very good at hyperkalemia. We see this all the time. People get sent to us all the time with hyperkalemia, right? My favorite is the referral for, what are you sending the patient in for? Well, their potassium was 6.2. Okay, great, when was that? Well, from the lab draw last Monday. It's like, we see that all the time, right? All the time. Hyperkalemia, though, is something that can absolutely kill people. It should be in your differential diagnosis of bradycardia. It should be your differential diagnosis of that. Be your differential diagnosis of bradycardic arrests. It should be absolutely in there because your heart needs potassium. The sodium-potassium pump in your heart is what is your automaticity. It's what keeps you going. It's what we poison with digoxin when we give people dig. It is really important, that sodium-potassium pump. Potassium is crucial to making your heart work right. If you have a person that has, so you're going to have two instances when this is brought to your attention. One is when the lab calls with a critical value. Okay, critical value is a potassium of whatever. The other is when somebody hands you an EKG and you're smart and you say, wow, let's check a potassium on this person. This EKG makes me worry about hyperkalemia. Those are the two instances where it's going to get brought to your attention. The main reason people get hyperkalemia in the United States, renal failure is 1, 2, and 3. It's renal failure, renal failure, renal failure. The drugs that do it are ACE inhibitors, and we see it, and it is not at all uncommon that when you go through the patient's, grocery bag full of meds and you're pulling out all the meds and stacking them on the counter to figure out what they're taking, you're going to find an ACE in there, an ACE inhibitor in there. And interestingly, lisinopril seems to be a big actor in this. I'm not sure why, but ACE inhibitors, look for those. ACE inhibitors can increase your potassium, so look for those things. So renal failure, ACE inhibitors, those are the two biggest causes of hyperkalemia. Now, the EKG, what they're going to hand you is an EKG that may have one of several findings. And I think about an EKG like a string. So it's like a string, and the string has this lovely little QRS thingy in there, your P wave in there. And what hyperkalemia does to me with that string is first it pushes the string together. And when it pushes the string together, that T wave pops up and becomes really pointy. So it pushes the string together first, and then it starts to pull the string out. As it pulls the string out, what it will do is basically drop your P wave out. So I lose my P wave, pulls it out longer, I get my QRS to widen a little bit, pulls it out longer, I go into a sine wave. So that's what I think about when I think about what's happening is the potassium goes up to that string of my EKG, pointy first, drop my increase my PR, drop my P wave, increase my QRS, go to sine wave, pulling out that string. And anywhere in there, you can just go into sinus bradycardia. Boom, sinus bradycardia. It's just that your automaticity in your heart says, no, we're just going to slow down. We're just going to slow down. Anywhere in there. It isn't, after this happens. That can happen anywhere in that stretch of things. So our treatment of this is our aggressiveness on how we go crazy with this really depends on the patient and the EKG. Really important here. So symptoms and EKG findings. The first, and I'll tell you, there's some debate about where you go charging in with calcium. To be honest, calcium is rarely harmful. It has some potential for harm in renal failure patients, but in general, it's rarely harmful for the way we're using it here if there are changes on the EKG. Definitely anything beyond a peak T wave, and some people will even recommend it with a peak T wave. So anything where the EKG, if you have the EKG that looks like hyperkalemia and they have an elevated potassium of whatever, 6.2, please feel free to go ahead and give calcium. It is the first line. What it does, by the way, at the heart is it basically says, calcium be gone, or potassium be gone, calcium is here, and it keeps, it basically, and you'll see the EKG change. You'll watch it on the monitor. People have sinus bradycardia from hyperkalemia, you push calcium, and boom, their heart rate goes up. People have their widened QRS, you watch it narrow. It is so awesome. You actually watch it happen up on that EKG. So it works right now at the heart. It is the lifesaver if you need it. So EKG changes. The more severe they are, the more alarmed you should be. Use calcium. Now, it's recommended to use gluconate. You can use calcium chloride. The key is just not to extravasate it. Okay, and go ahead and just push an amp. You don't have to do all these calculations. People get in the heat of the moment, don't worry about numbers and which one has more calcium in it, and just grab one of them with calcium and give it. Because you're going to watch the things change, and then you'll have time to regroup and figure out why are they hyperkalemic, and what do I have to do long term about this. But don't go too crazy in focusing on which of them should I use and what should the dose actually be, and just grab an amp of calcium. If all you can grab is off the crash cart, go for it. That's absolutely fine. Just don't let it extravasate. Now, once I've gotten that EKG better and the patient's bradycardia has gone away or their EKG is narrowed down, it's not looking normal, now I have to figure out what to do about that potassium in their body. Okay, it's still in there. So I can do two things. I can get rid of it and I can shift it into cells. So what we do for the short term is we shift it into cells. So I can give glucose and insulin. Remember yesterday we talked insulin drives potassium into cells. So if I give insulin for sure, and if their glucose is already high, I don't need to necessarily give glucose, but if they're normal, I give them both. Insulin will shove that potassium into cells. Bicarb, if I alkalinize someone who is acidotic, I can shove that potassium back into cells. Now, bicarb used to be part of the cocktail for everything. You are now more sophisticated in knowing that it really only works in people who are acidotic. It buffers that acid, it helps that potassium go back into cells. It really doesn't work that well in people who have a normal pH, but it's fine to grab, and if the person's critically ill, certainly go for it. And then inhaled adrenergics, grab your albuterol. Albuterol drives potassium into cells. So I'm doing something here, I'm doing something in their IV, I'm giving them sugar, insulin, and maybe bicarb. Now, all I'm doing now, though, is moving it. At some point, I have to get rid of it. Now, the ultimate get rid of for renal failure patients is they might need dialysis, okay? They need to get it out of there. They often have missed a dialysis, they need to get dialysis. But we're often asked to bind it, to give something that's like a binding resin, where it actually binds in the gut and basically gets sucked into the gut. Kxalate was the thing we used forever. I'm supposed to use the long names here, but forget it. I'm just gonna use what we all know. Kxalate we've used for a long time. It's fallen out of favor with pretty good reason, actually. It doesn't work very well. It has some potential serious downsides as far as things like colonic perforation, et cetera. It's not particularly perfect. And we've all gone to Lokelma, but I want you to understand that both of these medicines take a while to work. They don't work right now. And in fact, the product insert that comes with Lokelma basically says don't use it in emergent situations because it takes too long. Your nephrologist will often say, will you please do this? Will you please give this to somebody? So I can come in tomorrow and dialyze the patient. If it's a safe thing to do, fine. But if it's going to be 12 hours to get the patient, the nephrologist in and get them dialyzed, and you're going to be bolusing the shifters over and over and over again because this takes a while, it may not be a safe practice. So you may have to put your foot down. And then there are other medicines as well that are out there. But just know these are eliminators and they take a while. So we have this awful window in between definitive something like dialysis and yay, we got them better, that we have to bridge with something. And often it's either multiple meds or just putting your foot down and having them come in and actually particularly dialyze patients. Now, how about low potassium? So low, again, this is really common, and we do this to people. So this is our fault. Usually it's our fault. It's usually renal losses that we've given somebody a diuretic for their hypertension, and they're basically peeing out potassium. Super, super, super common. But you can also get it from GI losses, so people who have bad gastroenteritis can get this. People who don't take in enough, that's not common, fortunately, at least not in our country. Shifting of this, if somebody's put on, let's say, albuterol, they already have a low potassium, they can get lower. Diuretics, we mentioned already. Alkalosis does this, can basically cause shifting in of potassium. And what people get with this, my favorite case of this, my absolute 100% favorite case of this ever, we had a patient brought in years ago, 20-ish-year-old guy, brought in by his family, and the chief complaint was, he's a lazy son of a bitch. That was the chief complaint. You know that people bring people to the ER for everything, right? I had a family bring their tati, their grandma, in for us to tell her that her grandson had been killed in a drive-by shooting. Like they brought her in for that. It wasn't a medical thing. The ER really is the place where people come to get answers. It really, really is. So this lazy son of a bitch got brought in by his parents. And apparently this lazy son of a bitch had been sitting in he liked to watch TV, whatever he watched, wrestling or whatever. And he would sit in the chair in their living room and just channel surf, like all the time. Wouldn't go out and get a job, And he kept basically just sitting there and not moving. And then that particular day, he'd had a whole bunch of ice cream, was sitting in the chair, watching the TV, and slid out of the chair and laid on the floor and wouldn't get up. And they were just pissed off. So they basically picked him up, put him in the car, and brought him to us. And he was lying on a gurney when I saw him. And the fascinating thing was, I said, lift your hand. No can do. Move your leg. No can do. Like, wait a minute. Lifted his arm up, wham, back to the bed. Lifted his leg up, wham, back to the bed. The critical value I got called back was a potassium of 1. He had periodic paralysis. He had been eating ice cream, jammed his insulin level super high because he chugged a bunch of ice cream, insulin high, potassium into cells, dropped to the bottom. Basically, that's actually, by the way, a life-threatening level of potassium. That is I can't breathe level of potassium. No muscles are working at that level. So fortunately, and that eventually it all shifts back out again and they're fine, but that was a dramatic example of what your muscles need the potassium to do. Weakness is a problem here. Palpitations, you get ectopy from this. Your heart doesn't like having a low potassium at all. And what is often, not in that case necessarily, but definitely in the cases that are diuretic related, magnesium is also usually low, and we kind of ignore that. But it turns out magnesium is the key to making these people better. If you notice it, you need to treat this, okay? And people feel gross, they feel lack of energy, they feel terrible, and mild cases usually are oral. You can just, and by the way, oral is beautifully absorbed, wonderfully absorbed. Just make sure they can tolerate it where it doesn't make give them stomach upset or make them nauseated, but give them oral replacement. And I'll tell you, if somebody comes in chronically hypokalemic on a diuretic, and they say their potassium is 2.8, their total body deficit in that, if their potassium is 2.8, is probably 200 to 300 milliequivalents. It's a lot. It's a lot to get them into what is a normal body sort of amount. So it's going to take a while to get there. If they're really, really sick, like somebody who is not moving, although not that periodic paralysis, guys, but other people who might be in that situation. He made his own self better. Or somebody who basically is having a ton of ectopy, or VTAC and their potassium is low. You can go ahead and give it IV, that's absolutely fine to do, but remember, your body's not gonna keep that in itself unless it has magnesium to go with it. They go hand in hand. Magnesium will help you basically, it's a shifter thing, but you need to have magnesium replaced as well. So if in your head, you need especially IV mag, go ahead and make sure or IV potassium, make sure you're giving IV mag as well. Mag, potassium go together. You can give oral potassium if you want to, but give a little bit of oral mag as well. It will help them actually raise their potassium level. Here's some EKGs. We talked about the hyperkalemia, peak T, then you lose your P wave, then you sort of increase your QRS and go sine wave. That's the one on the bottom. Hypokalemia doesn't do a lot, but maybe gives you a little bit of ST changes, sometimes a U wave. All right, hypercalcemia. We see this in cancer. Cancer. Hypercalcemia. We also can see it in hyperparathyroidism, but we tend to see this in cancer. Breast, lung, kidney, it's basically bacon, lettuce, and tomato or the kosher pickle. Breast, lung, thyroid, kidney, prostate. Those tend to go to bone. What we find when people are hypercalcemic is they have vomiting, constipation. They have this thing that you learned about, maybe this mnemonic, basically bone stones, groans, and toxic moans. They end up with painful bone problems. They end up with renal stones. They get kidney stones. They end up with abdominal pain, mainly from constipation. They get bad belly pain. And being hypercalcemic makes you loopy. It makes you confused. It makes you lethargic and actually make you comatose if it's high enough. Depression, psychosis. And think about somebody who has cancer, right? They're already on opioids, so they're constipated. They already have cancer and they're psychologically incredibly stressed. So it is not at all uncommon where somebody comes in to see you who has cancer and you attribute their symptoms to their cancer or the meds they're on. I want you to, when you see a patient like that in the ER, please look at the labs and look at their calcium. If their calcium is high, you may be able to make a lot of that better by fixing their calcium. The EKG will go with this with a shortened QT. The QT is shorter with this thing, so that hypercalcemia, it's shorter, hypocalcemia is longer. So you'll see a shortened QT here. And the treatment here is basically, if somebody's super hypercalcemic, they're 14 or higher, give them water. They're dehydrated with this. They get water, so give them sodium, give them a normal saline, tank them up, and I will tell you, that drops the calcium a lot in and of itself. So often you've done your first job. You've tanked them up. You've started to help them feel better. You've got to get them sort of, now they'll go on to the next step. But you've done your job. You've identified it. You started to treat it with hydration. And now they can go on to definitive medicines, which include things like salmon calcitonin, bisphosphonates, et cetera. Those things, honestly, we don't need to do in the ER. Your job is to basically get them on something like normal saline and then talk to their docs. Hypocalcemia is with renal failure. This is the person who comes in with tetany. They end up with tetany and spasm. There is a mnemonic called cats go numb, convulsions, arrhythmias, tetany, numbness, paresthesias of the hands, feet, and lips. That goes with hypocalcemia. They may end up with true tetany, like they get their hands stuck like this, but honestly, that's not, they end up with sort of myoclonic tetanic staph. The key here is to treat them with replacement, mild replacement. You don't have to go crazy. You can do it orally, you can do it IV. Basically, gluconate is fine to do with this one. So is calcium chloride, but calcium gluconate is probably best here. Magnesium I'm going to spend two seconds on. Magnesium is the silent electrolyte. It is hardly ever an emergent problem. The only time it's really problematic is when you need to replace it to get somebody's potassium up. You can use it, basically most people who have hypomagnesiemic are alcoholics. That's a chronic thing for them. We fix that a lot by giving mag in our little sort of yellow bags kind of things. But in general, this is not something that's clinically relevant for us most of the time. Treatment, again, orally is the way to go. Hypermag, again, extremely rare, usually renal failure. And that's something we're already taking care of, to get the dialysis involved, but it rarely causes anyone to have any significant symptoms. So here's kind of a review of the electrolyte abnormalities. You're experts at this. Thank you for your attention. And I'm going to bring up Dr. Tabatabai, right? Tabatabai.
That was pretty good. Yeah.
He is awesome. Besides the fact he has the funnest name to say ever, Tabatabai. It is like so awesome. Love it.
Thanks, Diane. Diane and I have done things together, and every time it's like a fun little variation of the name, Tabatabai. It took me a long time to figure it out myself. But I'm not here to teach you guys about the last name. It's too confusing. I'm going to teach you guys about shoulders today. What are we missing? Here we go. Yeah. Hope the first 24 hours have been treating you well. Exciting, but not too exciting in a bad way. I just got in this last night. We drove in from Palm Springs and went through the Mojave Desert. It was the first time I ever took that road. I don't know if any of you guys are coming from California. You guys? There's one road that you can usually take, the 15, that is the straightforward shot. If you ever have the chance to go through the Mojave Desert, it is a funky drive. It is such an interesting, bizarre desert. Beautiful rock formations, all these like random homes on the sides of the roads that are like pretty sure built without permits. They're very interesting sort of desert places if you haven't seen them. And if I forget to say this, on every Vegas trip that I come to do this course, I almost always have an extra day to go to Red Rock Canyon. So if any of you guys have a little bit of extra time, the weather is beautiful. If you get a chance to check it out, check it out. All right, let's move on to shoulder disorders. So the shoulder to me is one of the most fascinating and interesting joints in the body. It is a remarkable joint. It is what's the most mobile joint in the body? The shoulder. And because of this remarkable mobility that it has, it is also remarkably prone to injury and unstable. And so we're going to start off talking about shoulder anatomy, and then we're going to dive into a bunch of the different conditions that you can get with the shoulder. So in terms of shoulder anatomy, it's pretty complex, but I'm going to try to simplify it for you guys. The shoulder complex is essentially comprised of 3 bones, 3 joints, and a bunch of stabilizing structures in the forms of muscles, tendons, ligaments, bursa, things like that. So the 3 bones are the clavicle, the scapula, and the humerus. The scapula also has the acromion process and the coracoid along with it. The scapula is also very interesting. It is essentially, if you really think about it, it's a free-floating bone that's not really attached to a whole lot of axial skeleton. It's really tethered to the body through just musculature and that kind of thing. And then the 3 joints are, starting immediately coming out, are the sternoclavicular joint, the acromoclavicular joint, the AC joint, and then the glenohumeral joint. All right? And then we're gonna, on this photo, you can see sort of peeling back all the muscles and the structures. I want you to focus in on sort of that area right under the acromion. It's called the subacromion space. And under there, you can see the subacromion bursa, you can see the supraspinatus tendon, you'd see the long head of the biceps. We're gonna talk about this when we talk about impingement syndrome. This anatomy, there's everybody in this room has a variable space here. There's a different potential space. Some people have really tight subacromion spaces, some people have a little bit more full. And depending on how much space you have in there, it can make you more prone to shoulder pathology. So the key concepts for the shoulder are remarkably mobile, but also unstable. The last important thing to know about the shoulder is that when you do have an injury, particularly a traumatic injury, it usually happens in combination. So say you have a dislocation, you can also get that with a fracture. You get a dislocation, a lot of times you'll also have a rotator cuff injury in conjunction with that as well. And so let's start with the exam, the old school exam. This one is, to do this really well is actually, it takes a little bit of time and effort, but I think it's worthwhile to be able to learn to do this in a relatively quick way. So for me, the approach is you palpate, you inspect, you get somebody through their range of motion, and then you do a quick motor sensory exam. If you get good at this, you can do this in 30 seconds to a minute. And so inspection, the way that you would really want to inspect somebody with a shoulder injury, particularly if they're telling you if they had a fall or some sort of trauma, is you really want to get their shirt off to be able to inspect and look for the symmetry or asymmetry on both sides. Once you're done with the inspection, then the palpation happens. And the palpation, again, I like to go from medial out. And so starting medially, you'll start with the sternoclavicular joint. Very difficult joint to dislocate or have injury in, unless you have a high energy trauma or mechanism, but still really good to start as a matter of routine. Sternoclavicular joint, palpate all along the clavicle, you get to the AC joint. Palpate on the AC joint, see if there's pain there, get to the glenohumeral joint, which then gets you right into your range of motion, because that glenohumeral joint is the reason why the shoulder is so mobile. And you want to get them in all the different cardinal directions. There's 6 directions. You want them in flexion, extension, abduction, adduction, and then internal and external rotation, which tests a lot of the rotator cuff. The strength testing, sensory testing, I'll give you a little bit more detail when we get to the cervical spine exam, going through all the cervical fibers, exactly how to do a good detailed exam of the strength and sensory in this region. So we'll start with the first condition, which is AC separation. So if you think about how this happens, how do people get AC separations? When most of us fall, for whatever reason, how do we fall? Or how do we ideally fall? Yeah, you want to get your hand out, fall on an outstretched hand. So if you fall and you fall on that outstretched hand, the types of injuries that we tend to get are either a wrist fracture, forearm fracture, or the forces can get transmitted up. And in the elderly patients, you can get a proximal humerus fracture. In younger patients, it gets transmitted all the way through. It can fracture your clavicle. AC separations don't happen that way. Somebody is falling, usually like somebody playing football, somebody snowboarding. They should foosh, or try to break their fall in some way, but they don't. Their arm is adducted, boom, they fall, and you get this directed force right at the anterior superior aspect of the shoulder that transmits into the AC joint, and then causes varying degrees of ligamentous damage. And so in the most minor cases, when you hear about a football player gets an AC sprain, what does that mean? It means that they have an injury to the ligament, they have pain when you're doing your palpation here at the AC joint, they have pain. That in and of itself is diagnostic of some form of AC injuries, usually a grade 1 sprain. And then as the ligaments start to tear, then you get higher up in grade. So every ortho condition, as you'll see throughout these next few days, has a grading system. And the thing with the grading system is in the ortho, you never want to have the higher score. The higher the score, the worse the injury. And in these cases, grade 1s are usually treated conservatively. Grade 2s and grade 3s mean that you start having some more damage to the ligaments and tears. Grade 3s, you lose your CC ligament, your corticoclavicular ligament, it tears. Still, those are mostly treated conservatively. And then it's called the Rockwood classification. Then there's grades 4s, 5s, and 6s. Those are the ones that need orthopedic intervention. What happens with those? You either spring that ligament so high that there's more than 100% translation of the AC joint, which can even cause skin tenting. You'll often see a big bulge in their AC joint. or it can like pop back and get into the trapezius muscle. It can cause damage that way. The bottom line is most of these can get referred to ortho unless there's skin tenting. And if there's skin tenting, then you got to call ortho in the ED. Otherwise, it's a sling. You refer them. If you see a tremendous amount of separation, more than 100%, just get them referred a little bit earlier so that they can get evaluated for possible operative intervention. Here's another picture of the Rockwood classification. Grade 1, sprain. 2, you spring one of the ligaments. Grade 3, you spring 2 of the ligaments. And depending on how bad it is, it can cause potential skin tenting and get into those grades 4, 5s, and 6s that we don't like. All right. So that was AC. Now let's move on to shoulder impingement. You remember that second anatomy photo that I showed you guys? That was showing the subacromial space. Now that is the reason that people get shoulder impingement syndromes. If you have some combination of anatomy that has a tight space in that subacromial space, and you're somebody that does some form of repetitive movement, maybe tennis, volleyball, something like that, or you're a painter, somebody who works and does overhead repetitive movements, this can over time cause this shoulder impingement syndrome. Why? Already there's people are anatomically predisposed. On top of that, if you start getting inflammation in one of those tendons that we saw, the biceps, the long head of the biceps that inserts there, or the supraspinatus tendon that inserts in that subacromial space, all of a sudden now you can get this shoulder impingement syndrome because of that inflammation. How will it look on exam? How do we examine these people? Again, we were talking about range of motion. If you get somebody who's trying to abduct their arm and starts to have pain at the arc above the, trying to abduct, that can be indicative of shoulder impingement syndrome. Now, in shoulder impingement syndrome and the next condition which we'll talk about, which is calcific tendonitis, it's painful whether you actively range them, meaning they try to range their arms themselves, or you passively range them, meaning that I grab the arm and I try to range it all the way up. Why? Because there's an anatomical impingement with both conditions. So whichever way you do this arc, they're going to have pain, which is different than rotator cuff injuries, which we'll also talk about later, which is only pain with active range of motion. If I passively range somebody with a rotator cuff tear, they shouldn't have pain. These are, and a lot of these are going to be treated with ice, pain meds, referral for PT and possible operative intervention if there's, in refractory cases. For shoulder impingement syndromes, most of these respond just to PT, ice, and rest. All right, here's another photo. You can see on that bottom photo right there what the impingement looks like. That's the subacromial bursa just getting squished as you have the patient abduct their arm. All right, calcific tendonitis, very much like shoulder impingement syndrome. There's an anatomical problem, usually at the long head of the bicep or the supraspinatus. This is a really fun condition because we don't really know why it happens. And once people get it, they tend to have it for a while, 3 to 6 months in most people, it tends to resolve. We also don't really know how to get this thing to improve other than doing some PT exercises. Some people can have it up to, the unlucky few can have this up to 5 to 10 years. Which really sucks. How is it diagnosed? Same way on exam as you would examine someone with shoulder impingement syndrome, pain with active and passive range of motion on the arc, abducting the arm. But also, you get the bonus of actually seeing something on the x-ray. How many shoulder pain patients do we get where we x-ray and you see nothing and you can't tell the patient that they, what they got? This is one of the few conditions, especially in the overuse category, where you can actually show the patient, look, here's this calcific thing. We don't know why it happened. You may have it for a while, and you're going to get some PT, but at least we know what it is, calcific tendonitis. So the treatment for this is rest, ice, and then you're going to also get them referred for PT. There are cases where steroids may be appropriate in somebody who's having excessive pain, that kind of thing. Usually the PMDs will do this, but it is a large enough space that if you have the skill set for this and you've done this, you could inject some steroids in there. But for the most part, I refer these out unless they're in tremendous, tremendous pain. This is something that you can try. All right, let's move on to biceps tendon ruptures. Who are the people that get biceps tendon ruptures? The image that I have in my head, it's not only this kind of person that can get it, but generally an elderly sort of gym guy who's like smoking a cigarette at the same time while trying to do curls. The people that are getting biceps tendon ruptures, smoking will increase your risk by about 7.5 times. Also, as you go up in age, you are more prone to having this type of tendon damage. And it's usually an eccentric force. You're getting resistance against flexion, and all of a sudden, you can pop your proximal tendon, the long head of the bicep. Seems terrible, right? They get this Popeye arm, the bicep rolls down toward the elbow, like emergency, right? Not at all. These patients do extremely well. A lot of times their biceps are still tethered because of with the short head of the bicep, and they do just fine with conservative management. Most of these never get operated on. However, that is, I'm describing to you the proximal bicep tendon rupture. That's the majority of cases. There is also a condition, and this tends to happen can happen in younger patients too, distal tendon biceps tendon rupture. That one can be a problem. And usually if it does happen in young athletes, those are more of an indication for ortho referral and repair. And the sooner you refer them, the better they have a chance of having a good repair. So proximal tendon ruptures of the bicep, no big deal. Conservative management, get them out as an outpatient. Distal, get them referred to ortho early in case they need that operative repair and they have better outcomes. In terms of other risk factors, we talked about the smoking, fluoroquinolones. So fluoroquinolones are I talk a lot about the residents that I work with at LA County. I work out at USC in LA about the caution of using fluoroquinolones. Fluoroquinolones are a wonderful medication. They are broad spectrum. They treat all kinds of things, but you have to know what the contraindications and the issues are with fluoroquinolones. And one of the major, and just so everybody knows, there is a black box warning on fluoroquinolones. You never want to be the person that gives fluoroquinolones to people with this black box warning. What is the black box warning? To give patients fluoroquinolones if they have a simple UTI, and then they develop a complication like a tendon rupture. So simple UTIs, acute bronchitis, acute sinusitis. If you end up giving somebody fluoroquinolones for those reasons, and they end up having some sort of tendon rupture, you can be liable. There's all these lawyer websites all over the web. They're annoying. There's a million of them talking about floxing, and if somebody's giving you a fluoroquinolone and this has happened to you and you've been given it for this condition, come see us and we'll make your doctor's life miserable. And so you don't want to be that doc. You don't want to be that provider. And the fluoroquinolones in this case, if you give someone a course of fluoroquinolones, in, say, a smoker or somebody with whatever, how long does their risk increase of having a tendon rupture? A while. So in the first 3 months, it's about 3 times as much. Next 3 months, it's about 2 times as much and can be increased for up to a year. So I still very much, I'm not saying don't get fluoroquinolones. I think they're a great medication. But like, for example, a COPD patient who's smoking and you think has acute bronchitis, give them a different medication. They're usually on steroids. They're already at risk. They can rupture their tendons. And so if you identify risk factors for someone biceps tendon rupture, they may be on steroids. They may have gotten fluoroquinolones. All right, we're going to shift gears to thoracic outlet syndrome. Thoracic outlet syndrome is actually sort of an umbrella term for 3 different conditions. And the 3 different conditions are arterial thoracic outlet syndrome, venous thoracic outlet syndrome, and neurogenic thoracic outlet syndrome. And they all present a little bit differently. So I don't know if anybody's ever seen a case. Has anybody seen a case of Paget-Schrader? No? So basically this is associated with people with repetitive movement, some sort of overexertion. It's often described that the anatomical space between the first rib and the clavicle is too tight. So as the nerves and the vessels come out of that space, they can get compressed, and you can have problems either with the artery, the vein, or the nerve. Paget-Schrader is the venous version of this, and it's a exertional sort of thrombosis that starts to develop, and you can get a venous obstruction. They can then subsequently clot. And I remember seeing a guy that had come from our jail emergency department who loved playing basketball, and he was playing basketball all day, shooting his 200 shots a day, make sure he never misses. And he came in and he had this huge arm, just on one side. And he didn't have a PICC line, he didn't have any other real risk factors, but what it was he had compression of his subclavian vein that subsequently ended up in him developing a DVT in his arm. because of this compression. That's called Paget-Schrader. If you ever happen to see it, that's what that is. Arterial thoracic outlet syndrome. These are patients who end up getting sort of like pallor, numbness, decreased pulses in their unilateral arm, which in and of itself sounds scary. You know, you want to have a Raynaud's in your differential. You want to make sure they're not throwing clots from other reasons, but have thoracic outlet syndrome in your differential. I'm going to talk about the provocative test that they usually talk about on exams and whatnot. It's called the Adson's test, so we'll talk about that. And then there's the thoracic outlet syndrome, which is sort of like numbness, tingling in the arm. I would imagine if I saw somebody with numbness, tingling in their like fingers, arm, that kind of thing, I'd be thinking about cervical spine disease. You know, but this is also something that's on the differential. Someone who's had MRIs and the cervical spine is fine, but they're continuing to get these sort of neuro symptoms. Here's the Adson's test. How does that work? You take somebody and this is sort of like a very dramatic position. You take their arm like this, you have them tilt their head toward the side of the affected injury, you feel their pulse, and if there's a decreased pulse on that side, that could clue you into an arterial thoracic outlet. It's not a great test, there's a lot of false positives, but it is something that's described and it's good to know. East test, arms up. This one checks for a variety of different thoracic outlet syndromes. You have them put their arms up. My wife, her dad used to, whenever she misbehaved a lot apparently when she was a kid, would have her like go into a corner and stand on one leg and do this for several minutes until she got tired. That was her punishment. And so that's sort of what the East test is. And if you do this for more than 3 minutes, your arms, if they get heavy or tingly or whatever, my arms are getting a little heavy just doing this, heavy or tingly, then that is indicative of neurothoracic outlet syndrome. All right, clavicle fractures. This is something you most certainly will see in your practice. You most certainly have seen probably at this point. But again, we talked about the ways that AC separations can happen. Adducted, fall this way. Clavicle fractures can also happen if you adduct and fall directly onto your shoulder. They can also happen if you foosh. So about 40% of them happen with a foosh mechanism. The others can happen with a direct blow to the shoulder. Both can cause fractures. The majority of fractures happen right there in the middle of the clavicle. That's the most common site. More than 80% are right there. Those are mostly treated conservatively with the sling. The other two places, which are more rare, can be more concerning. If you get a fracture sort of at the sternoclavicular joint very medially, that can be a problem and it can be associated with high energy mechanisms. If you get it out more laterally, that's at the shoulder joint. So if you get a comminuted sort of like clavicle fracture at the shoulder joint, you can get other injuries related to the shoulder. I always get shoulder films in addition to the clavicle views that you get whenever I have something out laterally. When do you consult ortho in the ED? Most of these, they go home in a sling, no problem, get them referred as outpatients. The ones that you want to call ortho and get them into the ED right away, again, just like we talked about with AC separations, if you see skin tenting, that is a problem. If you see a severely comminuted, displaced fracture that's overlying either side of the fracture fragments, you might call ortho just to get them closer follow-up, but generally most of these can be referred as well. Right? How do we sling them? I don't know if anybody remembers these figure-of-8 braces that seemed like they were better for posture than they were for actually helping with anything, and they were complicated to put on. They actually cause more injury damage to several of the structures, vascular neural structures. It's not worth it. You get just as good outcomes putting the patient in a sling. Now, one note for slings, a little kind of a nuanced thing, but when you put a AC separation patient or clavicle fracture patient in a sling, a lot of times we'll put someone in a sling and the weight is supported where? Right here on the forearm. But for these patients where you really want the weight distributed, you want them down at the elbow to kind of hug the shoulder complex up to prevent them from having more pain and issues. It's just more comfortable. So you want to kind of tighten up the sling a little bit, give them a little bit more comfort by supporting at the elbow rather than at the forearm. Rotator cuff syndromes, these are patients that this starts to happen in patients that are 40 and over. A good friend, colleague of mine just did a shoulder talk at USC. He very kindly noted that I was in this 40 and over range and that I was the person with the risk factors for this, the weekend warrior, the person that's doing repetitive movements. But this is a very common injury pattern. There are 4 muscles. You don't have to memorize these, just know that they exist, and I'll show you the provocative tests for each of these muscles. So the sits muscle, supraspinatus, infraspinatus, subscapularis, teres minor. Subscapularis is the only one in the front. Supraspinatus is the one that's in the subacromial joint. Cool? The way that you test for this, remember I said calcific tendonitis and shoulder impingement syndrome, painful arc with active and passive range of motion. In this case, only active range of motion. Abduction, you talk about the drop arm test. The indication really for orthopods to repair these are people that have like that are younger, like really want to maintain function. They do a drop arm test, boom, and the arm falls down when you abduct them. That's severe weakness. It's indicative of complete rupture, and those are patients that tend to be more surgical candidates. So abduction tests the supraspinatus muscle tendon, and then you're doing internal rotation, external rotation to test all the other muscles, all the other rotator cuff muscles. Rotator cuff mechanism, this is very interesting because we're going to be talking about shoulder dislocations in a minute. The rotator cuff is most prone to injury. You can see as the rotator cuff inserts into the greater and lesser tuberosity on this photo. And there's this vector diagram. I'm not going to get into the physics of this, but the position where people are at most risk for injury and dislocations is when they're flexed and they're abducted, like this. And so this puts your rotator cuff at the highest risk for injury. You can get, this is the position where a lot of people get shoulder dislocations. I was trying to read up if anybody's ever gotten a shoulder dislocation from an aggressive high five. I couldn't find any medical case reports, but I did find some blogs of friends that described this in mosh pits and things like that. So this position, the high five, aggressive high five position, that's one way that you can dislocate, but of course that's not the way most people dislocate. We'll talk about that. Shoulder dislocation syndromes, there's 3 major types to know. If you only know about one type, it's going to be the anterior dislocation because that's what the majority of people are going to come in with. The position that they're going to be in is usually a little bit abducted. They're going to have a flattened out shoulder, a bit externally rotated. It's going to be painful when they come in, and you'll recognize these when you see them. And these anterior shoulder dislocations are best put back in immediately after the injury. The longer they sit around and spasm and the muscles sort of tighten up, the harder it gets. So we'll talk about how to manage that. Posterior dislocations, the classic board exam for this is somebody who just got electrocuted with a lightning bolt or had status epilepticus and had a seizure, and they go into this contracture mode where they're hyperextended in all their muscles, and then you can get a shoulder dislocation. That's usually not the most common way that people will get it. It's usually through trauma, either a direct blow to the shoulder, young patients with trauma, things like that. But this is the most missed on x-ray, so we'll focus on that. And then luxatia erecta, this is the hand to forearm. This is you can pick this out from across the room. If you see a patient like this doing one of these in the room, that's luxatia erecta. It's an inferior dislocation. So before you do any kind of reduction, 2 things that you need to do: check the distal neurovascular status, make sure you check the axillary nerve over the deltoid, and then you want to make sure to have a good pain control plan. The longer you wait and send them the x-ray and do all these things, the harder it'll be for you. So if anybody knows how to do the intra-articulars, that's a really good way to do it. If it happens immediately after the injury, sometimes you can just pop them in without even any pain meds. But most of us in the ED will need to use either intra-articular or sedation, procedural sedation. Imaging, do we need to get pre-reduction films every time? So the benefit of it is you can see if there's fractures and those kinds of things. For traumatic like injuries and stuff, I tend to get them. But somebody who's a chronic dislocator who comes in multiple times and you've relocated them like 4 times in the last 6 months, those patients you can oftentimes avoid and just try to get them re-reduced. Post-reduction films, everybody should get those. After you've done the post-reduction, make sure you get a post-reduction film. All right, there's a million ways to reduce. I'm just going to focus on the 3 that I like the most. You can read up about all of these, look at all the videos. You probably have your own favorite techniques. I'm going to focus on a few. The Stimson and scapular rotation, really good when you have a very busy ED. The place is bumping, you don't have time. You hang some weights, you get them down at about 90 degrees, have them lay over the gurney, and then you come in after about 5-10 minutes and you try to do some scapular rotation. You take the inferior tip of the scapula, you move it medially. The error that I see people doing most often with this is they also translate the scapula superiorly. You don't want to do that. You get it inferior and you move it. You take the inferior tip and you move it medially, which then orients the glenoid fossa in a way that can make it easier to relocate. So this is one nice thing. This is you get a lot of variable success with this one, but it's something worth trying. We're getting comfortable with. The Ferris technique, fast, easy, reliable, and safe. This was developed by a Greek orthopod in the, I think right around when I was training, 2009. This is a technique where you take the patient, have them lie supine on the bed, and you extend their elbow all the way out. You have their thumb up, and you just kind of like wiggle their arm. You oscillate their arm like a handshake, and then sometimes it goes in, and you try to get them up to about 90 degrees. So it's kind of like a slow, relaxing, wiggly handshake that you do with them. Spazo is a rotary technique that you can look at. This is my preferred, Hennepin and Milch. The one that we don't have on here is Cunningham. So the first thing I always try for is the Cunningham technique. I really, if you haven't used it or you haven't seen it, it's the one where you sit down, you're face to face with the patient, you have them put their arm on their hand on your shoulder, and you put your hand on their elbow crease, and you just basically massage their arm at the proximal head of the bicep, the deltoid, the trapezius, and with very minimal pain medicine, a lot of these will pop back in. So that's always my first go-to. It takes very little pain meds. It's just a very relaxing procedure, and you kind of adduct them and bring them in as you do it, and you got to have them sitting all the way back, like have them kiss their shoulders as they're doing it. Tends to work really nice. But if I can't get it in with the Cunningham, then I go to the Hennepin and the Milch. Hennepin is external rotation. Milch, the picking apple position. So you get them out, and then you start to rotate them all the way up. And a lot of people will use some form of traction, counter-traction, where they wrap a sheet around the patient and start to get them up into the Milch. Okay, all the things not to do. If you ever read about a shoulder technique where you're taking your foot and you're sticking it in the patient's axilla, it's usually the wrong thing to do. It's been described, it is described, these like Eskimo techniques, Hippocratic techniques, don't do those. The other thing is the coker. If anybody, I just saw a resident that was doing this technique the other day, and I'm like, do not do this one. This one is associated with injuries and you can be liable. You take them out in external rotation and then you wrap them right back around with internal rotation. You can cause fractures, you can cause damage. Those are the things not to do. All right, posterior shoulders, easy to miss on an x-ray. It looks like a light bulb sign. Very rounded appearance. You have to get the axillary and the scapular Y views to be able to diagnose this a lot of times. This is a very tricky one and often missed. Luxatio erecta, we talked about this one, the hand to the forearm. The way that you treat these, you actually will just do inline traction. They'll be in this position, and you just pull and sort of internally, externally rotate them. We had a case of this a few days ago, and they'll generally pop right back in. Adhesive capsulitis, this is what happens when you don't, for all of these conditions we talked about, if nobody tells them to do range of motion exercises after, like, they have a clavicle fracture, they have a shoulder dislocation, they have any of these things, and you put them in a sling indefinitely for 4 to 6 weeks, they will develop adhesive capsulitis. A lot of these dislocations, you get microbleeding into the joint, and then the fibrin will lay down, and they can start getting fixed. And so there's no active or passive range of motion that they can do. They just get stuck and frozen. Not a good thing. The way to avoid this, you give them Codman's exercises. This is the exercise where you tell them to just gently kind of like do a pendulum thing with their shoulder. You can do some rotary stuff as well. Last thing we're going to talk about, proximal humerus fractures. You will also see a lot of this in your career. Typically elderly patients, forces get transmitted through a fouche all the way up. Most of these are treated conservatively. There's a near classification for this condition that if you have multi-part fractures with your proximal humerus, then it's very controversial, but some orthopods will operate on those. So get them referred to ortho. All these patients should get referred to ortho, okay? And if there's a dislocation along with the proximal humerus, don't pull on it. Mid-shaft humerus fractures rather than the proximal humerus, these ones have the radial nerve kind of coursing through them. If this gets fractured, you need to put them in a coaptation splint and refer them to ortho. Some of these need to get repaired, more nerve damage, things like that. If it's really severe, I would just call ortho in the ED. Sometimes they need to be the ones putting the coaptation splints. All right, guys. That's all we have for the shoulders. I'll see you guys a little bit later today. And we got Mike Gooch coming up for ear disorders. Thank you. Sorry for going over.
Well, good morning, everyone. Welcome back. So we started the ENT talk yesterday talking about nose, and we'll kind of finish up that this morning talking about ears. And some of the things we talked about yesterday are going to be applicable to things we talked about today, especially we talk about foreign bodies and all those really fun procedures. Just kind of a quick review of anatomy. There's 4 nerves and 4 blood vessels that feed the ear itself. The inner ear, the middle ear get really good perfusion. Your external ears are a little different story. For the most part, your external ear is all just soft tissue and cartilage with very minimal blood supply. So especially if we have a significant injury there, definitely those tend to be more prone for complications and healing. And we'll talk about a little bit if we're talking about doing anesthesia. It's really important that we not put any type of anesthetic agent that has epinephrine in the ear itself. We may do a regional block, that's okay, but not directly in the ear. And we really try to avoid putting anything in the ear itself because there's such a small space there as well. So we're looking inside the ear. What do I see? How does the tympanic membrane look? Is it has that nice classic textbook pearly gray look? Can I identify all those ossicles? Or is it dull? Or is it red? Is it truly bulging? One of the classic things we may see with an otitis. Do I see anything else weird there? How does the canal look? When we talk about otitis media in a moment, the other big thing is, can I do insufflation and actually see, do I have mobility and movement of that tympanic membrane? How do we get a good look at the ear? So the typical adage was, if they're under 3, it's down and back, over 3, up and back. As kids grow up, we tend to pull up. And sometimes that works, pulling down and back for those young kids and starting to pull up as they get older. But that doesn't always work for every patient. Just try what works. But usually you're going to do a little manipulation of that external ear, try to get a better view. But especially for those little kids, it's getting them to stay still. And I love it when parents are like, well, they're not going to stay still for this. Nope, that's why you're going to help me. Or we're going to get somebody else in here to help me because we're going to have to get a good hold on them. And obviously, the top position is not going to work. Also think about how you just kind of approach. And ideally, if I want to approach, let's hold it with my handle up so that my hand moves with their head versus holding the handle down with the speculum up. And that tends to go in further and cause more injury. But I really want to get a good hold on this kid, have mom or dad wrap their arms around them, sometimes get their legs too, get that head in their chest, and that usually does help. Making sure you're also using the right size speculum. For those little kids, don't grab the big one because that's just going to take up a lot of room and really more uncomfortable for that kid. But get a good view. A good light source is really going to be helpful. You know, sometimes it's like, where'd the head go for this one? It's missing out of this room, so you got to run the other room and find one, or just carry one with you. It's amazing how these things just disappear. So our cerumen impaction is probably one of the common things we see, which is kind of fun and kind of sometimes gratifying to take care of. So they may come in complaining of some decreased hearing, maybe it's that fullness sensation. You look in there and like, yep, there's just a wall. You can't see anything else. Sometimes it looks like you've got little hairs growing out of it because it's been there for so long. But what's your favorite trick or tool trying to get this out? Sometimes it's pretty soft and you can just use some instruments and just kind of get it out a little gently, but oftentimes it is just rock hard. So there are a couple things we can do. They actually make commercial preparations that are meant to dissolve the wax. Most of us probably don't have those available. I like warm water and peroxide. Dulcosat sodium also works, Colace. You can put that in there. The biggest thing is that I need to have some time. So I'm going to mix usually half and half warm water and peroxide, put it in there and let it set, and it may take 15 or 30 minutes, not our best for length of stay, or squirt that Dulcosat in there and just let them lay there, and then come back a little bit and try to manipulate that and get that out. I really like ear getting these out. I need a nice large catheter, so probably a 14 or 16 gauge IV catheter, or take your butterfly, just cut the needle off and use that tubing. That might be easier for you, depending if your resources are. And I probably need at least a 20 ml syringe. And I want to use some mild to moderate force. I'm not going to try to really force it all out, but it does take a little bit of force. Just kind of dribbling that in is not going to work. So what I want to try to do is get my catheter and my tubing kind of behind that if at all possible, so I can use that force to push it out. Or sometimes that at least will loosen it up, and then I can kind of instrument it out and get it out that way. There are actually a couple of cool little commercial devices out there. When I was a student and did my family practice rotations, one of the pediatricians I worked with had this little device. It actually plugged to the sink and had a nice little suction cup, and it actually created suction. So as the water shot in, it also sucked it back out, and there was no mess. I've never seen that in ED anywhere, probably because it cost a lot of money. But sometimes people will get red on this ride. So kind of warn them, maybe give them a gown, lots of towels and chucks. But this can be really gratifying. That big chunk comes out and they're like, what was that? Well, that was in your ear. Now I bet you can hear. And their spouse is like, I told you. But cerumen impaction, usually pretty easy, but you gotta soften it up first. Foreign bodies. We talked about some of this yesterday. These can also be pretty gratifying. The funny ones are usually the bugs in the ear. They come in and you see them walking in the hallway like bug in the ear. They're just all over the place. You can see their head, they're doing this thing. So sometimes it's the moth. I've seen roaches. I've seen all kinds of other things in there. That person is not having a good day because they can feel it and they can hear it and it is freaking them out. Probably would freak us out too. The first thing I need to do is drown it. If you have something really thick like mineral oil or even viscous lidocaine, pour it in there and drown it. And after a couple minutes, that bug is suffocated. Now it's easy to get out. It's no longer scratching and marking at the walls. And I can either irrigate it out or sometimes instrument it out. If I don't have anything thick, then just use water or saline. It'll eventually work. It doesn't work as fast because that bug could be more mobile. But then just kind of get a good look and see what I see. Now, if I am worried about a tympanic membrane rupture, this is probably the time I don't want to do the irrigation. I really want to try to get it out instrumentation. You know, some of the old texts will talk about like cut the lights off, get a light source, and the bug will come out to the light. I've never had that work. I've tried it just to see. The bug has no desire to come to the light. But just drown it and get that out. And for the most part, that's all the patient needs. They may have some little scoriation of the wall of the canal. It heals fine and does great. And they will be really happy because this bug is no longer in there having a field day with their canal and their tympanic membrane. But other things can be kind of interesting. Beads, pieces of paper, little pieces of plastic. So some of the things we talked about yesterday might be helpful if you've got a scoop or a hook. Those might be very helpful as well. The alligator forceps come in really handy here. Again, I need that kid or that person to be really still, so good holding methods, sometimes a little procedural sedation, sometimes a little bit of noxiolysis can go a long way. If you need to, let's get ENT involved, think about getting your other resources involved as well. But these can be really helpful in trying to get those hard to reach things. The biggest thing here is I don't want to push it further back. I don't want to cause other injury. I really definitely don't want to push it in the tympanic membrane and cause an injury that way. So one thing you may be able to try, especially like a piece of paper or a bead, something that's really hard to get, is take your cotton-tipped applicators. If you have access to crazy glue or maybe some of the skin adhesives, that's a little expensive, but put that on the end of that wooden stick and just go in there and touch that object. Obviously, I want a patient who's really staying still for this to happen, but that dries pretty quickly, and then that can easily allow me to remove that little piece of paper or that bead, something that's really hard to get out with instruments. But usually with a scoop or a hook, or even those balloon devices I talked about yesterday, those can sometimes work pretty well because you can get them behind the object, inflate, and then pull those back out as well. So the auricular hematoma, we talked about the septal hematoma yesterday, and just the same process here. This person's been involved in an assault, maybe they're a wrestler, they're a boxer, didn't have good protection on, and they get that trauma to the ear. And just like yesterday, the blood's going to collect there on that auricular surface. That blood is very damaging to that cartilage. And if it's not treated, as you see on the other side, they're going to get that cauliflower ear formation. And we see lots of people that had this. Typically, if we can intervene early and prevent reaccumulation, they usually have no problems. But it's really important that we get this drained, we pack it so it doesn't reaccumulate, so it hopefully doesn't cause this deformity. So there are a couple things we can do here to treat this. If it's kind of small, usually you can just use a needle and a butterfly and aspirate that out. If that has been there for 12, 24 hours, now it's time to coagulate, that's not going to work. Then I probably need to take a scalpel and size it, get all that out, express it all out, then hold pressure for a couple of minutes, and then do something to pack it. Most of the time, these are so tight that all you got to do is just really touch them and the blood's going to start coming out. They may not even need anesthesia. But if you're really concerned about that, this is the time for an auricular field block. We'll talk about that in just a moment. You just get the whole ear numb, and then they don't care. But I want to get all that blood out, and I want to pack that area, usually with Vaseline gauze, and get all that surface of their auricle covered up, and then put some gauze behind it, and then compress it together and do this compression dressing here. A couple techniques out there actually involve suture, and actually we'll put a couple of sutures through the ear itself to hold that skin together. Or actually, you'll sometimes see they'll use little pledgettes, and they'll suture pledgettes to that as well. There's several cool techniques out there to do this. I just want to hold pressure after I drain it, and then pack it and keep that pressure on there for about 24 to 48 hours, and then definitely have them follow back up. If this has repeated itself, it's reaccumulated, that's really the time we really have to do the IND and make sure we get all that out, even go in there with some saline and irrigate all those clots out, and then again, get it well compressed and hold that pressure so that hopefully this doesn't reaccumulate. If it does, they're going to get that deformity eventually. So perichondritis. This is kind of interesting ear infection. And what happens here, it's actually there of the cartilage itself. And as we talked about earlier, there's not a lot of good blood supply to the external ear. It's there, but it's not great like the rest of the face is. Your biggest culprit here is they decide to go get their tragus or their auricle pierced and then go get in a hot tub somewhere. And that's usually the biggest culprit here. And our biggest bug here usually is good old Pseudomonas. And so the key here, this diagnosis you notice, is it only involves the area of the ear that involves the cartilage. The lobule down at the bottom, there's no cartilage there. So there's no erythema, there's usually no redness, no swelling. Pseudomonas is well covered by our fluoroquinolones. And this is the one time that I might actually have to use a fluoroquinolone because I don't have a lot of good other oral options that cover Pseudomonas. Definitely I can go to my carbapenems. I can go to my anti-pseudomonal penicillins, but most of those are only parenteral. So this might be the time that I have to use a fluoroquinolone, but I'm going to do really good education of the patient. I'm going to document that decision making that, hey, there is no other outpatient option available here, and I definitely want this person to still have good close follow-up. But if they're severe enough, maybe giving them some parenteral antibiotics may be appropriate, and then definitely having them see ENT the following day. Also, if you haven't already, get that piercing out. That's just going to continue to irritate that area, and this also be a reservoir for bacteria. So our TM perforations, probably our most common here that we usually see are spontaneous. That patient has that really significant otitis. They've got a lot of pressure built up. Their ear is killing them. And all of a sudden it pops and their pain's better. Their pressure's released. Or they wake up in the morning and there's just blood and mucus all over the pillow. That's a classic thing we'll sometimes see with spontaneous. Sometimes we'll see this also with aviation stuff. Person decides they want to go fly and they're in a pressurized plane, but it doesn't pressurize enough for them, and they'll rupture their tympanic membrane. The person sitting beside them is never happy when this happens, because literally it's pretty explosive, and that blood and mucus comes flying out. It could be traumatic, using their cotton tip swabs. We'll sometimes see this with lightning strikes as well. They have that strike, whether it's indirect or direct, and there's such a significant pressure change that it actually will rupture those hollow structures, tympanic membranes being the most common. But also think about your skiing injuries. They're along skiing and they fall and they slap the water. We call those slap injuries, and that may force that water in the inner ear as well. When they're penetrating, those are the ones I'm really worried about complications, because that now has introduced whatever was outside, inside, like dirty water. So patients may have that pain, that decreased hearing sensation, and a lot of times when it does rupture, their pain gets better because it's relieved that pressure. Luckily, most of these that are spontaneous heal pretty quickly. Kids obviously heal a lot faster than we as adults do, but definitely think about that most people within a week, 2 weeks, are really going to be healed. Definitely if this is traumatic, this is penetrating trauma, that's the person I want to see ENT sooner versus later. But for most of these, they can definitely follow up in a week or two just for make sure they've got good resolution. If that doesn't heal properly, then they definitely can have some change in their hearing. And sometimes they'll go in there and do some grafting or something to try to give it a smoother appearance. Most of the time, these people aren't going to need any antimicrobial therapy coverage unless it's a dirty injury. Now, definitely this is that slapped injury from skiing. That's the person I may want to cover for something. Also, it's really important if they're getting and going home with this, educate them about how to prevent things from getting in their ear. So usually take their cotton balls, cover it with Vaseline or something else, and then put that in there so that when they get in the shower, they get a bath, they do anything else, that just prevents water from getting down in the inner ear. But usually these heal very well. Kids within a week, most adults usually within 2 weeks, unless there's something else going on. So otitis externa, swimmer's ear. Usually very common in the summer months. People are going out swimming in those large bodies of water, but definitely because of this other times. Our biggest culprit is us. We're using that cotton tip swab in the morning after the shower. I'm cleaning out my ears. It feels good. Cerumen is protective. It's there to protect the canal itself. But if I remove that cerumen, or I'll sometimes even abrade the wall with that tip swab, that's the problem here. And then they go swimming, and they get in those bodies of water, and they're exposed to whatever's in those bodies of water. Unfortunately, usually it is Pseudomonas as well. Your pools, your lakes, your ponds, all are culprits here. On exam, it's red, it's swollen, it hurts to touch it. Sometimes you can't even see in the canal. They have so much debris and so much swelling as you see here. Look at this, could easily be treated with topicals. So we're going to use a topical fluoroquinolone with a topical steroid. Here, the quinolones, I'm not worried about black box warnings. It's topical, has no systemic effects, so it's safe. But definitely the steroids are really going to help. The antimicrobial coverage is going to really help. Other option is neomycin with polymyxin. Neomycin works really well, but it can sometimes cause a contact dermatitis. So just be aware that occasionally you'll have somebody that comes back in worse ear, more red, more swollen, and it may not be a worsening infection. It could just be a contact dermatitis from the neomycin itself. So it depends on patient resources. Ofloxacin's fairly inexpensive. Now, if we get up to the things that actually have the hydrocortisone in it, that gets a little more expensive. Depends on your resources. Also, you can always put eye drops in the ear, and those might be less expensive. You just can't put eardrops in the eye. But if you have eye drops available, use those. There's no absorption here, so it just gives us that topical coverage for these patients. And usually they're going to feel better in a couple of days. If they truly have an otitis, within 2 or 3 days of treatment, they're going to feel better. It's going to start looking better. If I am worried about that tympanic membrane rupture, we don't always know, but if I can't see it and I'm concerned, just make sure you're prescribing a suspension. Your suspension otic solutions have a little bit more stable pH. It's more closer to 7 than your solutions. Your solutions tend to be a little bit more acidic. If you have access and they have a lot of edema, this is when the ear wicks really come into play. Those little cotton wicks work really well to just really pull that medication down through there, because sometimes it is so swollen, you just put the drops and it's set there. But if you can get that wick in there, it's going to pull the medication down through that area and tends to help facilitate resolution. And eventually it's just going to fall out. But that's a really good resource if you have those available. But definitely get your patients to tell them that, hey, when you put these in, I want you to lay on that side and stay there for 10 or 15 minutes. Let that medication have a chance to kind of work its way down through that edema. And that's just going to improve resolution faster than just putting the drops in and setting right back up. So now the fun one, otitis media. Talked about acute bacterial sinusitis yesterday. Kind of the same thing here. In most patients, this is actually a viral process. Most people are going to have a recent upper respiratory infection. They probably had some cold, some congestion. We know our risk factors here definitely are children under the age of 2 because of anatomy. You know, up until about the age of 2, those eustachian tubes are pretty flat. And they get a little bit of angulation to them. But also children in the home of smokers, children in daycare, recent antimicrobial therapy, and children who weren't breastfed have a higher incidence of having truly otitis media. So they may complain of pain, they may have a low-grade fever, they just may be irritable, depends on the age group. You know, that 3 or 4-year-old is going to tell you their ear hurts. That 6-month-old, that 10-month-old, they're just irritable and crying. If they've got a really high fever, think about something else. Typically your typical otitis is a low grade, 38, 39, but I'm seeing high fevers. Look for other culprits just to be safe, because it could be something else. Typically it's viral in nature. There's your big bacterial causes, H. flu, MCATs. If they have a concurrent conjunctivitis, that's almost H. flu, and that probably tells you it is bacterial in nature. But most of these start out viral, and they usually resolve fine. If they don't resolve, they may have converted over to a bacterial problem. So what do they tell us about? What do we see? I really need to get a good exam of this ear. Is it red? Is it bulging? Do I see an effusion? If I see an infusion, that's really important the parents or the patient understand the importance of follow-up care. Because that effusion doesn't resolve, that can cause hearing problems down the road. The textbook thing is to get my insufflator out and actually blow some air at the tympanic membrane and see if it's able to move. I've never seen one in the ED. It has disappeared years ago if we ever had one. But if it's red, it's bulging, that person's complaining of ear pain, yeah, it's probably infected. Probably viral in most people, but definitely could convert over to bacterial. How long have they had the symptoms for? It's been a couple of days, probably viral. It's been 2 weeks, that may have transitioned over to a bacterial infection. Most of these are going to resolve without intervention. Usually within a week, they're totally better, the inflammation's gotten better, they're doing great. Talked about several of these studies yesterday. Again, here, this one, number needed to treat, 15 to 16, but number needed to harm was still 9. Diarrhea. Antibiotics are not good on the gut. That, they're just irritating, but also they alter the normal flora. So if I'm really concerned about a bacterial infection, look at your guidelines, especially for pediatrics. And they give us some really good guidelines here about when we should treat and when we should wait. Amoxicillin is still a good agent for these patients, but it's supposed to be high dose, 80 to 90 milligrams per kilogram. That's twice what we used to use. So if I'm really concerned about bacterial infection, then amoxicillin's where we go with. Now, have they recently been treated for anything else? Oh, they were treated for an otitis a month ago. They were treated for sinusitis a month ago. Now I'm worried about this is resistant, so let's go ahead and add in our beta-lactamase inhibitor and use that amoxicillin with clavulanate. If they're truly penicillin allergic, maybe I can use a cephalosporin. If not, I can try doxy. I can try a macrolide, but unfortunately macrolides, 25% or more resistance, they're not our drugs of choice anymore. We have just used those out. If they're penicillin allergic, what was the allergy? Or if they're cephalosporin allergic, what was the allergy? Oh, it was just a rash. Oh, it was just some itching. Then we're probably safe to use the other one. Usually it's less than a 5% cross-reactivity between my penicillins and my cephalosporins. So less than 5%, that's pretty good odds. But if they go, oh no, we had anaphylaxis, then yeah, we're not doing penicillin, we're not doing a cephalosporin there. I've got to use something else. So here are the guidelines which came out from AAP and AAFP. So if they're equal to or greater than 6 months of age and they have severe disease, they've got a good fever, it really looks red, it looks angry, and it's been for more than 2 days, that's probably the patient that we might treat with antimicrobial therapy. If they have bilateral otitis media, that's the person who probably should be treated with antimicrobial therapy. Probably for most patients, around 10 days is plenty. More severe disease, younger kids might require a little longer duration of therapy. But look at the guidelines, look these things up. Unfortunately, this is the time we're going to have some shared decision making with patients, or their parents especially. Well, my pediatrician always gives us this CPAC. But what does we really need to do? And educate them. That shared decision making is important. Sometimes you accomplish something, sometimes you don't. But try our best effort to educate them. This is viral. It's only been happening for 12 hours. Let's focus on symptom treatment, not just giving them antimicrobial therapy. For most people, especially older kids and adults, they just want symptom relief. They want to get rid of this pain. Unfortunately, our great things that we used to have, like our topical anesthetics that really help with pain, benzocaine and antipyrine, they don't make it anymore. Aralgan isn't available anymore. If you have a compounding pharmacist in your area and y'all have a great relationship, he or she might make it for you. And your patient will be really healthy if they have both ingredients. Compounding pharmacists are not as easy to come by as they used to, but they will really make some good mixtures for you to help with these patients. But let's really focus on treating their pain. So acetaminophen, ibuprofen. If it looks really bad, maybe some viscous lidocaine will work. Put some drops in there, and that'll help relieve some of their discomfort. So their big things was here, if they're not severe, if it's not bilateral, then watch and wait is probably appropriate. Big caveats that we talked about yesterday, do they have follow-up care, and as long as they're not immune compromised. If they're immune compromised, I'm less likely to do the watch and wait, because this could easily progress very rapidly. Focus on analgesia, focus on education, and the importance of follow-up care. And unfortunately, they may need to come back and see me again. So be it. We'll be glad to look at you again and make sure. Sometimes we win that battle, sometimes we don't. But if it's been mild symptoms and only for a few days, it's likely viral. Let's watch and wait if at all appropriate. So bullous meningitis, sometimes when we look in there and we actually see this little bullseye right there on the tympanic membrane. They may have a little pain with it, but really no other symptomology. This usually is viral in nature. For the most part, it's associated with that upper respiratory infection they have. It'll resolve without any intervention. If it looks really angry, there might be a benefit for doing antimicrobial drops. Again, systemic, no effect, so it's all local. But for most of these people, it'll be fine. It'll be gone in a couple of weeks, no problem there. But if they're really complaining about this, then just make sure they follow up with their primary care or they come back if this gets any worse. But usually it doesn't affect, cause a high fever, shouldn't cause any change in hearing. So I mentioned this earlier, so ear anesthesia. If I've got a little small injury to the ear, maybe it's okay to put a little bit of anesthetic in the ear itself. If I'm doing that, it should be plain lidocaine or plain Marcaine. But that is such a small structure, and you distort it really easily. So most times, if I've got to do something significant to the ear, I'm going to do a regional nerve block. And what I'm going to do here is I can use lidocaine or Marcaine. You can use with epi if you want, just no epi actually in the ear. And we're just going to go right above the top of the ear and right below the lower of the ear, and just go in that angled pattern as you see here. And this gives you really good anesthesia of the ear. In 5 or 10 minutes, that entire area is anesthetized, and now I could do whatever I need to. Drain that hematoma, I could repair that laceration. A lot of us, I'm really particular. I may just get this over to ENT or plastics if I have that resource, because ears are not that easy to fix. But definitely if I've got something I need to try to fix, or even they've got that piercing I could try to get out and it's really hard to get out, this is when this might really come into play. There's some really good videos out here. It's kind of hard to describe without having a model, but just go straight above and straight below and angle up in those two directions, injecting your anesthetic. And in 5 or 10 minutes, they have really good regional anesthetic that's probably going to last 4 to 6 hours. So that can really help them with pain control. If I do have this laceration here that I'm trying to fix, how deep is it? If it involves the cartilage, it's gone through the perichondrium, that I got to take a little bit extra care to fix. Cartilage does not hold suture. So I definitely want to make sure I don't put suture through the cartilage for these lac repairs. I mentioned it earlier, we may do that with a hematoma repair. But with these lacs itself, I really want to make sure I've cleaned up that edge, and I don't leave that cartilage exposed. Most of this time, we're going to send this to plastics or ENT, let them fix it, because it really doesn't benefit from a microscopic type approach. But I want to clean that up. I want to close the perichondrium. That's your covering over the cartilage, but not the cartilage itself. I'm going to use some nice absorbables. If you've got 6-0 or 7-0, perfect. And then we're going to close the skin. Most would really say, let's go ahead and close the skin with non-absorbable so we can remove those in a week. In kids, that's really not fun. So some people will go ahead and throw in some absorbables and just let it be. If you have access to those really rapid resolving absorbables, your typical absorbable may last 2 or 3 months. There are some that are meant to dissolve faster, and they only last a couple of weeks. And if you have those name brands, they're great for resource. So I just throw a couple sutures in there, and then nobody has to worry about taking them out. Because trying to get these little sutures out is not easy, especially in a kid or in that little back of the area if it's behind the auricle. But use your resources. I definitely just want to make sure that cartilage is all under the skin. I don't go through it, and making sure they have good follow-up care. I've seen a couple pretty nasty avulsions here, and I'm like, nope, that's going to plastics. Because this is a lot of time-intensive work, and definitely it has a big cosmetic appearance for most patients. All right, our last topic, and we kind of started on this a little bit yesterday, but vertigo. As we talked about yesterday in the Q&A, this is everyone's favorite patient, right? So the patient comes in saying they're dizzy. What does that mean? Ideally, let them describe it. Don't offer them suggestions. Don't ask them, hey, does it feel like you're lightheaded? Does it feel like you're going to spin? No, because they'll say yes to everything. So when they say they're dizzy, what does it really mean? So true vertigo is that intense spinning motion. They feel like the room is spinning around them and they're going to have some balance problems. Hopefully this is a peripheral problem and this is something easily we can manage, but I've got to look for those signs of central problems we talked about. There's a couple things that can really help us here. Your typical benign vertigo is a rapid onset and short duration. It doesn't last for hours. Usually it's repositional. They turn their head, they get up out of bed in the morning and it starts. Nausea is really common with it because it usually involves cranial nerve number 8. So this table here may be very helpful for you. So look at their symptomology. When did it start? How bad is it? True peripheral problems, it's intense, but it comes and goes. Also, peripheral problems are fatigable. If every time they turn their head to the left, they get dizzy, if they keep turning their head to the left, the vertigo will actually get better. It gets less intense. That's fatigability. You don't see that with central problems. Do they have any other symptoms with it? The nausea. Sometimes they actually have some balance issues and they've got a little disequilibrium and trouble moving around. As we talked about yesterday, it's really important to get a good neurological exam. And there's lots of opinions about what is a true good neurological exam. But within 2 or 3 minutes, I can get a good idea of what's going on with your cranial nerves, your reflexes, your sensation, your motor. Peripheral patients will have an intact, complete, normal neurological exam. Most of your patients that have a central problem will have something in their exam that's abnormal. Maybe it's the pronator drift. Maybe it's your balance thing. Maybe it's finger to nose. So those are really important to document, and typically, most of those central patients will come out in your neurological exam. If they've got cerebellar issues, you're going to find it there. So vestibular neuritis or neuronitis. This is usually a viral problem. This can cause pretty intense vertigo. It usually doesn't cause the other problems that we see with other conditions like hearing problems or the tinnitus. If they've got hearing issues, that's more labyrinthitis. And if they've got the tinnitus, that's your Meniere's disease. Typically, those are going to help us really differentiate those two. Two big things we think about with tinnitus is Meniere's and aspirin toxicity. Or as my patient would say, that doctor told me I had manure in my ears. Meniere's. But Meniere's causes the vertigo and the tinnitus. So here with this vestibular neuronitis, this is usually an acute onset. They wake up in the morning, they get out of bed, and the vertigo starts. But it goes away. They may have this intense nausea with it, but usually head positions tend to make it worse. This usually is a viral inflammation of cranial nerve 8, so it's supportive care. Give them something that makes them feel better. Usually it's going to be either one of those antihistamines that are labyrinthine suppressants. ENT loves benzos. If you've got a patient that really has bad peripheral vertigo, some diazepam works. Number one, they feel good. They don't care what's going on, but it does really help suppress that vertigo. So if I'm really concerned about a central problem, we can talk about the HINTS exam. And there's lots of opinions out there about the HINTS exam. It does have some good benefit, but unless you do it all the time, it is not easy to do. I've watched all these videos and going, those look the same to me. So with the HINTS exam, what we're doing is the head impulse test. We're looking at nystagmus, and we're doing the test of skew. So with the head impulse test, we're testing to see how well our oculovestibular reflex is working. So right now, if everyone stares at the screen and just moves your head side to side, you can still read the screen. That is your reflex. It's intact. I can move my head and still see what that says. That should be what happened. But if somebody truly has neuronitis, that gets altered because the eyes don't stay focused where they're supposed to be. And what we're looking for is they have that saccade that we're looking for. So you actually just have them in front of you, whether you're sitting or standing, have them look at your face, you take their head and you move it to one side or the other, roughly about 20 or 30 degrees, but after you move it, you rapidly turn it back to the midline. And what I'm doing to see is what their eyes do. Your eyes should stay focused on the center target. And if I move their head to the left and then rapidly back to the center, and their eyes keep moving in that direction and then rapidly jerk back to the center, that's your corrective saccade. That is really reassuring this patient probably has vestibular neuronitis. If I don't see that corrective saccade, that tells me that reflex is intact and this might be a central problem. I need to do the rest of the exam. But the caveat here, your patient has to still be having dizziness, the vertigo symptoms, and they have to still be having the nystagmus. If they're symptom-free right now, this test is not helpful. So they're having the vertigo, they're having the nystagmus, we can do this. The head impulse test, if I see that corrective saccade, that's reassuring. It probably is a peripheral problem. Let's do the other two things as well. So then I'm going to look at their nystagmus and see what their nystagmus truly does. So just looking at them, don't have them focus on anything, looking at them, and then have them look to the right and see what their eyes do. Do they get that nystagmus beat to the right? Have them look to the left, see what their nystagmus does. In peripheral problems, that nystagmus be unidirectional. So it always goes to the left, or it always goes to the right, no matter what direction they look. If I see multidirectional nystagmus, it changes directions, or it starts having a vertical beat, that is very concerning for a central problem. So whether you have them look to the right or the left, this nystagmus always goes in the same direction no matter which way they look. That tells me probably peripheral. And then the test to skew. So looking at them, have them look at your nose, cover up one eye, leave their eyes open, you cover up one eye, and then you rapidly move it to the other eye and see what their eyes do. Remember, our eyes work together, they move together. But if I'm covering up one eye and then I rapidly cover the other eye, and I see that uncovered eye make a significant diagonal or vertical change in direction, that is very concerning for a central problem. So the HINTS exam, not easy to do. There's tons of great videos out there. But I've looked at them and I've watched my neurologist do it going, that looked like the same movement. But what do their eyes do in these? But most people that have a central problem are going to have neurological changes in their physical exam. So there's this detailed list. There's some really great YouTube videos out there to look at these. But again, your patient has to be having symptoms to doing this. And if you keep doing this, eventually your eyes will stop doing the nystagmus. So you can't just do it constantly for 30 minutes. You're not going to get good results. So our other big thing we have to think about is BPPV, benign paroxysmal provisional vertigo. Probably people that have BPPV have those little canalophysis. They've got those little calcium flecks that have kind of broken off and found their way somewhere inside the semicircular canals. And during position changes, this causes that intense vertigo. Typically the key is here, position changes make their vertigo worse. Now our treatment here is going to be the Epley's maneuver. We can do our Dix-Hallpike test to test for this. So the Dix-Hallpike test, when you have them sitting up, you hold their head, and as you drop their head over the bed, you turn their head to one side. If that recreates the symptoms that they've been having, that's pretty confirming the diagnosis of BPPV. And then we can do the Epley's maneuver. Some of us are good at that, some of us aren't. I know some physical therapists that do a phenomenal job with it. Neuro, other ENT people as well. I've not had good luck with it, but some people have really good luck with it. But if they truly just have the vertigo, it gets worse with positions. Your Dix-Hallpike test can confirm that. With both that and the Hintz exams and even the Epley maneuver, I want to be careful about who I use it with. If this is your older patient with a lot of arthritis, a lot of concerns for neck problems, that's going to be the person I'm going to be more careful with. And ideally, if I'm doing the Hintz in that just 20 or 30 degree turn versus the full 90, probably safer, but I'm going to be still selective who it is. That 90-year-old with kyphosis and cervical stuff, I'm not touching. If I'm really worried this might be a vertebral artery dissection, I'm probably not going to manipulate their neck a whole lot. So just keep those things in mind. And there's the Epley's maneuver. That sometimes works really well. It's just simply a repositioning technique. Things like BPPV does not get better with medications. They really need this reposition technique. And I know some of the neurologists and the other people, they'll teach them how to do it at home. Hey, you start getting your vertigo, this is what you do at home, and it works. So those are those repositioning techniques. BPPV will not get better with medicines. Meniere's might, definitely your peripheral problems too tend to get better. So just kind of summarize, look at your physical exam findings. What do I see with my neurological exam? One of our big culprits for really concerning vertigo is multiple sclerosis. That's one of the first things they sometimes get is that intense vertigo, but they usually have something else going on with their physical exam findings. Always think about those big bad things like your cerebellar strokes. Most of those people are going to have some changes with equilibrium or some of their cerebellar function. Do your physical exam. If in doubt, get neuro involved. Get your imaging studies. Those are sometimes very helpful as well. So good neuro exam. Think about your other things. Document your physical findings. Think about your use of your resources. If you need to, get that MRI. It is much better, especially if I'm worried about that posterior stroke, that cerebellar infarct is really going to help us. Here's this algorithm that may be kind of helpful with dealing with vertigo patients. Again, I'll look some of these things up to figure out what they are, but these can be some really good helpful tools. Use your resources. Go back to your physical exam. That neuro exam can be really helpful. Don't forget about things like coordination tests, cerebellar tests. Those can really help guide me in the right direction. All right, thank y'all very much.
All right, all right. We're going to, whoops, hang on. We're going to advance to cardiac dysrhythmias. A friend of mine gave me that. That's from my t-shirt, that little kitty cat thing. I love that, actually. It's one of my favorite t-shirts. All right, let's talk about cardiac dysrhythmias. And if you want to entertain yourself while you're hanging out here, Google Dr. Dance's dysrhythmias. Just search that. There are a couple of videos, but my favorite is a German doctor that basically, and I tried to do this, and I recommend you do this. He basically dances out this dysrhythmias. Here's his P wave, here's his QRS, and he does like sinus rhythm, and then he'll do first degree block, and then he gets all the way to V-fib, which is hilarious, and he goes to this all through all the rhythms. And I'll tell you, it's a workout, so we should like add this to workouts for people to dance out the dysrhythmias. It's hard to do. It's actually really fun. Okay, let's talk about cardiac dysrhythmias. And yesterday, when we talked about adult chest disorders, we talked about the fact that when you look at a chest x-ray, you have to have a system, so you don't miss anything. You have a system you go through when you look at a chest x-ray. The similar thing has to happen with EKGs, and it's, again, up to you. A lot of people use Dubin as their sort of their resource for this, but a lot of it have systems to look at EKGs that have the whole look at the intervals and the blocks and the QRS and all this jazz, the ST segments. Whatever it is, please pick one. And I will tell you, in this half-hour lecture, we are not going over every little detail of every possible treatment, of every possible dysrhythmia out there. This is a recognition lecture. We decided to put together a half-day course that we add onto our advanced course for actually EKG interpretation for all the different things that can happen in treatments, et cetera. That is something actually that's streamable, because we haven't done the course for a little while, but it's actually online. I can't do everything that's dysrhythmias in a half an hour, but I am going to have you leaving here with at least a system to look at things and sort of a general approach to dysrhythmias and not to be afraid of them. So that's the gist. So your EKG is all these little squiggles, and it's on this little piece of paper with little pink boxes that have different intervals. You do need to know those intervals. Those intervals are important. Each little teeny one, 5 of them is actually 0.2 milliseconds or 0.2 seconds. It's perfect. You can actually trace them out, but you need to know all of these complexes and intervals. The P wave, the PR interval, the QRS, the QT interval, the T wave, and the TP interval. Those are all important for you, particularly the P and the QRS and how they relate to one another when it comes to rhythms. So let's start. Let's start with first degree AV block. Now I'm willing to bet that in this room, probably 30 of you, 20 of you have first degree AV block. You're young, you're healthy, you're vagal, you're athletes. It is all first degree AV block means is that it takes a little longer from my P to talk to my QRS. So my P wave happens, then my QRS happens, and it takes longer than 200 milliseconds, basically 0.2 seconds. And that's actually fine for people with high vagal tones. It can be associated with heart disease. It's common in older people as your conduction system gets a little tired over time. But it in and of itself is not pathologic. It just is something that happens. It does increase somebody's risk, especially if you're older, you increase the risk of going into AFib later, but it's not anything right now that's anything to worry about. Just note it. We do start to worry though when we get into the higher degree blocks. Now, group Wenckebach, which is basically second degree block type 1, with basically first degree block. It's not usually a dramatic thing in and of itself. What this is basically the PR interval gets longer and longer and longer, and then eventually a P wave happens with no QRS. It just doesn't communicate anymore. So it gets longer, 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 drop. Longer, 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 drop. This is actually something also that's associated with increased vagal tone. Some people who are very athletic have this. It can be associated with things like ischemia. So it's something to keep an eye on in somebody who's ischemic, but it is not something that becomes chronic. Usually this reverts to normal sinus rhythm. Usually there's no consequence of having this. Every once in a while it will degenerate into even a second degree, second degree type 2 block, Mobus types 2. But in and of itself, you're just gonna make a note of this. Young, healthy person, no symptoms, good to go. Person who might have some ischemia, keep an eye on them, watch that, watch those intervals, watch what happens to their rhythm. But in and of itself, you do nothing except observe this and put it in the right clinical situation when you note somebody has Wenckebach. And it's kind of cool, actually. PR, longer, longer, longer drop. It's kind of cool to check it out. When it becomes type 2, though, this is different. This is PQRS or normal, so it just is bouncing along at its normal sinus rhythm, looks just fine, the intervals are fine, then all of a sudden a P wave happens and no QRS happens at all. That is much more pathologic. That is much more suggestive of something really wrong with the conduction system of the heart. And this is seen sometimes with ischemic events. So people are having cardiac ischemia. These patients, if they are symptomatic with this, you absolutely keep them around and you talk to a cardiologist. If they're asymptomatic with this, you keep them around and you talk to a cardiologist. These are things that actually are not normal. Your P wave should be talking to your QRS in some manner. It shouldn't just drop. The reason that type 1 isn't as concerning is that it has talked to itself for a while. And what it's doing is basically just becoming a little bit slower and taking one off. It's not like it's going, you're fine, you're fine, you're fine, I'm ignoring you completely. That is scary for the heart. That's not something that should happen. It's usually treated with a pacemaker, by the way, if somebody is symptomatic with this. So the second degree block type 2, Mobitz type 2, again, just a P with no QRS, but everything else looks normal, that should catch your attention. That involves a cardiologist. And then we know that, and the RR intervals would change with each, but honestly, you will recognize these. These aren't usually subtle. The only time they're confusing is when you have a type 1 Wenckebach where it's every other beat is dropped. It's basically RR interval, then it drops one, RR interval, drops one. That can actually be type 2, and that's confusing. And if you're ever confused, call a cardiologist. That's why they get the big bucks. Okay, have them work it through with you. And again, younger, healthier people, it's less concerning. Older people or people with heart disease, more concerning. Third degree AV block is where basically the pacemaker of the heart, the AV node is not talking, or the SA node is not talking to the rest of the heart. It basically is doing its own thing, P wave, P wave, P wave, P wave, P wave, and the ventricles are on their own. So you have P waves marching through, usually at what would be that person's normal sinus rate. So they're marching through at 80, 100, even 100, whatever the sinus rate is that for that person. And then the QRS, the ventricles are just depolarizing on their own. Your ventricles like to depolarize if they're left on their own at a rate of about 60. So what you tend to see in these cases of complete heart block is P waves marching through at any kind of rate. It can be 80, it can be 120. They just march through at any kind of rate. And then your QRSs just kind of hammer through there at a rate of about 60. And there is no communication at all. In an acute setting, by the way, this is very rare for people to have chronic third-degree heart block. They can, and those people usually have a pacemaker. But in anyone that has an acute anything, I'm syncopal, I have palpitations, I'm having chest pain, I'm having a myocardial infarction, anybody with an acute event that has third-degree heart block, you slap those pacer pads on them. You should do that probably with Mobitz type 2 as well. You slap those pacer pads on them, and you get cardiologists involved, because these people often need pacemakers if they have third-degree heart block. The summary for this is, again, remember, first degree is just the PR longer. Mobitz type 1, which is basically Wenckebach, is P QRS longer drop. The type 2 is where you just, it looks normal and then a P wave just happens by itself with no QRS. And third degree is the two things, the atria and the ventricles are doing their thing all separately. So, and again, progressively worse in general. And just keep the clinical picture in mind. PACs. This is where just your atrium decides to just go rogue for a sec. It's just that you have PA, and you guys have them all the time. We have them all the time, PACs. It's just somewhere in your atrium. Sometimes it's your regular SA node. Sometimes it's a little ectopic spot. But basically, something above the AV node just goes boom, done. You have a PAC. It is usually nothing except people may notice them. I've had, I can feel my heart flipping in my chest. I feel a palpitation. It is rarely significant at all. So the PAC just happens. You have a little pause afterwards. Everything gets back to normal. Very usually benign. Very, very benign. SVT is a different thing now. Now, SVT, if you think about the term, supraventricular tachycardia, SVT actually encompasses sinus tachycardia, MFAT, the reentrant SVT, AFib, A-flutter. That's all supraventricular fast heart rates. So SVT. For the purposes right now, though, we're going to use the term SVT for what we use it sort of routinely, which is that reentrant kind of tachycardia, the kind of thing like the shoulder dislocation that you just heard about earlier today that makes your day. Usually a young, healthy person zipping along, heart rate of 200, narrow complex, looks beautiful, boom, you can fix it. Awesome. That's what we're going to be talking about now. They are often young and healthy people. They often will tell you exactly when it started. I was driving my truck and I turned the radio on to the new, whatever, Taylor Swift song, and my heart went really fast. So this is they can usually trigger this exactly when it's narrow complex, it's super fast. This is the triage where they say, I'm bringing back an SVT. Everybody's happy with this. And they're easy to fix. These are usually very easy to fix. They're narrow, they're regular, they're rapid. Key, narrow, regular. Narrow, regular, very important. They're usually about 180 to 200. They're rarely faster than that. They're usually about 180 to 200. And you can fix it. You have drugs that can fix it. You have maneuvers that can fix it. It basically either slows it to show you it's an SVT or breaks it completely. Now, it can be wide. Sometimes an SVT, this true reentrant SVT thing, can be wide. And that can be for any number of reasons. That can be because the person has a heart block. That could be because the person has WPW. If it is wide and you are not sure if this is VT or not, it's fast, it's regular, and it's wide, maybe this is VTAC, it's 140, that's about what VTAC usually is. Is this an SVT or is this VTAC? If you are not sure, you don't have to be clairvoyant. Assume the worst and go ahead and treat that as if it were VTAC instead. It is totally, and you're gonna do it with a drug, it's totally fine. Or if you're not sure, go ahead and try to break it. Go ahead and do something like a vagal maneuver. That's not gonna hurt anybody. And see if you can slow it down and see what's happening in there. See if you can kind of see if there's a rhythm behind it. So if it's hard to distinguish, assume the worst. And especially if the person is older or has underlying diseases, definitely assume the worst. If it's wide, it's regular, and it's fast, assume the worst. Now, if it's not, and anybody who's unstable, I don't care if they're young and healthy. If they have a reentrant SVT that's narrow and they're unstable, you're just gonna cardiovert it. And you're going to do it synchronized, and you do it, I recommend highly going high. Go 100 joules, synchronize it, and get the thing to go. This ditzel thing hurts, right? Getting cardioverted, you're basically shocking somebody. So at least get your bang for your buck out of it. And if they're unstable, you may not have time or the blood pressure sort of boundary to be able to give even something like a sedative, but consider it, especially even afterwards. If it really is something that's painful, it hurts. So anyway, unstable cardiovert. Otherwise, you have time. This is where you can play. It's like the shoulder dislocation. What are you going to do? You can actually do a thing called the revert. This is the Valsalva maneuver, basically done with the patient kind of sitting in this direction, and you flip them with their legs up. And just look it up. There's awesome videos on this thing called the revert method. But it's a way to basically modify the Valsalva in a way that seems to be much more effective. The efficacy rates vary. And I think, anybody had it work? Have you tried the revert and had it work? I have. I didn't like it at first. At first I was like, what? But when it does work, it's like, wow, it is great. It is awesome. And it's non-invasive. It's super easy. So look it up, the technique. I'm not going to waste time here to do it, but look it up. It works. You can use the regular Valsalva, but think about it. I mean, when you tell somebody how to do a Valsalva, it's like, okay, well, like bear down like you're having a bowel movement. And people do the weirdest stuff, don't they? They go, and it's like, no. What I really want you to do is like take a breath. And you can have people blow out a candle. There's all kinds of things you can try. Try this. It's much, much better. So vagal, no harm, no foul with vagal maneuvers. It's fine. Don't rub here. But go ahead and do the breathing kind of vagal maneuvers. Those are fine. If those don't work, though, if the revert doesn't work, go to what we know. Now, I will tell you, calcium channel blockers work, and they're getting a little bit of a resurgence recently in the literature. They work. That's all we had back when I first started. And then adenosine, we all are very familiar with. It works beautifully. It's terrifying for the patient and for you, right? You give this 6 milligrams. Make sure you tell the patient that you may feel like you got kicked in the chest, which is often what they will tell you, because what you're basically doing is killing them for about 6 seconds. You're basically shutting their heart down, and everything just restarts. And they feel it. Some people will come in and say, never again, do not give me whatever that thing was, do not give that to me. I don't care what you do. Shock me. I don't care. I don't want it. But make sure that people know when you give it. It works beautifully. First time I ever gave it, it was when it very first came out. We'd never used it before. We started back in those days at 12 milligrams. And everybody wanted to see it, right? I was the first person in our ER to use it. So I was like, okay, cool. And so all the nurses are gathering around, all the residents are gathering around. We're all excited. And the patient's like kind of wondering why there are a million people in the room. And we did the whole raise the arm, push it, follow it with the bolus, everything. And we're all watching the monitor. And the patient kind of did that kind of gaspy thing that they do. And we're watching the monitor, and it broke. And I was like, wow, that's cool. And then it stayed flatline. And then it stayed flatline for 22 seconds. I almost had a heart attack. It's like the gray instantly came into my hair. Incredible. It does work. It works beautifully. So use adenosine. Again, no harm, no foul kind of thing. If you are given this kind of EKG, though, where it's wide complex and you don't know if this is SVT or VT, this one turned out to be an SVT. This is a young, healthy person, but if this is an older person, if there were any symptoms you were concerned about, like hypotension or anything, just treat it like VT. Cardiovert it if you need to use a drug like procainamide if you're not sure. Totally fine. Oops, back up. Now, AFib and AFlutter are also SVTs, right? We just have different names for them. So AFib and AFlutter, there are a million etiologies of this. This is extraordinarily common. I'm willing to bet that Vegas is kind of an AFib, AFlutter sort of hub for people that binge drink, right? We know binge drinking, holiday heart, causes transient AFib, AFlutter. I'm willing to bet this is a hotspot for AFib, AFlutter. Again, that's one of the gajillion reasons thyrotoxicosis, just aging will do this, heart disease does this, all kinds of valvular disease, a ton of things do this. Our job is to figure out how to treat these. So AFlutter is that sawtooth thing where your atrium is doing this little fluttery thing, but at a regular rate, at about 300. Why 300, I don't know, but that's what it picks. And your ventricle says, man, that is too fast, and it chooses to only take a certain number of those, usually at a predictable block, a 2-to-1 block, a 3-to-1 block, a 4-to-1 block. So my heart rate is going to be either 150 on the button, right? That's a 2-to-1 block, and it stays 150 and doesn't budge, or 100 doesn't budge, or 75 doesn't budge, because that's the different degrees of block of AFlutter. So if it is irregular, by the way, if it's 158, 144, it sits in the sort of range in there, that actually is probably AFib, just with big, huge fib waves on this. So it's not just the little teeny waves. So this is regular. And this is something that your body doesn't like. It doesn't stay there. So AFlutter usually goes away. It will either degenerate into AFib, or more often, it would just convert itself back, revert to normal sinus rhythm, which is often what we see with the holiday heart folks. Come in an A flutter, sit there for a couple hours, even a day, and then flip right back into normal sinus rhythm. Which means that we don't do much. Okay, you don't do much for A flutter. If you really, really need to, and I'll tell you, it's extraordinarily rare to really have to do anything for A flutter. I guess if somebody's fast and they're having chest pain, they're sitting at 150 and having chest pain, you might want to intervene. But in most cases, you just sit and let them sit. If you need to, you can slow them down. Calcium channel blockers work, beta blockers work. Same kind of thing as AFib treatment, same kind of deal. And remember, this will either degenerate into AFib or it's going to go away, and usually it tends to go away. Okay, so this one's usually not anything, you just watch it and it's like, dude, don't drink so much. You don't have to do much for this. AFib is a whole different story. So AFib is extremely common. And AFib should come, for you, it comes in two flavors. It comes in acute AFib, like new onset AFib and having trouble with this, or chronic AFib, and now you have other things to decide. You know, is that heart rate something you actually need to do something about? We'll talk about that in a minute. This is the irregular rhythm. So remember we talked about checking somebody's pulse when you walk up to the bed. You check their pulse, you put your finger on their pulse, and you find that their rhythm is irregularly irregular. You don't have to have me on the monitor, you know that. It's like, oh, likely this is AFib. You've checked that. Very, very common rhythm, extraordinarily common rhythm. When this thing is acute, so let's say one of you flips into AFib today. It is usually not heart disease that does that. It's usually something like a drug that you've taken, or thyroid disease that does this, or your alcohol binge that you've done over the last 2 days during the course. That's what usually throws you to an acute AFib. I'm in sinus rhythm and then I'm not. As you get older, as people start to develop what turns into chronic AFib, there's always a first episode of AFib, right? Everybody always has the first time. There's always a first episode. That is technically acute for them, and that is where you get more into its heart disease range as people get older, where it turns into more heart disease stuff. Our issues here, when you have somebody with AFib, first of all, don't freak. If the patient, remember, patient trumps everything. If the patient is stable, they're fine. They may not even know they're in AFib. I don't care if their rate's 140. You have time to just sit and hang out and figure out what's what. So ask about other things. Are you stressed out? Are you drinking a lot of coffee? Have you been sick lately? Do you have a fever? Do you have any chest pain? Are you having any shortness of breath? You know, you can add, have you had syncope? You can ask a lot. Take your time to figure out, ask about these associated symptoms. If it's a younger person, have you been tremulous? Have you lost weight? Have you noticed any change in your hair? You know, where there may be AFib or something that's going on there. The key here is to make sure you don't go charging ahead and treat the EKG. Treat the patient. That is critically important. I am not going to go into what to do about is it rate or rhythm control in AFib, because that is an entirely separate, gigantic topic that we actually cover in depth in the advanced course. Just know that with AFib, there are a couple things you do need to be careful about. One is, let's say I go to the bedside and it's a 62-year-old woman who's had AFib for a while, who comes in now with a temperature of 102, feeling pretty short of breath, and she's had a cough. Okay, she hasn't been able to eat very much, she looks clinically dry, and she has AFib and a heart rate of 145. Technically, that's AFib with RVR, with rapid ventricular response. But for her, it's sinus tach. It's the same thing you would have if you ended up with a pneumonia and you were dehydrated and you got sinus. Because her baseline rhythm is AFib, this is a physiologic response. So what you're going to do is you're not going to control her rhythm, you're going to fix her. You're going to tank her up, you're going to take her fever down, you're going to give her fluids, you're going to take care of what caused her to go into it was her version of sinus tach. The best example of this I had in my career of focusing on just AFib with RVR, I need to block. Okay, AFib, RVR, slow, AFib, that sort of thought process happened in a trauma where a young surgical resident, we were taking care of a trauma, an older person with AFib and baseline who had a ruptured spleen, ruptured liver, but it was like a solid organ bleeding injury, who was basically AFib with RVR, AFib baseline, increased heart rate, that the resident did just the knee jerk and treated with a beta blocker. Well, that's not what you treat a ruptured spleen with, right? You treat a ruptured spleen with resuscitation and maybe blood, or maybe even the OR. And the outcome was not fabulous. It was less than optimal. So make sure you're more sophisticated than that you look at the whole picture, and if this is a chronic AFib person and they're fast today, maybe there's something else going on. It's like having sinus tach. Treat those things first. And then whether it's rate or rhythm kind of ends up to you, but just know if you are a rhythm control person, you want to try to cardiovert, do it safely. And there are ways to do this, and again, that's literally an entire whole separate lecture. You can, if you're not sure if somebody's having, sort of AFib with RVR, if they're having, is this a flutter, I don't know, is this an SVT and I'm not seeing the P waves in there? You can do carotid sinus maneuvers and it will slow people down. What it can do with SVT sometimes is, these vagal maneuvers, is to go ahead and it might slow them down and show you, either convert them, or if it's a flutter, show you the flutter waves. It's like, oh, that's what that is. That 150, sitting there at 150, that's flutter, boom, got it. It may break SVT. It really doesn't do anything at all, usually for AFib. So you can use that kind of diagnostically if you need to. And again, these are the vagal maneuvers, not a drug like adenosine, although adenosine would do the same thing. Multifocal atrial tachycardia. This is basically a bunch of places in your atrium fighting for dominance. They each kind of go off and say, I'm going to make the beat happen. Now I'm going to make the beat. No, I am. This is basically multiple places in your atrium sending down basically stimuli that then your ventricle responds to. So it's narrow complex but irregular, and the P waves are all different. You have 3 or more morphologies of P waves for multifocal atrial tachycardia. Now this is not a heart problem, this is usually a lung problem. This is somebody who has lung disease. We see this by far and away in COPD patients. So this is somebody who has COPD. They come in and you notice that their heart rate is 120 and you see a bunch of different P waves, 3 or 4 different P waves. You fix the COPD, you will fix the MFAT. This goes away. So at least 3 different P waves. You can also see this with hypoxia as well. So fix the oxygen, you'll fix that as well. So treat the underlying condition for this one. And this top EKG here is multifocal atrial tachycardia, multiple different P waves, and tachycardic. The middle one is AFib. It's also irregularly irregular, but I don't see any P waves. The bottom one is what's called wandering atrial pacemaker, multiple different P waves, but the rate is less than 100, so it's not tachycardic. So that's wandering atrial pacemaker. This is the entity that basically strikes fear in most of our hearts. WPW. Not because WPW in and of itself is scary. What's scary is if you end up in an SVT with WPW. So what WPW is basically an alternative electrical pathway. To me, it's like the fast track lanes on a freeway, where most people are going the normal way and kind of slowly, and all of a sudden somebody goes zipping by you at a gajillion miles an hour. It's a fast track. On the EKG, the way you know it's there is your PR is really short. Okay, it usually is less than 0.12. You end up with that little slur, that delta wave on the upslope of the QRS, and the QRS looks longer because that slur makes it look wider. That's your clue on the EKG. And sometimes it's hidden. You look mainly in the standard leads for this thing. So you look in basically leads 2, leads 3. You can sometimes see it. Usually the standard leads are where you see this. And the reason it's important is that if somebody does get an SVT, if it goes down this pathway, it can go too fast. There's no sort of stopping it. It can go too fast from an SVT. So if you have a tachycardia in a person who has WPW, if it is a regular tachycardia and it's narrow, okay, regular, narrow, just treat it like a regular SVT. I don't care if they have a WPW or not. It's going down the right pathway. It's narrow. If it is regular and wide, well, now it could be an SVT going down that aberrant pathway. Okay, that's an issue. It's going down the aberrant pathway if it's wide, or just maybe that they have aberrancy anyway. But if it's regular, at least I know it's an SVT. I'm going to go ahead and treat that though as VT. I'm going to give them a drug that's going to slow that thing down. I'm going to slow that thing down. Wide complex in somebody who has WPW, I'm going to go ahead and use a treatment for VT. Procainamide is the magic here. And the danger is if they have an AFib where there's a gajillion stimuli happening, all these electrical impulses going down this pathway, they can actually crash and burn. So irregular complexes that vary in size, shape, and bunch up really fast. I'll show you in EKG. Bunch up together. Do not block that person. No. I will tell you, if you have any concern in a wide complex tachycardia, whether it is regular or irregular, just assume that you're going to go right to procainamide. Procainamide works for this. It works for VT. It works for SVT. It works for people that have atrial fibrillation. It works. Go to procainamide. It is your magic medicine. So if you ever are freaked out at an EKG that is wide complex, irregular or regular, and you're not sure, just grab procainamide. The magic to that is it works for all the things that might be, from benign to malignant kind of problems. So grab your procainamide. This is an EKG that is AFib in a WPW patient, and it is super fast, and they're bunched together. If you see where that V2 is on this EKG, and right to the left of that are these bunched together super fast complexes, that is extraordinarily fast. Your heart can't do that very long. I don't care how healthy you are. So that person is procainamide. And if you're unsure, shock them. If they really are crashing, and just shock them, get them out of the thing. These two algorithms, this one and the one that's on the next page, are really, really good. They summarize all of it for you super clearly. It takes you to what the entity might be and suggests what the treatment should be. And this one I like in particular. On the far left of this algorithm, the far right, I guess, to you, this algorithm where it says that the patient has underlying heart disease in a wide complex tachycardia, you assume VTAC and you treat it as such. Underlying heart disease, assume VTAC. All right, let's go down to the ventricle, PVCs. PVCs are where just your ventricle has an extra beat, and they happen all the time, like PACs do. They happen all the time. We don't treat them in and of themselves. We don't treat them. They can even happen to people with ischemia if they're isolated. We don't treat them. We used to, I will tell you. I'm old enough that we used to, and it turns out we killed people by knowing that. Not a good idea. The drugs are not benign. So if they have a PVC here and there, that is fine, even in somebody having a heart attack. If they're multifocal, it gets your hackles up a little, so pay closer attention. Those mean the heart is pretty irritable, so keep an eye on those. More is worse, multifocal is worse, and ultimately, ganging together, becoming VTAC is what we worry about. Technically, it is defined as 3 PVCs in a row, but sustained VTAC is where they're basically more than 10 beats in a row or longer, where now it is the ventricle just basically doing its own thing. We know that this can end up degenerating into atrial fibrillation, or to ventricular fibrillation and cardiac arrest. We know it can. So if you're not sure what's what, if they have this rhythm that's this wide complex tachycardia, remember, wide complex, the older they are, the sicker they are, the more underlying disease they have, especially heart disease, assume that that is VTAC and treat as such. And anybody unstable, just grab those paddles and cardiovert them. Now, last couple of weird rhythms. Torsade. Torsade de pointe is basically a form of ventricular fibrillation. They call it a form of VTAC, but it's not perfusing. So it's, to me, a form of ventricular fibrillation. And it's the one where it goes bigger, smaller. It looks like somebody takes a crepe that you use while you're decorating, for parties, and you twist it. It's what it looks like, almost like a twisted sort of strand of things. This is something that basically is usually a magnesium problem. So, or an acid problem. We don't hardly ever see this anymore because this turned out to be extremely common as the degenerative rhythm in people that overdosed on tricyclic antidepressants. We don't see people on tricyclics very much anymore. So torsade is extremely rare. We hardly ever see this. If you see somebody with torsade, you're going to grab magnesium and you're going to grab bicarb. Bicarb because if there is a tricyclic on board, that's how we treat it. Magnesium, because magnesium does seem to fix this rhythm. And if the person is awake with this, which is uncommon, be careful, expect them, they might vomit from the magnesium, but if they're out, just push it, absolutely push it. Usually counter shock will not fix this. Trying to shock, it's so frustrating. It's like shocking should work with this. Why isn't it working? It usually does not. So this is where remember, mag and bicarb, remember. Grab those and push those. Now, the last rhythm I'm going to talk about is Brugada. Brugada theoretically didn't exist until it was discovered about 10 years ago, but clearly we had young people dropping dead before that, and this is probably why. This is a channelopathy. Remember we talked during the electrolytes that your body needs sort of the sodium and the potassium to go across all these membranes, and they go through channels. This is a sodium channelopathy in the heart that is, it tends to be familial, not always, but tends to be familial. It was initially described in young Asian men. Where basically they just drop dead. They just drop dead. They have sudden, out of nowhere VF arrest. They just drop dead. It is probably one of there are multiple causes, but it's one of the causes of people dropping dead as a young person. And because it's familial, you're going to ask somebody who's had a syncopal episode, we'll talk about this when we talk about syncope, you're going to ask every single one of those people, do you have a family history of anybody who's died where nobody knew why? Especially if they died young. Because if they say, yeah, it's so weird, my cousin's cousin did that, and my dad's brother died when he was 25, and we never knew why, it tells you that this may be Brugada. It's an autosomal dominant trait thing. The treatment, by the way, is a defibrillator. They get an implantable defibrillator. And your job is to look for this EKG. Eyes are going to go right to V1, and you're going to look for this right bundle branch blockish looking thing in V1, and don't memorize this. There are several different types of Brugada. This is where the internet is fabulous. I usually pull it up either on my phone or on the screen. I take the EKG, I hold it up and say, does it match any of those? If it does, cool, then I call the cardiologist. If not, then it doesn't mean Brugada's not there, by the way. It can be transient, but this is, if you see this, even in somebody who's asymptomatic, you're going to at least talk to a cardiologist and say, wow, this is kind of cool. And if you see this and the person's it's an ankle sprain today and somehow they got an EKG, go back and ask them, have you ever fainted for no apparent reason? It's like, yeah, it's just weird. I did the other day, or I did a couple months ago, and it's like, boom, you just got somebody who needs to have implantable pacemaker right now. This stuff is fun. This stuff is interesting. It's not that hard. And I tell you, one of the things to get good at EKGs, if they intimidate you, is just practice them. Once a week, pull out 5 or 6 from some website and just look at them. Every day, look at the EKGs that are sitting around on the counter in your hospital. Take them to somebody and say, wow, could this be this? What do you think of this? It's a way to keep up on these, because EKGs, you need to stay sharp, and it's one way to do it. So it is break time. We're going to take 15 minutes. So let's come back at right before 11, or right before 10:30, and take a break. Thanks.
This is one of my favorite topics, so it's going to be hard for me to save any time doing this. This is such a great topic because it's so physiologic. It's so easy to work through the pathophysiology of this problem. So this is, the normal heart on the left and the bigger heart on the right. Look how thin the right ventricular wall is. The septum is thin. The ability of this heart looks like more of a bag kind of thing. The ability of this heart to squeeze is not there. And when I was a younger doctor, congestive heart failure was congestive heart failure. We didn't make a distinction between systolic and diastolic. And it was about ejection fractions, and the ejection fractions were low. And that was what it was. But now we know a lot more about it, a lot more. This is Medicare's most costly diagnosis by far. That's why they have all of these programs about trying to decrease the number of readmissions, because frankly, this is a terminal disease, and most people don't kind of talk about it in those terms, but this is a terminal disease. This is not going to get better on its own, and I don't know whether you see any TV commercials for Entresto. They talk about Entresto, which is basically valsartan, which has been around for 100 years, and an ACE inhibitor combined together as prolonging your life, not getting you better, but buying you time. And that's the way they talk about many of these cancer drugs. And in some cases, that you will live longer if you have certain cancers than if you have this disorder. So that's a different perspective on this, that it's not a good diagnosis to have. And they have all of these programs in hospitals trying to prevent these readmissions by, they have these nurses who call you, check your weight, those kinds of things, so that this pathology doesn't creep up on you and result in another Medicare admission. So there's a lot of incentives for hospitals not to readmit patients who have this disorder. So there's basically systolic means it's weak. The contractions are weak. And that's really easily understood as why that would cause heart failure. And there's diastolic dysfunction. Now this is kind of an interesting one. In this case, your ejection fraction may be perfectly normal, but the amount of blood that you're pumping out per stroke is small because you've got a muscle-bound left ventricle that is thick-walled from hypertension usually over time, so your heart has been under this extra effort pushing out blood against your constricted vascular system. So bottom line here is that you're not pumping out very much blood. You're pumping it out, but there's not much blood going out. So the net effect is cardiac output is still going to be low, no matter what is the process. So this is a kind of a little graphical presentation. So the heart that is basically having diastolic trouble, it's not necessarily going to be particularly large when you take an X-ray of it. This is not the floppy, baggy heart that is due to myocardial infarction or thereabouts, where a good section of your cardiac wall dies, turns into fibrous tissue, no more muscle there, kind of thing. Left-sided failure is now that I have no idea why they chose to put these initials on it, but when you read about it now, they have this initials where they call about HF and R, reduced ejection fraction. Heart failure with reduced ejection fraction. Is that a pronounceable word? Anybody know how to pronounce that? If you can't pronounce it, why have it? We understand that there's two kinds. And the other one behind it, there is heart failure with preserved ejection fraction. Have we made any progress in medicine by knowing this stuff? And so don't be intimidated by it. There's diastolic and systolic dysfunction. That's kind of it. Basically, in both of these weak hearts, one's not weak, but the fact is they don't get the job done. Both of them don't get the job done. So the blood starts backing up into the lungs. Lungs start becoming heavier because they're full of blood as this pressure in the lungs and the pulmonary vasculature increases. There's this transudation of fluid into the alveoli. These lungs are heavy now, boggy. It's hard to get the ventilated, excess muscle activity to try to open them and close them because they're so heavy. So you see them huffing and puffing. You see the intercostal retraction when that's going on. There's other compensatory mechanisms trying to help out here, and it results in the clinical picture that we'll show you in a second. But this is a vicious cycle, spiraling downward. And so when you see a patient who's in congestive heart failure, actually you're seeing them in pulmonary edema or thereabouts, or their transition to it. Basically, the right heart has failed, resulting in blood backing up into the lungs. The blood backing up into the lungs basically inhibits the emptying of the right ventricle. The right ventricle backs up blood into the neck veins, into the liver, peripherally. Those are the signs of right heart failure. And so basically, you've seen this patient a million times at least in the emergency department setting. And this is basically total failure, failure of the right and failure of the left. They say the most common cause of right heart failure is left heart failure, and you can understand how that could occur. So these are the causes that you have to think of, because what precipitated this event? Was there a precipitant, or was this a gradual, progressive kind of thing where the people were gaining weight over time? More and more weight was being gained as they were retaining more and more fluid because they couldn't get it out of them. So is there an infection, particularly an infection in the lung? And oftentimes pneumonia is going to be maybe there, or maybe they also have COPD, which might be gotten worse, and that makes the failure worse. Sure, myocardial infarction, we can understand that. This takes out a part of the wall of the heart, and hopefully you're going to have a small inferior myocardial infarction. Some people are offended when we use the word inferior myocardial infarction, like it's a characterization of you or something. You've had an inferior infarction. Arrhythmias and uncontrolled hypertension. Arrhythmias, the heart only does two things. It pumps, and there's a rhythm to that pumping. It pumps, and there's a rhythm to that pumping. That's it, two things. True remarkable things, giving all the pumps that go on in a lifetime, but that's it. So, it's kind of got the word NSAID beside the word uncontrolled hypertension. NSAIDs cause your blood pressure to go up, and so it's not a great thing to be retaining salt through this NSAID mechanism or some others. So, and as people get older, they have more and more musculoskeletal kinds of problems, and it's a temptation for them to take NSAIDs because, frankly, NSAIDs work better than acetaminophen in many, many things. I think clearly there's a difference. So bottom line is you've got this NSAID problem, and on top of the NSAID problem, in terms of raising your blood pressure, retaining fluid, you got the issue of NSAIDs causing myocardial infarction. Remember when there was Vioxx and they took that off the market? Vioxx was believed to be responsible for 60,000 deaths. This was a great example of post-marketing surveillance. Before Vioxx was licensed, it looked like it was going to be a good NSAID for sure. And then over time, it was just kind of like randomly, hey, I think my patients are having more when they're on this medicine for their arthritis kind of thing. And sure enough, they start putting all these little points together, and they came up with this association between Vioxx and heart attacks. But that's not unique in that this is a class effect. Every NSAID increases your risk of myocardial infarction. Did it increase it as much as Vioxx did? No. but this is a class effect. So every NSAID will also be not a great thing for a patient who has congestive heart failure to be taking, especially on a routine basis. You know, maybe once in a while, sure, okay. Anemia is one of these, we call it high output failure. If your heart cannot pump out enough nice normal blood, hemoglobin 14, the hemoglobin is now 8, well, it has to pump out a lot more blood to oxygenate tissue. And to pump out a lot more blood to oxygenate tissue, it has to pump harder and faster, harder and faster. But this heart can't pump harder and faster. So that, you know, this is called high output failure. And so you could see how hyperthyroidism would be a cause here, because this is releasing drugs that cause you to pump harder, faster, but the fact is you can't do it. Medications, there's this list, this class effect. If you give somebody a leave, tell them to take a leave, you're not doing them any favor. But it's a really delicate balance, because if you say take acetaminophen, and some other drugs, calcium channel blockers are not particularly helpful. Certain diabetic drugs are not particularly helpful. This picture is, I think, is it blown up in your book, that it's full page in your book, this picture? This is a terrific picture because it basically goes through all of the pathology that occurs and the response to it. So one of the response, why do people come in who are in pulmonary edema? Why are they sweaty and pale? They're sweaty and pale because they have a lot of adrenaline that's been released. That adrenaline is the body's attempt to make the heartbeat harder and faster, because that's the only things it can do really to overcome this problem, is harder, faster. But the problem with harder and faster due to adrenaline is it also is a peripheral vasoconstrictor, which is the last thing that you want to do in somebody who has heart failure, is constrict their peripheral vessels and have this heart pumping against this resistance of the vessels. So that becomes a problem. But we also know that when it clamps down on the vessels in the skin, you become pale. When you clamp down on the vessels in the skin, you cannot radiate heat. So there's only other way to radiate heat in this case is to sweat. So these people are sweating and they're pale as a result of adrenaline. That's the manifestation of adrenaline. Think of a person who comes in with a blood sugar of 30. They're wet and pale. Why are they wet and pale? Because adrenaline is being released to try to get their liver to release some sugar into it from glycogen as a store to response. But the response is always the same. It always does the same thing. When adrenaline is out there, these people are likely to have an increased heart rate, pale, clammy kind of thing, whether it be low glucose or be as a response to congestive heart failure. So the body's attempt to resolve this problem is not particularly physiologic. In some ways it is, but it's only a Band-Aid, because one of the problems is it's causing peripheral vasoconstriction as well, and that is not what we want. So most of the cases of congestive heart failure that present to the emergency department are obvious. First of all, most of them are going to have a prior history of congestive heart failure. You're going to see peripheral edema as a manifestation of right-sided. You might hear rails in the lungs. What are rails in the lungs? That's that fluid that has been transuded through the capillary, the alveolus. Fluid is supposed to stay in here. Oxygen is supposed to be exchanged. When you get fluid in the interstitial space, it is harder for the oxygen to go through from the capillary from the alveolus into the capillary, because now you've got a lot of fluid in here. Before it used to be like this, now it's like that. So you've got all of these physiologic things working against you, and it's getting worse by the minute. So you got to get on top of these people. And fortunately, we can fix these people quickly as long as they have a high blood pressure. You have to have a high blood pressure. If you have a low blood pressure and pulmonary edema, that's called cardiogenic shock, the mortality of which is, very, very high. Because basically this heart has just got not enough. If you got a nice high blood pressure, that means there's a fair amount of strength left in this heart, you can fix this within an hour. They're going to be breathing so much better when you fix this. BNP is secreted by primarily the right ventricle. It is secreted in the presence of increased pressure in the ventricle wall. And that's certainly going to be there when you have too much blood that you're trying to handle. So so we measure BNP to help us know whether this is congestive failure or not. But it should not be ordered routinely, because the vast majority of cases when it's ordered routinely, you don't need it. This is a clear case of pulmonary edema in a patient who's had this diagnosis before. We don't need it. So, I don't like to see all of these order sets that have this this test in there. What is it going to cost, kind of thing. It should be ordered when you really aren't sure. And when you are often unsure, this number is unsure. It's in the middle. It's not on either side. So that's one of the problems. When you have a problem, this number is also in the mid-range too. Obviously, the heart, when it's compromised, needs every part of it working as best it can. If you have atrial fibrillation, boy, you have a chaotic rhythm here. Atria are not contracting when your ventricles need it to contract. You don't get the atrial kick that you need. There's some reason that the atrium is supposed to contract. Yes, it's part of this whole coordinated, beautiful picture about how the heart works. So a dysrhythmia may precipitate atrial fibrillation. Now, most people who get atrial fibrillation don't have hearts that are fundamentally weak, and so atrial fibrillation is not usually a cause of heart failure. However, if you have a history of heart failure and go into fibrillation, you can become much worse very quickly. Because, you've got this tachycardia, you've got this incoordinated beating of the chambers. Not a good idea. This is interesting because this is a bad x-ray on the left, and it's the same person with a better x-ray a month later. But the better x-ray doesn't look fabulous. But it's interesting. If you take this person and fix them with the magic drug, IV nitrates, they'll be breathing better in an hour. If you take an x-ray in an hour, it's going to look like this. There's a big lag between what the x-ray looks like and their clinical picture. Big lag. So there's no point in doing that. In fact, this shows that even at a month later, it's still not normal. But you would think that if I can get you better so that you're breathing better in an hour, then I should see less evidence of fluid in the lungs, et cetera, et cetera, et cetera. That's not the case. Just experiment, if you want to take an x-ray on somebody 2 hours into a pulmonary edema case. This is fascinating. This basically says ultrasound is better than chest x-ray in making the diagnosis of congestive heart failure, pulmonary edema. Not marginally, it is grossly better. This is a study that basically concluded that the sensitivity for point-of-care ultrasound looking for these B lines was 96% sensitivity. That means it missed 5% of the cases. Specificity was good, 90%. So 90% means that was the diagnosis. When it said it was pulmonary edema, it was pulmonary edema. Look what chest x-ray was. Chest x-ray was 65% when read by a radiologist, not by you. Terrible. And yet that had been one of our things that we leaned on in the past to determine if somebody was in failure, is what the chest x-ray looked like. Now, those of you, this is kind of like, if you could have a test that you could do relatively easily, and my understanding is doing this is not a hard thing to learn at all, in finding these B lines, and you have a test that is 96% sensitive. When you had a prior test, which was the gold standard, it was 65%, that's out. So point-of-care ultrasound, this is a great example of the value of point-of-care ultrasound in the lungs. And the other things like pneumothorax and in terms of picking this stuff up. This is an important paper, I think, for sure. So what kind of stuff are you going to be ordering? You're going to order the comprehensive metabolic panel. You'd like to know what the potassium is. Potassium is always going to be low, usually unless there's some renal insufficiency, because they're always on thiazide diuretics. And they're trying to get all of the excess fluid out of you. We can, so that we don't have to compromise the vascular system, asking it to push around all this fluid. So we're going to get it out of you. However, in the process, you're going to deplete potassium. And whenever you deplete potassium, brother and sister go together. Magnesium is going as well. Magnesium and potassium are both needed for muscle contraction. So the idea, and you may be also getting rid of thiamine. Thiamine is needed to make your heart contract as well. So thiamine is, remember Bury, that was thiamine. So you're losing thiamine, magnesium, potassium, all of those things which you need back. So you may have to start repleting these electrolytes. Don't measure magnesium, just assume it's low. It is always low. And it's also a hard test to measure, really, because when you measure the serum magnesium, you're really measuring the part in the vascular, in the liquid part of blood, but the vast majority of magnesium is in the red cell. So there's not necessarily a one-to-one relationship. It's the same thing with potassium. The potassium that you measure in the blood, intracellular potassium is 30 times higher than in the intravascular part. So they're not the same. Obviously, you'd like to know whether there's an infection, so we'll get a CBC. We'll want to know whether there's any renal insufficiency. We'll check that out as well. We're going to monitor them for sure. We're going to give them some supplemental. All these patients are drowning, basically. And so are they going to need some supplemental oxygen? Probably, you bet. So if the oxygen low is going to give it, we're not going to be too scientific about the, they say this causes vasoconstriction, oxygen. Oxygen is a drug. And in fact, you cannot, some of these places, these hotels used to have oxygen distributed for hangovers. I don't know if you would see them bubbling oxygen to these things. They're not allowed to do that. We want to reduce the afterload. Afterload is on the aorta side, and preload is on the vena cava side. So we want to dilate both of those. By far, we want to do the arterial side the most. And so we're going to give big dose nitroglycerin. We're not going to putz around with the small doses. We're talking 200 micrograms here per minute. And the nice thing is it's titratable. Give more, it's overshoot, and it's also gone quickly. So if I overshot a little bit, well, then I can back off a little bit, and I can titrate just so that there's a reasonable blood pressure. And you've gotten that high blood pressure, the 180 over 110 down to something like maybe 130 or something like that. So IV nitrates, IV nitrates, IV nitrates. Now the other thing that people give generally in these cases are the other fluid overload. So they're going to get a good slug of Lasix. You should not give Lasix first and then the nitrates. Lasix has been shown to cause initially some peripheral constriction. That's the last thing we want to do in somebody who's got pulmonary edema. So the nuanced way to do this, nitrates first, then the Lasix. On assuming that we're a traditional case of pulmonary edema here. BiPAP, CPAP, you bet. It'll help retain the fluid out of the alveoli to a certain extent and facilitate the breathing of these people. When they talk about the pressures that are used in BiPAP, like 10 centimeters and 5 centimeters, and you think that is nothing. That is nothing. People who have sleep apnea, 10 centimeters, 5 centimeters every night. So 15 centimeters, okay, go for it. So it's all about venodilatation. Both sides get done by nitrates, IV diuretics. And not all patients obviously are fluid overloaded. What about the person who has flash pulmonary edema? Flash pulmonary edema is all of a sudden you get a brain hemorrhage, and there's some primitive reflexes that go down around there that basically say brain hemorrhage, sympathetic outflow, vasoconstriction, leakage, immediate. That happens with intracranial hemorrhages because it's really a catastrophe that is being manifested by the heart as well. Or myocardial infarction. All of a sudden, your heart becomes compromised. There's not been chronic overload of fluid. So you look, and the heart may be pretty much normal size. There is some fluid there, but you're not vascular overloaded. And so that case doesn't need Lasix. They just generally need, hoping with their blood pressure is decent, that you can give them, titrate down carefully with IV nitro. ACE inhibitors are good to use too. If you're at a place and you can't get the IV in, then this person's like drowning kind of thing, here, pop them a sublingual captopril, 25 milligram capsule, open that capsule up, put it underneath the tongue. Here's the 5 nice things that it does for you. And it's been shown actually that this works. If you can't get an IO line or something like that, and the person's decompensating, this is something to do that would give you a little time. Myocarditis is basically in the United States, it's usually a viral infection of the heart. You have a flu-like syndrome, achiness, fever, the joints ache, those kinds of things. And what this person has is a disproportionate tachycardia. They may have a fever, maybe 100 or 101, something like that, and they get 130 pulse. That 130 pulse is not consistent with 101 fever. And this is particularly important in kids, because missing myocarditis in kids is, all myocarditis is associated with sudden death. So these kids come to the emergency department. They were coughing, hacking, breathing, some breathing difficulty. And this kid's got a disproportionately elevated pulse. It may not have much in the way of fever at all, maybe afebrile, and running a 110 pulse, 115 pulse. You have to think in these cases myocarditis. You can take a listen to the chest, you may hear some rails. So this kid's coming in short of breath. Why? Hear some rails. Pulse 110, 115, 120. This is most likely myocarditis. And this is a diagnosis that is often missed in children because people don't think about it. Disproportionate tachycardia, shortness of breath, listen to the chest, hear a few rails. There's some drugs that can cause this as well, myocarditis, alcoholic myocardiopathy and myocarditis. Renal cases can have myocarditis as a result. There's a whole list of things that can cause it, but in our setting, myocarditis is viral. It's not the most common case in all the world is whatever it is. Flu-like, out of proportion. You do the histology, and there you see all of these white cells throughout the muscle. And one of the things that now you got a sick muscle, you got a sick heart. It's infected, it's inflamed with this virus. And so you're leaking troponin, because these sick cells leak troponin. So here's the case where you got troponin not caused by a problem in arterial delivery through the coronary artery system. Here's the case of troponin elevation because your cells are sick and they're just leaking. The manifestations of congestive heart failure, yeah, that's a part of this thing. And sudden death for sure. I had a friend, an ER doc, who was a real jock, and I would see him at our conferences, and it was the diet, the jock, everything. And he always made me feel bad because every time I saw him at a conference, he was so damn healthy. And my friend got myocarditis, and my friend wound up getting a pacemaker, defibrillator kind of thing in. And he went out for a jog one day, and he dropped dead. And that defibrillator didn't work. And he dropped dead. And there were 1,000 people at his funeral because he was the director of the local ER. It was the only game in town kind of thing. Everybody knew him. Everybody loved him. He was young. It was probably in his late 40s. It was really sad. Sudden death. Myocarditis, basically every element of the EKG is abnormal because the entire heart is infected by this virus. So it's not limited to the coronary artery distribution, anterior, inferior, lateral, that kind of stuff. No, whole heart. So there's going to be a tachycardia, and every lead is going to be abnormal. No focal issues. So you can see there's a tachycardia there, and every lead is abnormal. So this is consistent with myocarditis. Pericarditis, it's hard to consider that the heart is infected, but not the wrapping of the heart. So that becomes infected too. So once that's infected, you got the transudation of fluid between the heart and the pericardium, so that you have the potential. This diagnosis is made by ultrasound. Pericardial effusion, ultrasound, easy diagnosis. A lot of causes, but the fact of the matter is you don't really need to know the causes. You need to know the manifestations in the emergency department. So this is the same kind of thing. All the leads in the EKG are going to be screwed up because this bag is inflamed, and because one is associated with the other. Now, one of the nice things is the pain from pericarditis is so characteristic. It's worse by moving, turning, taking deep breaths. It's worse by laying down, just leaning forward. That's when you lean forward and you can hear the friction rub. If you've ever heard a friction rub, you'll never, ever, never, ever forget it. So we're not going to mistake pericarditis for myocardial infarction or PE. No way. Tachycardia, every lead is abnormal. Anti-inflammatories, this is not what you're going to give. You're going to make that diagnosis. You're going to be a hero by making that diagnosis. Somebody else is going to take over doing this. Pericardial tamponade all that is that this fluid collection has gotten so severe that it's squeezing the poor heart. Can't fill. So you get the neck veins distended, can't fill. And the heart sounds are muffled. Ultrasound makes a diagnosis, and this is called a water bottle heart. I don't know what a water bottle is, but that's called a water bottle heart. It's like a big bag. Electrical alternans. If you see it, it's kind of a rare manifestation. Doing a ultrasound makes a diagnosis. So, fun diagnosis. Serious problem, however, terminal disease, actually. So we're going to stop here, and Mike is going to come. This is the first one I've done on time. I didn't go over but 1 minute.
It's not a lot to talk about in 30 minutes. So let's talk a little bit about elbow and forearm complaints. So there's the forearm, there's the elbow. Any questions? So not a very sexy topic in my opinion. There's a couple of cool names here, but this is something we run into and just really thinking about the importance of our orthopedic evaluations. And you're going to hear some of this over and over again as we talk about the assessment of these orthopedic problems. Just kind of a quick review again of anatomy. We talk about especially the elbow. My ulnar collateral ligament is really important for stability of that joint. So if I have an injury there, if I'm worried about an injury to that ligament itself, that's usually going to cause some instability. And they're not going to have a good movement and function and may have a lot of laxity there. And definitely those patients that I have that concern or know they have an injury, orthopedic follow-up and evaluation is really important. My distal forearm, same thing here. And one thing we'll talk about later, especially with the lower leg and the lower arm, is anytime I have this paired bone phenomena, I have this interosseous membrane that runs between those two bones. And anytime I have that paired bone phenomena, always make sure you look at both bones very well. There's a significant risk if one is injured, both of them are going to be injured. Definitely always thinking about if I've got that distal injury, make sure I look at the proximal area really well as well, because sometimes that injury will get transferred up, and that one injury may be at one end and the other injury at the other end. So we talk about the forearm itself. They break these into distant fascial compartments. My anterior compartment is really important there for my flexion. And I've got both a superficial, a medial, and a deep layer. And remember what goes in what layer. I looked that stuff up as well. But then my posterior is going to play a role with my extension as well. There's a lot of muscles involved there. And we know the radius plays a role with my extension. and my ulnar there with, my ulnar with my extension and my radius with my flexion. But really good evaluation of those nerves. How is it upper? How is it lower? Do I see a deficit on one side that I may not see on the other side? And there's also, how is my sensation? Do they have that good discrimination? Sometimes even that 2-point discrimination there if I'm really worried about some type of nerve injury from either just injury itself or sometimes even that concern for compartment syndrome. So things we're going to talk about over and over again with orthopedic stuff. Always, again, looking at the joint above and the joint below, because typically if I've got injury at one area, it has that risk of being energy transferred up to another area. Always making sure I have good documentation of my CMS, my circulation, movement, and sensation, or old school we call it PMS, pulse, motor, sensory function. But especially when that patient arrives in my ED, I want to assess that. Before I do any manipulation, I want to assess that. After any manipulation, I want to assess that. And at discharge, ideally, I want to assess that again. And I had those documented. Hey, pulses were great, cap refill was less than 2, sensation was equal, especially before and after manipulation. Because if I don't get a good assessment, then I reduce that injury, and then, oh, that finger feels a little cool. That cap refill's a little delayed. Was that there before or after? So just get a good idea of those, especially if we are doing some immobilization and you're not the one doing it, your nursing staff's doing it, go back and look at that. And one thing that's really important with all these orthopedic things is if that splint's been put on, was it put on properly? Because some people miss that step of that full anatomical position. And if it's not in that proper anatomical position, that splint may not be accomplishing the goal we're looking for. If I'm worried about significant neurovascular compromise, get ortho involved earlier. Definitely, I don't want to wait 3 hours to get them to somewhere that has ortho if I've got a dislocation that's altering perfusion. I need to reduce that sooner versus later. So who needs that elbow x-ray? They come in, they've got that pain. How's their range of motion? And if they can lock that in full extension without a lot of severe pain, they likely don't need an x-ray. Do they have point tenderness? Is it truly right there over the olecranon, or is it somewhere else there in that area? But typically, if they don't have point tenderness right over the olecranon, and they can lock that in full extension without any significant pain or problem, those people probably don't need an imaging. Just immobilize them with a sling, give them some rest and support, and then have them follow back up. But if you're concerned, definitely go ahead and get that imaging. So fat pads. We typically talk about fat pads a lot with pediatrics, but sometimes also for adults. So an anterior fat pad can be normal if it's small, but as a general rule, posterior fat pads are always abnormal. Because sometimes we may have those little small occult fractures that are really hard to see. I mean, I can remember years ago when we had the little hot light and we're looking at films like this, and now that they're all digital, it makes it really easy. I can blow them up and change the contrast and things. But sometimes those occult fractures are difficult. So look for those fat pads. And if I've got that really obvious fat pad sign, that makes me really concerned about some type of interarticular fracture or something ongoing there that's caused some bleeding in that area. If in doubt, you don't see a fracture but you're concerned, it's never wrong to simply just immobilize someone, have them follow back up, because we can re-image that in a week and we may see changes. If they've got good distal function, I'm just really concerned, even just putting them in a sling is enough. That gives them support, gives them a little bit of protection, but immobilizing someone for a couple of days in a splint, totally fine. So as you can see here, this anterior fat pad, that looks nice and normal, but on that other image there on your right, I've got that classic sail sign. It looks like I've got the sail coming off the sailboat out there because it's inflamed, it's got some blood there. And again, posterior, always abnormal. Be that suspicious about it. If I see it, look further. Sometimes we have to get advanced imaging. Occasionally, ortho's going to go ahead and get a CT of that, and let's just truly see what's going on there. But most of these are pretty obvious if I see a fat pad there on my plain films. So radial head fractures are definitely very common things we'll see with our kids, but also for adults. The most classic here is going to be your Fuchs injury, that fall and outstretched hand. And sometimes these can be very subtle fractures, and this is when the fat pads really come into play here. They use the Mason system for classification. Who cares? But if I've got a non-displaced fracture, that usually doesn't require any intervention more than just immobilization. But if this is displaced, and especially if they have a significant amount of displacement, those usually do require operative intervention. So go ahead and get ortho involved sooner. Nowadays, usually they can pull them up on their phone and look at them easily on their electronic system and go, hey, that's fine, just immobilize it, I'll see them tomorrow. But definitely I want to make that connection now so that patient has that resource. Not displaced, usually not a problem. Most of these people, greater than what we call a 3 or 4 or 5, those require operative intervention. but probably going to mobilize them at least for a week. But then also think about rehab. When can they start using again? If there's no displacement, they don't have to leave that sling on all the time. Just keep it restful, do a little bit of range of motion, but give it a rest for a couple of days. So we can see here, very subtle fracture there, but that fat pad is what really points me in. Because look at that, that's kind of maybe. And this is sometimes also when comparison views may come into play, especially with pediatrics. We'll talk about growth plates in a few moments, but used to do a lot of comparison views, especially before we had 24/7 radiology overread. And like, hey, let's go ahead and x-ray the other arm and just see if it looks the same. Because unfortunately, everyone has some normal variants out there. Not all of them are things we can find easily in a textbook. Does it look the same as the other side? It may be a normal variant for that patient. But if it's tender, if it affects range of motion, you're not wrong to do a brief immobilization with follow-up care. So subacondral fractures definitely are our most common elbow fracture there in our pediatrics. This is also typically your Fuchs type injury. We see this a lot with playground equipment. The monkey bars, they're doing their things, they fall, and they catch themselves. And one thing that can really help me here is this anterior humeral line test. And we'll look at that in just a moment. That can really go, hey, is this in the right normal alignment, or do I see some displacement there? Again, if these are non-displaced, usually it's immobilization, nothing else. But if there is some displacement there, I want to get ortho involved, and this may require operative intervention. So here's my anterior humeral line test. I just kind of look, and if I put a line right down through the humerus, it should go through the middle third of the capitellum. A little bit on each side, perfectly, that's the normal placement it should be. As you can see here in this radiograph, I've got my nice clear line right through that middle third. That looks great alignment. But if I've got some displacement here, that one's pretty obvious. I can go, yep, that's broke. But do my humeral line test and go, ooh, that line is not going through any part of that capitellum. And of course, there's my nice telltale cell sign on the backside that I have that posterior fat pad as well. This will likely need operative intervention. I'm going to get with ortho. What do they want to do? Sometimes it's just a posterior splint. Sometimes like, no, go ahead and I'll come in and see them. And we may take them to the OR today. But what's my distal circulation? So kind of a little table here to kind of help some of those common adult and pediatric things. Where is their tenderness at? Is it point tenderness, or is it kind of just generalized, like the whole area just hurts? How is their range of motion? If it really affects the range of motion, I'm more concerned about something else versus some non-fracture that's present. Look at those fat pads. Again, always think about your distal circulation. How's their grip? How's their sensation? How's their capillary refill? If I've got some crepitus over that area, that's more concerned that I might actually have something there. And usually you can just kind of feel that little change in sensation when you're pushing on those bones. Epicondylar fractures, also common that we see in our pediatric patients here. Avulsions are very common here that we'll sometimes see. They just tear off part of that bone. And as you can see here, sometimes those are pretty obvious. Sometimes those can be a little bit more subtle, and sometimes can be kind of difficult to differentiate. Ooh, is that part of the growth plate, or is that something different? They don't always have those fat pad signs, so that can make it really challenging here to do that. And this is when those comparison views definitely may come into play. If I'm concerned, I'm going to get ortho to look at them sooner versus later. Go in and mobilize them if we need to. So crito is our mnemonic for when those growth plates close, and we'll come back to this with several other joints as well and talk about those. But typically your growth plates are going to look very smooth. They're not going to look jagged. They're not going to have a significant amount of irritation look to them. Comparison views, again, may come into play, but what's your physical exam findings? Is there a limited range of motion? Is there point tenderness? Then I'm more likely to be concerned this might actually be something versus just simply like contusion. Elbow dislocations, again, common with our Fuchs injuries. It's almost always posterior. P's is your mnemonic. Posterior for elbows, anterior for shoulders. We talked about shoulders earlier. This is almost that posterior dislocation from usually that Fuchs. These do have a high incidence of having some concern for neurovascular compromise. Anytime we have a dislocation, I have to worry about that. These are usually fairly easy to reduce. I get there, got that obvious dislocation. They have lack of range of motion. Distal perfusion is intact. Let's go ahead and just reduce this. Maybe a little procedural sedation. Sometimes just giving a little bit of traction, counter traction works well. Have the patient seated down, getting somebody to help hold some traction up here on the shoulder, and just grab their wrist and kind of pull down and push, and it usually goes into place pretty easily, and you'll get that classic thunk that's like you do with the nursemaids. Anteriors can be a little bit more difficult, but about 80% of these are usually posterior. Probably don't get an x-ray initially, but I may get one post-reduction just to show that, hey, there is no fracture here. We've got good realignment. For most of these people, brief period of mobilization with a sling is probably all they need, and just have them follow back up. And this easily could be primary care even, just to make sure they have still good function. One of our non-traumatic things we usually run into, olecranon bursitis. This is usually just some type of irritation. See this a lot with people that do a lot of studying down on their elbows, sometimes workers that do a lot of crawling around on their knees and elbows. This could be sometimes associated with things like rheumatoid arthritis or even lupus, but occasionally these could be traumatic or even infectious as well. So how does it look? Is it just swollen and tender, or is it kind of red, angry, swollen and tender? And that kind of may help me differentiate that. If I'm really worried about maybe a foreign body, like, hey, they were doing some work on their elbows and they felt something, that definitely the patient I may want to image just to see if there's a foreign body there. Ultrasound can be really helpful here as well. Occasionally, these chronic bursitis patients, or they've had a lot of problems with it, you may occasionally see a little calcium fleck there just from inflammation. It's not an avulsion fracture, just a little fleck of irritation there. It's caused some calcium deposits. But if I'm worried about infection, if it's red, it's angry, go ahead and do a tap and get some fluid out of it. Typically, if it's just inflamed and just irritated, your white count's going to be well less than 100. But if I'm really worried about septic bursitis, that white count's going to be significantly elevated. Usually that fluid is pretty purulent. It's going to have that cloudy appearance to it. We're going to get our gram staining culture, but usually it's almost always staph. For years, we could just probably treat it with simple things like dicloxacillin or maybe even cephalexin. But nowadays, MRSA is so common, probably most people are going to go ahead and treat them with clindamycin or TPMSX just to cover that typical MRSA. If it is infectious, definitely that's really important for follow-up, and sometimes we may even bring those people in for some parenteral antibiotics for a day or two. But if I'm not worried about infection, just simply irritation, then an intralesional injection may be very helpful here. Using some long-acting corticosteroid like triamcinolone is really helpful. Probably putting a little anesthetic in there is really helpful. Go in there, give it plenty of fluid, about 2 or 3 mLs of that solution. Put a bulky dressing on it and hold pressure. That's going to kind of keep that solution there where we put it, and then put that dressing around it. And this usually provides some help. And these can sometimes take a while to recover, these irritations. So we try to do the short term of the injections. Unfortunately, long-term use of those, especially long-term use of the corticosteroids, can cause some changes there in the bone structure. So we try not to do repeated of those, but definitely this person's having continued things, that's definitely going to be an orthopedic referral. May need to go in there, and sometimes they'll even remove that bursal sac to reduce that continued inflammation. But if I'm worried about infection, get your culture and treat those. So again, just some images here. I see that nice, pretty, red, inflamed looking section versus, hey, it just looks swollen, it looks tender. And there's that little calcium fleck that you'll sometimes see off the olecranon with inflammation, or especially chronic bursitis if they've had those problems. So our radial head subluxation, our typical nursemaids. Typically this patient comes in, mom or dad, they're neglecting that arm. They usually don't complain of pain, it's just they're not using it. They're holding it up close to them, they don't want anybody to touch it, but it doesn't usually hurt a whole lot, they're not crying a lot. Typically, if it sounds like nursemaids, it probably is. Again, check good distal vascular infusion, looks great, let's just reduce it. Imaging probably isn't needed and not even warranted in these patients. Sometimes you can even teach the parents how to do this, because usually by age 2 or 3 this lessens, but if they've had it once, they might get it again. So just simply, I've caused a partial dislocation there of the radial head. It's kind of slipped out of that space. That annular ligament that usually holds it there is still pretty lax at that age group, but it's usually easy to put back in. And after about age 3, the diminished risk is there. So for years, we would do things like this classic supination and flexion. And probably most of us now are using more of this hyperpronation. That tends to work very well and probably also less painful. So I'm going to take and find the radial head with my thumb and then grab their wrist and hyperpronate it. And as I roll it over, you're usually going to feel that click. And almost immediately, this kid's going to start using his arm again. And within 5 minutes, they're back to being active and playful and normal. That's your classic nursemaids. If I don't get that click, if they don't start reusing it within a couple of minutes, then maybe this might be something else. Let's try it again. Maybe have somebody else try it again. I've had a couple who are easy to reduce, and some like, I just didn't really feel the click, and then somebody else got the click. But typically, you get the click or the clunk, and then they're using it within a couple minutes, they're fine, they can go home. No imaging needed, they don't need anything, maybe some ibuprofen just to make mom and dad feel better. But this is just a simple subluxation, a partial dislocation. So some of our kind of cool fractures that we talk about. So the Monteggi fracture and the Galeazzi fracture. These are going to involve usually significant blunt force trauma, and the big thing we have to worry about here is they have both a fracture and a dislocation. And these do have a higher risk of causing vascular injury and sometimes can even lead to compartment syndrome. These always require operative intervention. So with my Monteggi fracture, I've got my fracture there, the ulnar, with a dislocation of the radial head. And then my Galeazzi at the end is going to be both a fracture and a dislocation as well. These probably are going to require some reduction there in the ED. Brief immobilization to ortho can come in and decide when they're going to do this repair. But definitely get a good assessment of their neurovascular function, immobilize them, reassess that, but these are all going to require operative intervention, and get a good keep assessment if they're there in your ED for a while of their sensation, their movement, and their perfusion, because these can lead to that compartment syndrome. And our distal forearm, definitely the Colles fractures are common we see. Again, that typical Fuchs injury, because we all want to protect our face. Your textbook Colles has to involve a fracture of both the radius and the ulnar styloid. So if I see one, go ahead and look for the other one. It is likely there to be a true Colles. Again, that paired bone phenomenon. So if I've got injury to one, I likely have injury to both. Good distal perfusion, usually it's there. These sometimes can actually get intra-articular and can cause more problems. So definitely follow-up's important. Usually mild displacement, immobilization, follow-up with ortho. But if they have significant displacement, these probably should be reduced there in the ED and then immobilized for orthopedic follow-up. Sometimes they'll go ahead and do it significantly that day, especially if it's a pretty significant displacement. So Colles and Smiths, Colles is that classic outstretched hand, where Smiths is just the opposite. They fall on that flexed hand. And some people fall backwards and catch themselves. But both are going to give us that radius and ulnar injury. So again, you see one, always look for the other and then document, hey, I don't see any injury to the ulna. The ulnar styloid looks intact or the radial head looks intact. Make sure you document the presence or absence of those combined injuries. So if minimal displacement is mentioned, just immobilize them, have them follow up. But definitely they have significant displacement. This is probably the patient I want to reduce sooner versus later. Don't want to wait for ortho to see them the next day in the clinic. Reduce them there in the ED. They usually do pretty well, and then I can immobilize those. Anytime we're immobilizing these patients, if you're doing it, your staff's doing it, definitely making sure we've got a good inspection of the skin first, because if they have some skin breakdown, that's going to increase the risk for complications. Do I have good padding there? Because whether we're using a fiberglass or some of us still use plaster, that can really irritate and cause some skin damage. So I want to make sure they've got good protection of that skin tissue. And again, make sure it's been immobilized in the right anatomical position. This is not anatomical position. There should be some flexion there with some bend in the fingers. That's where I need to keep those ligaments and tendons flexed. And occasionally with people that will just immobilize them the wrong way, we need to fix that, because I don't want to leave them in that wrong position for a day or two. Definitely in some of our kids, these can be Salter-Harris fractures, may involve that interarticular surface. So slip straight above through RAM, that's our mnemonic for these. But where is it? Does it involve that epiphysis? Does it actually involve the interarticular surfaces? Is that truly that rammed injury? And those bone ends are jammed together. So we can see here the Salter-Harris 2 are probably our most common, but that injury is right there above the epiphysis. Or in the middle, it's rammed. They've got that impacted fracture, which we see a lot with those Fuchs injuries. And these are definitely things we want to make sure they're following up with ortho, because if this doesn't heal properly, this definitely can impair bone growth and development in that patient. And then lastly, this is a short topic section, thank goodness, but this is our overuse syndromes. So epicondylitis we see a lot depending on people that do a lot of arm movement. So your lateral, your tennis elbow, that's going to involve your wrist extensors. So if they've got their elbow straight, when they try to extend out their wrist, that's going to cause that pain. And definitely may even have some tenderness right there over that area if you palpate. Medial, just the opposite. Initially, for most of these people, we want to limit their activity. Recommend rest, some of these immobilization devices. Try NSAIDs. Long-term injections may be complicated and may cause problems, so we usually try 2 or 3 weeks of conservative therapy, rest, one of these compression devices, and then follow up. And typically after 2 or 3 weeks, if they're not getting better, that's when they may try some injections. But most of us, we're going to leave that to ortho and let them make that decision, because we know these can have some long-term problems. And then de Quervain's tenosynovitis. Inflammation there, that tendon sheath, as that flows right through the wrist. We'll sometimes see this with overuse stuff. Also can sometimes see this in OB and in postpartum patients due to fluid retention. So occasionally you'll have that postpartum patient come in and they've got that pain there in their wrist, and especially when they do some deviation movements, that causes pain. Sometimes you can actually palpate right over it and you'll feel some crepitus, especially when you have them do some ulnar deviation. Immobilization, NSAIDs are usually our first line therapy here. Your thumb spica splint may come into play whether you're making one or have a prefabricated one, but we can do the Finkelstein test. And when we do the Finkelstein test, when you have them bring their wrist up, it feels fine, but as you have them do some ulnar deviation, they're going to have pain right through that area, and you often, as I mentioned, will probably feel some crepitus because that sheath is inflamed, it is irritated. But typically immobilization, rest, they do well with this. Most of these, we're going to delay that injection if they fail with other outpatient therapy. All right, thank y'all so much. This is my last lecture. If I don't see you at the Q&A, enjoy the rest of your conference. Thank y'all.
All right. Okay, let's talk about you. I want to stand here and give tribute to what you all have done over the last 18 months. I want you to give tribute to what you all have done over the last 18 months. If you are somebody fresh out of school and fresh out of training, realize that you as a practitioner have been forged in a dumpster fire that happens once every 100 years, hopefully. It won't happen again for another 100. I spent my first part of my career during the AIDS epidemic, and I started my residency training in San Francisco back when we didn't even call it AIDS yet. It was called HTLV-3. That pales in comparison to what you went through in the last 18 months. And it has taken healthcare workers to the brink, and I want you to acknowledge that and give it its due. Anybody in this room, the fact that you are in this room means you are smart, you went through a gajillion years of school, you are incredibly resilient to have done what you did already. So don't let anybody tell you you are not resilient. You are resilient, but you are being put into this insanity that we've all been living through for the last 18 months. So I want to talk about a woohoo topic. I want to talk about something that people find whifty and wafty and whatever, wacky, except that it is incredibly important and completely ignored. It is something that gets lip service up until now, and now it is real for everybody, for your colleagues, for everybody. I want you to walk out of this lecture with 3 things you're going to do. I want you to find one little tiny thing you can do to break a moment when you know things are going bad. I don't care what it is. I don't care if it's aromatherapy. I don't care if it's taking deep breaths. I want you to have one little thing for that. I want you to walk out of here with one thing you're going to do for yourself in a longer term, whatever that happens to be. I don't care if it's a gratitude diary. I don't care if it's taking a walk outside, but you're going to schedule that and make that part of your life. And I want you to walk out of here with a 3rd thing, which is one thing you're going to do that takes it outside of you back to the world. Now, besides your job, which you do every single day. I mean, I want you to empower yourself with anything from donating $5 a month to a cause you believe in to spending time outside of what you do every day, giving back to the world. Because it turns out that having a purpose is extraordinarily helpful to your mental health. So that's going to be your assignment. But let's kind of figure out how we get there and where we are now. So this idea of burnout, this is a cartoon from 2012, 9 years ago, 2012. The patient is saying, the doctor's saying to the patient, what seems to be the problem, Mrs. Johnson? And she says, I feel the way you look. This idea that physicians or healthcare practitioners would be burned out was something that people knew about, in fact, knew about well before 10 years ago, but it really started to hit the fan about 10 years ago. And it made the news. It was like on the national news, and it was in newspapers, and it was in our journals, and all this stuff. And it was like, oh, burnout, woo. Everybody paid big attention to this, theoretically. Except that it was turned on us. It was turned on you. You're burned out. It's your problem. You need to fix it. You need to develop resilience. You need to develop a wellness plan. A self-care, all that jazz. And so we knew this was a problem, and then we dropped on top of it a pandemic. And not just a pandemic where your life was put at risk just to go to work, but a pandemic that did something to the brains of thinking human beings and broke them. They're broken. It's like people can't seem to logic their way through anything anymore. So it is dumped on top of us this extraordinary stress as human beings trying to take care of other human beings. What it really did is put us in the stages of grief. Each of us has had to, everybody on the planet, not just us, but everybody has had to deal with stages of grief. This idea that, what, a killer virus? What the heck? Seriously? Well, it won't come here. It won't be here. That's the denial. And the anger is, well, I'm not going to wear a mask. I'm not going to get a vaccine. And then bargaining. Okay, fine. If I wait, if I do the right thing now, I lock down, they'll find a cure. They'll fix this thing. To finally depression. It's like, it's never going to go away. Here we're stuck with this thing. And then testing. Well, okay, maybe if I wear a mask, I can eat out. Maybe my life might go back to what is a new normal. We have been through this. Each and every one of us has lived through this. Our patients have, you have, we have, our families. Everybody has lived through this. And also during lockdown, an additional layer got thrown on top. And there's a term that kind of came out of lockdown time that I think is really helpful. And it's called languishing. It was that Blur's Day thing, right? It's like, I don't even know what day of the week it is. I can't even remember what month it is. Was there a holiday? Because I don't even remember. We didn't get together with anybody. This languishing idea where there seemed to be like nothing. It wasn't really depression. It was just like nothing. This got laid on top of a situation where we are already sort of stressed out in the jobs that we do. So let's kind of back up and see what we can do about that and why is this even happening? So Medscape does a fabulous survey every year, incredible, fabulous survey every year. And they ask physicians, but I think they should open this up to everybody, what is it about your job that fries you? Like, what is it about your job that fries you? We're going to come back to this list in a minute, because when people tell you it's your fault, I'm going to want you to pull this list out and say, oh, really? Let me show you why people are burned out. We'll come back to this. Because burnout is a real thing. It is 100% real. It is really, and please watch yourself and watch your colleagues. Because I don't know if any of you know a colleague who has really had trouble or worse. If you have, you know that sometimes there's a way you can actually pick up on this. So burnout starts with this idea of trauma. You've had some sort of trauma. They call it vicarious trauma. It's not directly to you, but it impacts you. Anything from what happens in your job to a case you see at work that reminds you of something. So one of my vicarious trauma moments is when my father died of lung cancer, and the first patient I saw back, my secondary traumatic stress, was a lung cancer patient that looked exactly like my father, was the exact same age as my father, and had the same complaints as my father had had. It was this moment of suddenly that became not just a patient I was taking care of, but something very real. Not that it wasn't real before, but it touches you in a different way. It touches you differently. And you end up with basically, you see too much of this over time. If you've had a new baby and now you take care of a SIDS patient, all of a sudden that is extraordinarily real. It gets into you. And it basically leads to a way to keep yourself safe is it leads to just kind of blocking it off, pushing it away, to compassion fatigue. And that's just the emotional part of it. That's not even the stress part of the junk we go through just to do our job every day. If you add on top of that a pandemic, where then they ask you, and I am willing to bet that some of you in this room have been through this situation, where they ask you to make decisions like, oh, let's see, who gets the vent, the heart attack patient or the COVID patient? And how do you integrate somebody who didn't get vaccinated where you know it might have helped, and does that even factor in, and should it, and maybe you want to and it can't, and so all of this gets added on top. Burnout is not surprising. It is absolutely not surprising, but it isn't absolutely necessary either. The thing to know is that one of the things to keep track of, and please watch your colleagues. Please watch your colleagues. There are people really struggling right now, really, really struggling right now. If you see people who are irritable when they are not usually irritable people, if you see people who are really just everything they do they feel like is wrong, if they're suspicious of everybody else, if any of these things, if they're super self-critical, please clue into this in people you care about that you work with. Anybody, but particularly people you work with. Because that is just a sign that they're starting to circle the drain. And all you have to do, honestly, all you have to do is say, are you okay? Are you okay? That's all you have to do. And you would be amazed what happens. You'd be amazed. Somebody might say, I am absolutely not okay. I am really, really not okay. Just kicking the door open gives them a chance to talk, because this is what we do not want to have happen. This is just physician data. It is, the nursing data is worse. Suicide in our colleagues is real. It is 100% real, and so we have to care about each other. And I'm willing to bet that some of you in this room have colleagues that you know of, or know of someone who knows of someone, who committed suicide. And the national news basically took Lorna Breen, a physician in New York last May, who had COVID, worked in a New York hospital in May, when everything was going crazy. She committed suicide. And the good thing that actually happened from that, from the phoenix rising from the ashes, is that Congress just passed the Lorna Breen Act, which basically is accessing money for mental health care for healthcare providers in the country. It's actually allocating money for this. It is destigmatizing getting mental health care as a healthcare provider. It's a first step. So it was a tragedy that happened that may end up leading to something that helps us. So this idea when somebody comes to you and they say, oh, we have a wellness officer and we have yoga classes, we have spa certificates. This idea that it's you that's the problem, I really beg to differ. Again, you are resilient people, phenomenally resilient people. I beg to differ. Let's go back to that Medscape list. Let's see what really drives us insane on our jobs. Let's see bureaucratic tasks. That might be part of it. Lack of respect. That definitely happens, and that unfortunately even happens within our own specialty, right? A lack of respect. We have different layers of who practices. We need to be careful in respecting other people. Profit over patience. I'm just a cog in a wheel. I have no autonomy. I can't make any decisions on my own. I spend too many hours at work just documenting this garbage. If you stay after work and you have to do all your documentation on the EHR, boy, God, you better be paid for that. And a lot of us aren't. It's just not valued. All this stuff is real. And I'll tell you, zero of this is your fault. None of this is your fault. This is a system problem that the reason I mentioned that last third thing I want you to do when you get out of here is find one of these things as part of the system or something that in the world you really want something to change and tackle that. Do something, get involved on a committee, donate money to something and donate to a PAC where your money is going to go to the causes you care about in lobbying Congress. Whatever it takes, find something that you can do that's the bigger picture, because this is a lot of what's killing us. This is the thing that's driving us crazy. So what can you do? I'm going to step back from with the big global things for a second, because the global things really need to happen on an institutional level, on a systemic level, where administrators have to get involved, legislators have to get involved, and we can have a little piece of that. But the reality is every single day you have to go to your job. Every single day you've got to get through. We all know you have bad days, but boy, COVID has made just every day horrendous. So what can you do? Well, I want to think about who you are as a person, like each person in this room. Who are you as a person? And you're a combination of three major things as far as your health is concerned. Your body certainly, but your mind needs rest. Your mind needs things as well. And I will tell you, your soul or your spirit or your essence or whatever you want to call it needs to be nurtured. You cannot ignore it. You will pay the price. It is at your peril that you ignore these things. It is 100% at your peril. And we think we are just all together, put together people, but you got to be honest with yourself. Think about all the parts of this thing that you're putting together. Your social structure, your family structure, your friends structure, your work structure. All of those are there, and all these things have to integrate into it as you as a person. So when things get bad, one of the first things we do is we kill our sleep. I have a book for you to read. It's called Why We Sleep. It will depress the hell out of you, just have to warn you. It'll make you realize you chose totally the wrong field to go into. But it explains to you why it is you need to get REM sleep, why it is you need to get just deep sleep. Don't even necessarily have to have REM, how you need to do that to stay healthy. Because there's a reason they torture people in places where they torture people by keeping them up and never letting them sleep, keeping the lights on bright, having things be really loud, because you literally go insane. Literally 100% go insane. And if you don't get enough sleep, there are little things called microsleeps. Your body says, oh really? Well, I'm doing it anyway. We microsleep on the way home. You're home from a shift, you've been up all night long, you're driving. How many people do you know who've had little car crashes on their way home? Sorry, didn't mean to rear end you there, just kind of fell asleep because I was flipping exhausted. Do not give up on your sleep. Sleep is key, but we do it first almost always, right? Almost always the sleep tends to go. And with it goes your nutrition, and with it goes exercise. Those three things, taking care of this is super important because it helps nurture this. So your body, you've got to pay attention to. And I know it sounds like we all hear it all the time. It is really, for your job, it is really, really important. When it comes to your mind, you have a bajillion times you spend all of your time stimulating your mind. You're here, stimulating your mind. Your work stimulates your mind. Our lives stimulate our minds. You need mental rest, and we don't do that. Do you just go like take a walk and hang out? No. Do you go do a jigsaw puzzle? Do you go do something that gives your mind mental rest? It is really useful to do. It is incredibly nourishing for your mind to do that. And then as far as who you are as an essence, your soul, your spirit, whatever you want to call it, that, by the way, is what makes you you. That's what gives you your compassion. That's what gives you your empathy. But we tend to smash it because we do things like get burned out, so compassion goes away. You end up with not finding any joy in anything anymore. It all falls apart. This beautiful house of your life that you've built with your friends, your family, and your job is sitting on a cliff waiting to fall. It is waiting to fall off. And I am willing to bet that there are people in this room who you feel like your house is just like that right now. And it wouldn't take much more to kick that thing over the edge. So you can't do that. You got to go back and go to those essence things and fix them. So let's go to the things we do to do that. In that survey that Medscape did, they asked physicians, what is it you do? And by the way, this applies to all healthcare workers. I only say physicians because that's what they did in this survey. But people know, you guys know what's the good thing for you, for your body. Exercise, absolutely. Talking to people about it. One of the things that is pretty consistent in people who end up going to the point of suicide is that they feel isolated, like they can't share. They can't talk. So if you feel comfortable talking it out, that is a healthy thing. That is a sign of health for you. So talking it out is great. Sleep, please, please get sleep. If you are sleep deprived, by the way, you can't bank it. You can't, I'm going to sleep a bunch on the weekend and then not get sleep during the week. Doesn't work that way. Your body, read that book. It does not work that way. You can't bank it. You can't catch up. You need to try to do your best to find a healthy way to sleep in this crazy, crazy field that we chose. And doing things like music turns out to be very powerful. And I think a lot of you know that. So if you need that thing to change my mood right this second, music is actually very helpful for that. So put in your little earbuds, nobody else can hear it, and play whatever. Metal, rock, classical music, I don't care what it is, but you know it's going to change your mood right now. That is incredibly helpful to you. So we know what these things are, and we do them, but we also do a whole lot of things that we know are not good for ourselves. We isolate from each other. We eat junk food. If the back seat of your car is full of In-N-Out burger and McDonald's burger bags, you know you're not eating very well. I like to go walk in the parking lot, look at the back of the residents' cars. It's like, oh man, besides the fact that all the handouts and things we give them, which we don't do anymore, but are always thrown in the back, if there's a bunch of just wrappers of fast food, you know you're not eating very well. So junk food, binge eating. You know, the super-sized bag of chips, family-sized bag of chips goes down while you're, binge watching whatever. We know that's fine for mental rest for a little while, but that's not a healthy thing to do over and over and over again. So let's go back to making sure you take care of your body, your mind, and your spirit. It's just important to do, and it's very woohoo and stupid. It isn't, though. And this makes people so uncomfortable. Every time I give a lecture on this, by the way, I lose probably 15 people during the lecture. It's like, this doesn't apply to me, this is woohoo, and that's completely legit. I totally get it. But you really need to pay attention to yourself to stay as healthy as you can to do this job for 25 to 30 to 35 years. So I'm going to bring up a term most people completely hate, which is mindfulness. It has gotten beaten to death. It has gotten basically made into almost a meme. It's almost like a hilarious thing, except that it is really important. This idea of all you have is right now is absolutely true. You are in a job where no one in the world, except maybe cops and firefighters, get to see the fact that people's lives literally change in a second. That literally you can have it now and you're like breathing fine and be dead in a second. We know that. So no one in the world knows more than what all you have is now. What you have is now. Paying attention on purpose. All mindfulness means is knowing that, like acknowledging that and really embracing that. That really what I have is now. I need to pay attention to the moment. Not to judge it or anything, just pay attention to this moment. Not to just respond, not react, not get reactive and like adrenal, but to just like, wow, it's beautiful. That person's really angry. I'm sorry that they're angry. That's a shame. But paying attention to the moment. It sounds really dumb, but it really isn't. And it's going to help you enjoy the little things that will enrich your life and give you back some of the spirit in your life. Because the reality is now is all you have. And I think most of us deal with the either what's coming down the pike or what happened. We either ruminate on what happened before, we regret things, we're frustrated about things that happened, or we worry about what's coming down the pike. What if there's another surge? What if I get fired? What if? You can't change that. All you can do is live in the moment and live as sort of honestly as you can. So these two quotes I found very helpful. No amount of regretting can change the past, and no amount of worrying can change the future. All it's doing is taking time for you to be human and enjoy your life and just wasting it. Worry does not empty tomorrow of its sorrow, it empties today of its joy. Now, I will tell you, this is not easy to embrace. If my husband were up here, he would be laughing his ass off, because I am the biggest worrier on the planet. I worry about everything, but at least I worry a little less, having kind of learned about these things and really embraced them or tried to embrace them. So I worry less, but I still worry a lot. So how do you do all this jazz? How do you do this? How do I stop worrying? How do I stop ruminating about the past? What can I do? Well, I'm going to also bring up something that people think is woohoo, that I want you to just sit back and think about, and that's meditation. And it sounds ridiculous, but I have another book for you to read, 10% Happier by Dan Harris. So Dan Harris was the Good Morning America newscaster who basically had a meltdown on live television. He had a mental breakdown on live television. It's actually an amazing video to watch. This really accomplished guy. And his boss said, dude, first of all, quit the cocaine, which he was doing, and now get off stage. And what we need to do is reassign you. And they reassigned him to be to report on different religions. So go report on these different religions. And then one of the things he ended up doing, he ended up getting into a meditation place. And they basically talked him into trying meditation. And he's like, are you kidding me? I do not do that. I do not meditate. That does not happen. And he ended up basically sobbing through his first meditation when he finally was able to kind of get to whatever place he needed to get to. And now he's a full-on meditator. And he explains it to people by saying, like, for instance, Diane Sawyer meditates. Like, a bunch of people that are in the industry and meditate. And they said, why do you do this? And he said, I do it because I just want to be 10% happier. I'm not trying to be woohoo. I just want to be 10% happier. And that people get that idea. It's like, if I can be 10% happier, I'm good. The book is hilarious. The first line of the book is, my mind is an asshole. You gotta love a book that starts with that as the first line. I highly recommend it. So there are all kinds of meditation, and this isn't just sitting with your legs crossed in a way that I can't get my legs crossed. It isn't that. It can be anything. It can be anything. It can be just paying attention to how you walk. Walk back to your room, pay attention to heel to toe, each step. You've just meditated. Didn't even know it, you just meditated. You can use beads. If you are someone who prays with beads, Catholics who say the rosary, you're doing a form of meditation. It's a form of meditation. You can focus on things. You can focus on a flame. There's all these different doodads. You don't have to get woohoo about this. You don't have to. It's basically just living in the moment without judging it at all. And I have another recommendation for you. There are two apps. One is called Calm and one is called Headspace. Headspace is free to healthcare providers. You can download it free to healthcare providers. And what this is an app that helps you learn how to meditate and why it works. And it is not woohoo. It's actually hilarious. The guy who owns Headspace is British or has a British accent. And he's really funny. And he makes it like, oh, I get it. Okay, this is what we're doing. And I'll tell you the benefit of doing this. There's other resources, by the way. But I'll tell you the benefit of doing this. I know an individual who was having an incredible amount of trouble at work, like phenomenal amount of trouble at work. And I had done a talk on this, and my recommendation on how to use these things, because like who in the hell has time to do any of this stuff, is to take 5 or 10 minutes of your day, once or twice a day. And way to do it is go to work 10 minutes early. Park in the parking lot, click this thing on, 5 to 10 minutes, go to work. After work, sit in the parking lot, 5 to 10 minutes, do it again, and go home. One of the people that I work with tried this, and basically 100% changed his life. I am flabbergasted. Not that this is any be-all, end-all, except for him it was. It was the thing he needed. Super easy, didn't feel like woohoo, embraces this completely now, worked it into his life. It was fabulous. So think about this. And again, you do not have to meditate. I will tell you, it saved me. I was the poster child for burnout about 8 years ago. Literally, my husband finally said, you're either quitting your job or I'm getting you a psychiatrist because you are over the top burned out. So this can help you. It was a lifesaver for me, so this could absolutely help you. Another kind of meditation that they've actually studied for physicians that says it works is a thing called loving kindness meditation. This is an idea that you, even if you don't believe it, even if you think it's 100% BS, if you say, may I be happy, may I be safe, may I be healthy, may I be at peace, if you say that, your brain says, oh, okay. I mean, and they've measured all kinds of psychological scales. They've actually measured people's brains in PET scanners and in basically functional MRI scanners. It's amazing. It changes your brain. So up to you. So that's all the meditation thing, but I'm a big fan. Now, the other thing is to remember, every minute of the day you're feeding your mind. You're feeding your mind right here, right? You're feeding your mind all the time. And you would never feed your mind a toxin, right? You wouldn't drink, let's see, bleach. You wouldn't drink disinfectant, for instance. You wouldn't take in a toxin on purpose. Why put one in your head? No one said, I love putting toxins in my body, but don't put them in your head either. One of the best things you can do for yourself today, is if you have news feeds that come on your phone, cancel them all. Every single one of them. There is not one news feed that's good. There is not. It doesn't sell. Get rid of the news feeds. Do not put toxins in your body. That's one way to get rid of it. If there's something important, you can read it at the end of the day. A friend will call you and tell you. You don't have to get battered 100 times a day with news feeds, news breaks. These news things, even in newspapers, it's what they put bad news when there's space, because that's what people thrive on, which is just, they don't thrive on that at all. Violent things also. You get plenty of violence in your job. If it's something you love, that's fine. If you like violent movies, if you like violent video games, fine. But violence does change your brain. It actually has been measured to change your brain, so know that adds a stress. And there are people in your life that you know, unless you have to have them in your life, probably shouldn't be in your life. They're not adding anything. And it is a hard thing to do, to take someone you know is not good for you and get them out of your life. But I don't know, this pandemic has shown us sometimes that people may not be good for you and you need to get them out of your life. So you have to decide what kind of things you put in your body, because the reality is every single thing you put in your body and your mind matters. So make thoughtful choices. Don't do silly stuff. Make thoughtful choices in what you do. You can change how you think as well. Don't focus on the past. The things you can't change are the things that you don't have, but focus on the future and things that you do have and things that you can change. Otherwise, you feel like you've just been, you're not empowered at all. Empower yourself. The last little bit I want to mention is gratitude. So there is great literature out there that people who focus on gratitude get happier. They just do. Sometimes it's hard to find anything to be grateful about, but find something to be grateful about. Even something. So I'll get up in the morning and I'll think, nothing in my body hurts right now. Like, I get out of bed, I'm not even aware of my body because it doesn't bother me. There are people who every single day they get out of bed and they have pain. Like, just that alone makes me happy. Just that alone, I am extraordinarily grateful. One tiny thing is all you need to do to help yourself. And if you want to do something really cool, there's a thing called a gratitude letter. Go through your life and think about somebody in your life that you would like to say thank you to, anywhere in your life. Look them up on the internet, find their address, and mail them a real letter, like an envelope with a postage stamp on it. I did this for one of my grammar school teachers who had been instrumental in how I learned things and how much I loved words, and she'd just been instrumental. I looked her up. She's a bajillion years old. I wrote her a letter, and I don't even know if she got it. I have no idea. But if she did, it made her day, and just writing it helped me a ton. So it's something to consider. All right, let's talk about a toolbox, and then we're going to wrap. First things first, be gentle with yourself. If you are not doing well, that is okay. It is okay not to be okay. Reach out, find a friend you can talk to, go talk to a therapist if that's, whatever it is you need to do, it is okay. Be kind to yourself. If you are really struggling, that is okay. That is absolutely fine. Make sure you get plenty of sleep, get good nutrition, get your exercise, but the way to do that at night, a big way to help yourself sleeping in the night or day, is get rid of that stupid cell phone. Get rid of that thing. If you do have to use it at night, turn it on that night mode where it's all yellow and it looks gross anyway, so why would you look at it? So if you have to use it at night, better yet, if you use it as an alarm clock, put it where you have to get out of bed to turn it off. It's going to get you up, and it's not going to keep you awake while you look at it at your bedside table. This thing kills sleep. 100% kills sleep. So this is the best thing you can do for your sleep, is get rid of your cell phone. And then remember the little things. Remember to smile. Remember to go outside. Remember laughing helps. Remember things like moving. So if I'm having a bad day at work, I go into our bathroom that we have for the staff, which is this big, gigantic bathroom for one person, and I put in my earbuds and I dance my brains out for about 2 minutes. It feels so good. And you go out feeling pumped. Little things, they sound dumb, but I will tell you, you can take control of this. Like, do what you know that works for you. Reframe the situation. Take a moment if you're frustrated. Stop, look at the situation, take a breath, and then go back to what you're doing. Use your senses. If good smells make you happy, go for that. If music does, if just going outside and looking at the sunset does, do that. It makes you feel better. Do something outside yourself. Make somebody else happy. Say thank you. I will tell you, take a day, just take one day, and say thank you to everybody whose path crosses you. So say you're flying home. Thank the flight attendant. Thank the person who drives you in the Uber. Thank the person who's checking you out at the grocery store because they risked their lives just like you did in your job. It is amazing how much you feel better and how you've made their day, and it takes no energy at all. It just takes some thought. Absolutely no energy at all. So do something outside yourself and make sure you remember to breathe. I'm going to skip this one because breathing is awesome. So take a body inventory. Know if you're having trouble with stress. So watch those shoulders. Make sure you get enough sleep. Exercise, even if it's just 10 minutes twice a week, do something you need to do. Find some quick relaxation technique. That's your assignment from here. Limit your news. It's never good. It's never good. If it's important, it will get to you anyway. Limit your screen time. It's called doom scrolling. You basically face suck yourself onto that phone and you never come out. Please come out. Practice empathy if you can. Gratitude helps. Loving kindness helps. And schedule some of that stuff. The last thing I want to mention, and we are done before lunch, keep in mind that you need a purpose and that you chose the job you have because you have an extraordinary purpose. You take care of other people in their time of need. I can't think of a better purpose in this world. I cannot think of one, except maybe raising children, which is actually really important. So keep your purpose and do whatever you need to do that. Make sure you vote what is important to you. You donate if you can. You protest if you need to. You mentor somebody. You lead. Get in there to make a purpose. So the last thing I want to mention, this book is the other one I recommend if you need a pick-me-up. This is actually a physical book on my bedside table, 30 Lessons for Living. This guy who did a PhD research project by interviewing people over the age of 65, and he asked them 10 questions about what would you tell your younger self now if you could. Now that you're an older person, what would you tell? What would you tell them? And actually, it's hilarious. It is a really fun read. It's hilarious. But to boil it down, free your heart from hatred, be grateful, don't waste time worrying, live simply, give more, and expect less. Each and every older person said that's what they would tell their younger selves. If you're younger now you can tell yourself. Please remember when you go back to work, you do not have to set yourself on fire to keep others warm. Please take care of yourself. I wish you well. Enjoy your lunch. We'll see you back at 1:30.
They're working on it. Martha.
Off. Oh, there we go. Hello.
Oops, go ahead.
I love that talk. One important thing that one of my mentors always told me is never use alcohol as a reward after a shift. I'm serious. You never should use alcohol to reward yourself, but today I'm going to. This is a reward for one of you people. And if we don't find them right now, who has the color manual in the audience? There is one color manual.
Color?
It's in color.
Ooh, fancy schmancy.
Basically, I want it back, so I'm going to trade you. Okay, it's nobody in this room. We'll try again this afternoon. Okay.
We might have to ask when everybody's here. That might help.
I know, not everybody is here. Not everybody is here.
You missing somebody?
Ramen.
Oh, ramen. That's okay.
Well, we'll see if he shows up.
Maybe we didn't tell him. Maybe I didn't tell him.
Okay. Gooch, the first one's for you. Any hints for using ear loop to remove cerumen without causing pain?
It's fun. I mean, if you can really soften it up, so using your peroxide, your Colace, whatever you have, let it sit there for 15, 30 minutes, and that's going to make it a lot easier to get out. But it's not pleasant because you're literally just scraping off that hard wax. And I usually try, unless it's really soft, I usually don't use a scoop. I'll try the irrigation first, once it's softened.
Yeah.
I love that you can cure deafness.
Yes.
I love that.
Do we want to say anything about beer potomania?
No.
No. Okay. Okay. Well, Ramon's not here, so I'm going to skip just a few of those and we can come back to them. And just a reminder for those of you that need the live stream website, it's just www.ccmelive.org. Oh, here's a good one. How long do you wait to recheck sodium levels after hydrating to reduce sodium levels? How long do you wait to recheck sodium levels?
Actually, either direction, it probably doesn't matter. So again, symptoms trump everything, right? So you're going to watch, especially in the hypernate or the seizing patient or comatose patient, you're going to want them to get asymptomatic. So you're going to want them to get their mental status changed. That's the most important thing. And then you follow it usually every 2 to 4 hours, depending how sick they were when they started. So if it's just that it's not that bad, you can go every 4 to make sure. The main thing is the reason that first 2-hour window is to make sure you're going the right direction.
Yeah.
To make sure it's actually going the right direction, which it usually is, and then you can relax back and get down to sort of less frequently. The sicker the patient, the more frequent. Usually every 2 hours is fine, and then extend it past that.
And for that initial seizing patient, you've only got to get their sodium up 1 or 2 milliequivalents, usually to stop the seizures.
Right.
So she talked about that. The typical 100 ml bolus is all you need, and that's usually going to stop the problem, and then it becomes an inpatient world problem because we're not going to fix it totally in the ED, and we should not try.
Right.
Dan, can you repeat the BLT mnemonic with the pickle and the mayo, just to hear
Yeah,
it
so
again?
bacon, lettuce, and tomato with a kosher pickle and mayo is my mnemonic I use for the cancers that go to bone. Bacon is breast, lettuce is lung, tomato is thyroid, kosher is kidney, pickle is prostate, and mayo is multiple myeloma. So bacon, lettuce, and tomato with a kosher pickle and mayo. Those are the ones that tend to go to bone that cause elevated calcium levels.
Okay.
Did you skip the one about the supraspinatus tendonitis? I think there was one question there about injections.
Yes, I can bring that back up. Here you go.
Because I think that's pretty straightforward.
Would you consider injection for shoulder impingement or just NSAIDs PT? That one?
Yeah. I had this oddly enough about a month ago, and I could not abduct my arm more than 5 inches. So I went to my orthopedic friend, and you know what I used to do is basically inject these with steroids. And some people say, well, let's break it up while you're there. Well, this is a calcific tendonitis. That calcium has been there for years, and you're breaking that. You're going to be hammering this up with your needle. Steroids work incredibly well. You basically have, there's not more calcium there, this week than there was before. It's just kind of got irritated in some way because it doesn't fit as well as it used to. And steroids work surprisingly well. I don't think, frankly, you need to inject it if you feel uncomfortable doing that, but within 4 days, like it was totally gone, 0.
Yeah, injecting any joint you need to do right. So part of it is make sure it's super sterile, et cetera. But injecting a shoulder is pretty easy. Actually, there's several approaches you can go. I like from the front better, but there are lots of ways to get in there. So it's a pretty easy thing to do.
Well, this isn't even injecting a joint.
Yeah,
This is a tendon that's running over the top of your, right there, and basically.
Right about in this area.
You can take 60 of prednisone one day, and it'll be remarkably better the next day without injecting it. If you don't feel comfortable, but you'll get a similar result for sure.
I think 2 really useful injections to use that I have been using simply because I see them so frequently are lateral epicondylitis and Dacrovane's tenosynovitis. So Dacrovane's tenosynovitis,
That's the Finkelstein.
right, with the Finkelstein, you put the thumb in and you bend it. I have actually, Jim used to inject this for me, which was really nice. So after I had a baby, I was pushing the cart a lot, and I was making bottles, and I was really using this wrist a lot. It really hurt, and we did an injection right along that tendon. Within maybe 3 days, I felt 100% better, and it hasn't come back in 7 years, believe it or not.
Yeah, but that injection, make sure you know what you're doing.
That's true.
Because you can, if you get that needle into the tendon with steroids, that's a really bad move.
The problem with it also is that you get a post-injection flare. So you have to warn patients that maybe it will get a little bit worse before it gets better. But then with the lateral epicondylitis, if you pepper the joint in there a little bit, it's painful. I've seen the orthopedics do it. We actually have a really good video. I'll post that. If you can find that one spot, I mean, you can bring someone a lot of relief by doing it if you know what you're doing. So.
Well, the reason to inject the shoulder actually is because you're going to put Marcaine in there, which will stop the pain basically instantaneously. So, but otherwise, if you want to wait a day or two.
Yeah, that's
steroids
actually
work.
probably a key thing to say. If you should learn how to do these correctly, but you're obviously going to use an aesthetic like lidocaine or bupivacaine, along with usually 40 of Depomedrol, and it's 1 to 2 mLs of the injection, and that's the solution that you're using to inject.
Okay.
All right. I put a couple videos on there of shoulder dislocation that we had done. If you want to take a look at those, there's so many different ways that you can try.
So fun.
But pick 1 or 2 that really work for you. That's was good advice. Then just kind of stick with those. Like if your first one doesn't work, then go to your next go-to.
I think it's important that low energy reductions be learned by people, because I remember when I became a resident, it was like pulling across the room kind of thing, where you had the biggest EMT in the department acting as ballast on the other side, and they had the sheets under the axilla. That is like, external rotation technique. And if you're a tiny little female and you're doing a big guy, external rotation techniques works, no force kind of thing, minimal force certainly.
Plus it's fun.
Yeah.
It's such a,
So fun.
There's one small little tool that I forgot to mention for the cerumen impaction. The ENT guys love to use the cerumen cone. And it's basically just what it is, a cone. It sits in the ear, and you can use that as a guide to safely scrape around to pull out the cerumen. And then that way you're not kind of banging against the sides or scraping where you don't want to scrape. So I put a video up of us doing that as well.
We should have invented that. We should invent that.
Yeah.
If you come up with some cool invention, we can all make $1 gajillion.
Right.
Next one is any recommendations for fungal infections? It was this in regards, I think,
Must have been to something.
I assume the ear and talk, and I think
Yeah.
this is something that we don't see very often. And occasionally you have the patient who comes in with recurrent external otitis or something else. It's just going to be an ENT referral. So they usually go in and do a little biopsy and then actually wait to see what they actually grow and then treat that. And that's usually a long course of topicals, powders, and other things. If the patient has recurrent otitis, definitely might be the person I want to refer over to ENT. Yes.
We have an audio.
So they've probably had 2 or 3 more.
Repeat the question.
So the question was, when might we consider it to be recurrent? Probably they've had 2 or 3 more cases within a couple of months. Because typically you're going to get better within 2 or 3 days and should have full resolution within a week. So, but if they've had recurrent episodes over several months, that'd be the kind of be more concerned.
I'm going to scroll down just a wee bit here. Can you just, we were talking about this, Gooch and I, about how to document for the HINTS exam, if you do choose to do that. The question was, how do you document a normal HINTS exam?
So probably the best would be here is just saying, hey, their hints points to this, is say, hey, there was corrective saccata, there was unilateral nystagmus, and there was no diagonal or vertical skew noted. That really just defines what 3 things I saw. Some people just say, hey, their HINTS exam points towards peripheral versus central. It's still fairly new and it's still kind of heavily debated. A lot of people don't like it. And I'd probably be more detailed and say, these are the 3 things I saw that really tell me it is peripheral versus central, especially the unilateral and the corrective saccade.
I think that any time that you're referring to something like, oh, Romberg is negative or cerebellar function looks normal, You know, it's not really great to say that. It's better to say, I stood the patient up and have them close their eyes. They didn't wobble. I watched them walk. I mean, it doesn't take...
Unless you have a standard cerebellar exam.
That's true.
So if you have something that and if you deviate, that's when you document.
Yeah, there you
so
go.
If you because otherwise you'll have, like, your charts will be a million miles long. So if you have a standard exam, so if you say hints exam normal, and you have your way of doing the hints, that if you ever got called on a stand, for instance, you could tell a jury, this is my hints exam, then that's a fine way to document it. Same thing with cerebellar. But if you deviate from what is your standard, then make sure that gets in the chart. Did not stand patient, but finger, nose, finger, and heel, shin normal. So anyway, that's
great.
Because otherwise you document forever.
And some are easy. Hints is detailed, but you know,
Yeah.
doing a Romberg, hey, they drifted or not.
Yeah. I like this question that Tiffany asked. I'm a new graduate PA entering practice for the first time. Do you recommend creating macros for the more common diagnosis in the ED? If so, are there standard templates available? I would love to be able to use a checklist to ensure I don't forget document essentials. So we do talk about this in the last lecture called Odds and Ends in EM. I talk about a couple of different things that you can put into your chart that are relatively safe. However, we have to be careful with smart phrases, right? They can get us into trouble.
So macros are absolutely 100% get macros. Please, please, please. Otherwise you'll be typing your brains out forever. But make sure you know what's in your macros. So make macros that are specific to you, not something you pull off the web, or if it's something you pull off, you adapt it to you in your practice so that it really reflects what you do. That is totally fine. And if you know that there are certain things, like I always ask X in my URI macro, but today I didn't, take it out. Like macros are adaptable, so take it out. Pop it in there and then delete something. So make them for you.
All right. Do we want to talk about calcium chloride?
I don't know what the question was.
So-
Why don't, it's actually not a great idea to extravasate anything, but extravasating calcium can actually necrose the skin. So one of the things when you're pushing, it is worth being as accurate as you can with calcium. And using calcium gluconate is probably better than calcium chloride. However, we don't have gluconate as easily readily available in an emergency. The key for any drug you're going to push, though, is just make sure that the IV works. It takes 2 seconds to do, aspirate a little bit and see. It just is, you don't want it to necrose the skin. There are other drugs other chemicals that do this as well.
There were a lot of questions about potassium and magnesium.
Yeah, so the key to potassium and magnesium is don't overthink it. So don't overthink it. It basically, if you need to replace potassium, consider replacing magnesium. You can do it orally just fine. If IV for sure, if you're going to replace it IV, then just hang 2 grams or a gram of mag. Get the mag in there. And it does not correlate with their mag level. Okay, so a level may look normal, but as far as what the cells are seeing, it may not be enough. So just give some mag. As long as people don't have renal failure, you are good to go. They're gonna, if there's extra they end up in their system, they'll pee it out. So IV potassium, definitely give IV mag. Oral potassium, there's no harm in giving them a little bit of magnesium to take orally. It's fine. So again, normal renal function, you're home free, and at least you'll be sure that they're going to absorb what they need in the potassium section.
Rick, you and I have talked about getting MRIs for non-emergent things in the ER before, but I don't think we've ever talked about getting a bicep rupture MRI. What do you think about that?
I wouldn't do that. I think it's really a nice clinical diagnosis. You got this Popeye muscle there. I don't think you need to do
And somebody
that.
did ask, how do you know the difference between the sort of the long head versus the distal tear? It kind of just depends where it ends up.
Yeah.
So it's one of those things that once you see it, it's like, oh, I
That's
know
that.
what
There
tore.
you go.
The lump is either here or the lump is here. It actually ends up being it's not hard. It's actually
I
pretty
posted
obvious.
some stuff on there so you can see a couple of different pictures, but as we've said, it's a clinical diagnosis and you have to see one to know it.
But once you see it,
you won't
it's like,
forget it.
Oh, I got it.
Okay.
And POCUS is helpful, using ultrasound just to kind of look at
Oh,
it
yeah.
and make sure, hey, this is the bicep versus something else.
Yeah, if you're ultrasound savvy.
So fluoroquinolones, risk for tendon rupture for a year, question mark?
So I posted a link on this. That's a really, really good article that looks at what the risk is. And most of it's with the median is 6 days. Most of them are within a month, can be as long as a year, but we're talking the majority are early. So there you go.
There you go.
And attorneys are all over that, I gotta
You
tell
know,
you.
I'm not quite sure why anybody in the ER now would use a fluoroquinolone when there are other drugs that you can use, particularly about these neuropsychiatric things. I would be less worried about a tendon than I would about making somebody not sleep, headaches, anxiety. If you go onto the web, the floxing, Floxing, I've been floxed. There's just a lot of stories about people who believe that this is true, and it resulted in a black box, which, and they specifically say for like bronchitis and UTIs and one other thing, but if they say for those three, well, why would you use it for something else? Unless there's something that is not cured by pretty much anything else.
I think the biggest time this comes up is with urologic issues.
Right.
Where it really is the best choice of agents. And then it really is just sitting down and chatting with the patient and talking about it and figuring out, if it's a 30-year-old versus an older person, or if they're on steroids. I'll tell you, the kicker is if they're also on steroids, I would, like the plague, avoid a fluoroquinolone in somebody who's on chronic steroids. Those are the people that get the big ruptures, as far as the tendinopathy part.
Well, the first lawsuit against it was somebody who was 84, ruptured bilateral tendons and Achilles tendons, didn't do well, and his doctor was treating him for bronchitis, so he gave him a Z-Pak and fluoroquinolones.
So I took Levaquin once, and I had the most intense hallucinations. It was really,
It's just begging for me to jump in there and say something.
oh, what do you want to say?
No, I think that we just aren't aware of what it's been doing.
Would they have occurred anyway, Diane? That's what
Just-
she's trying to
just
say.
leave-
This is
leaving
a
it
great
there.
example of post-marketing, surveillance.
It wasn't the Levaquin. It was all, never
Are you
mind. I
having
won't
fun
make-
down here?
Yes, we are.
Okay. For complete block, Diane, addition to
Yes.
pacing, we would treat as ACS even if asymptomatic, correct?
So not necessarily. So people can have just their own heart block that gets worse over time. If it's out of the blue complete heart block, they haven't had any kind of block before, yes, you can consider ACS. And actually, Mike put in the comments there, the replies in there, that once you start pacing somebody, if you need to pace them, know their trope will go up. So having a trope ahead of time is useful. It certainly is something we see with acute coronary syndrome, no question about it. But it also is something that is a progression in people who have underlying heart block disease that can just progress to third-degree block. If you don't know, you can go ahead and assume that there's ACS and just do the simple stuff, the aspirin and whatever. And as long as the EKG isn't, EKG will still show you if you have changes that go consistent with particularly a STEMI. So that's still in there. But in general, though, if it's somebody they've had blocks before and they had second-degree block last time, or they had a bifascicular block and now suddenly they're in complete heart block, then that doesn't necessarily need an ACS workup. Again, use your clinical judgment. Use your smarts.
How long do you wait after you apply lidocaine prior to removing a bug in the ear? I had an experience where the bug was breaking apart. Well, about 10 to 15 minutes should be enough to kill that sucker, but honestly, I like to use a little bit of liquid cocaine. It's very useful. We
don't stock it
Is that the
anymore.
shot or the? No, okay, not the shot.
I like the liquid cocaine for the procedure, all right? So basically you dilute this little powdery substance, it's cocaine, and you just put it in the ear, and it will work and anesthetize the ear within about 90 seconds.
What's the
Super
likelihood
quick.
that
Yeah.
pharmacy is going to give you
So
a powdered cocaine
we don't
for
have
a bug?
cocaine at all,
Yeah.
period, anymore, for anything.
Although
So-
I think
Well,
that's the same
that's
too.
a
because
letdown.
Lidocaine works.
Lidocaine can work too. I would leave it a little longer though.
It can,
using
there's one little weird side effect that can happen when you put lidocaine in with a living creature in somebody's ear, is the living creature may seize.
Oh, that's right.
So warn them
Yeah.
that because they'll freak out. They're sitting there, but they already know something's in there, and then it starts moving and seizing in there. So please warn them it can seize, or at least be prepared for them to wig out as that creature is dying in its status epilepticus.
Yeah, and Jesus.
Usually 2 or 3 minutes, the bug's suffocated.
Yeah, so,
It's done.
Warn them.
just do a little gentle irrigation and get all those pieces out. And honestly, if you don't get every single tiny little piece out, it's not the end of the world. They can re-irrigate later. Just irrigate as best as you can. You don't have to like shove the water in there. Just gentle irrigation.
Some of the best
irrigation.
stories come from these things, right?
They really
like
do.
I like the people who want to take it home, the people who want to take a picture. It's just the stories.
Okay. I like this one because it made me think of something else. What type of splint for midshaft humeral fracture? So, I like this question because if you have a midshaft humeral fracture, really getting that person in a sling is super important for comfort levels to start, no matter what you're doing. Now, as far as like an actual hard arm splint, my orthopedic people don't recommend doing that. They just say put them in a sling and we're either going to take them to the OR or we're not. But it made me think about other splints that we do for people. And I think there's another question in here somewhere about it. Anytime that you have the ability to make your own unique splint for a patient, you should do that. I think it's really good practice to splint all your patients. It saves you time. You know what you want. You know what you need. You don't need to waste time trying to wait for a tech to come and do it. You should just do it. So anytime that you can do that for a patient, I would highly suggest it.
Yeah, so I splint them. And I've done it for a long time, mainly because I find that orthopedists, until they get something broken of their own, where they actually understand how painful fractures are, tend to get a little bit cavalier, and it's fine, except that think about the people who usually get midshaft humerus fractures. These tend to be elderly women who basically have broken their arm, and they often are frail anyway, and opiates are not a great thing I want to snow them with. I'd like to keep that thing from moving the best I can. So splints are key, but I use an elephant ear. I basically wrap it under their elbow, so basically it's called an elephant ear. You can tuck it over their shoulder if you want to, but basically it just wraps, it's like a sugar tong
Right.
going
Yeah.
up. And you can actually tuck it on top of the shoulder if you want to actually give a little bit of support to this thing. So it actually from here to here keeps it elongated but not moving. And I just find that's more comfortable for people. I've talked to orthopedists, they say, yeah, you can if you want to.
Yeah.
But these poor people are miserable. Imagine.
Especially if this thing is obviously.
Go home with this. Oh yeah, go home with this bone that's gonna go.
Would you ever do a long arm? Have you tried long arms? Have you tried to do that?
I haven't done a long arm,
Haven't
but-
done a lot of them with success. They feel more cumbersome than anything else, and they're heavy as
Yeah,
all hell.
right.
So it's like you've got all this extra padding down here. So I like the idea of doing
I like the
your
elephant
elephant ear, that and the support under the armpit. But I remember the last couple times I've had one, orthopedics, they were there and they were like, don't do that, don't splint that. And I'm like, okay, well, you know.
Yeah. And then I let them go away and I do it anyway.
And somebody
That's
posted
a
there, you
good-
could do a comptation splint as well. They
Yeah,
sometimes
those work
sell.
too. Yeah.
Those
Okay.
are kind of fun to get to stay in place because it's coming off the top of the shoulder
Yeah.
and down halfway and it stops and that's it. And it's like trying to get this to stay in place is sometimes kind of fun.
Yeah.
I love this question. We get this frequently about what to do with patients with heart failure. Do you give them the fluid or do you give them the pressors? What do you do first?
Heart failure?
Sepsis.
I didn't. Sepsis.
Heart failure and sepsis or shock? So this is septic shock, but they can be heart failure and shock too.
Oh, did I get that confused with the other question? Sorry, what's this question? Sorry, I have one job right now.
That's right.
So what do you do with severe heart failure in patients who are in septic shock?
This is the
So you go
septic
to
shock
pressors
question.
early or go ahead and do the 30 per kilo bolus. So what do y'all do?
That's where it is.
Give them 10 per kilo and reassess. And
Yeah.
I put in there, try to think about doing ideal body weight here, not actual. And Chip posted some really good stuff too, but if you can't do the full 30, document why. Hey, this person has a history of heart failure, they already have rails. I
So
felt
I'll
30
tell
per
you,
kilo was detrimental.
there is no way some bloody CMS person sitting in an office with their feet up on the desk is going to tell me how to manage somebody who's in septic shock with heart failure. Thank you. So I'm going to do what I think is appropriate. 30 per kilo is bullshit, and I'm going to basically say, I am not giving it because I don't want to drown my patient. Thank you very much. Get out of my life. I'm going to go ahead and take care of this patient. It's ridiculous.
Damn, girl, I like that.
Well, it's insane, right?
You tell them.
It is insane.
Can I tell the people at CMS that all of these remarks are her personal reviews?
I
and
will
not those of the
totally own
company?
up to these things.
Unrelated.
It is ridiculous. I'm not going to pay you for your care because you didn't give 30 per kilo.
I
Oh,
love
yes,
it.
you are. I'm going to tell you why I didn't do it, and now go away. You know, so don't practice medicine as medicine needs to be practiced. And if it's something, the patient is first, always. Yes, you want to get paid. Yes, you don't want to get dinged. You don't want those little letters we all get. But you also put the patient first, always. And there's a way around it in this one. You just have to add a little documentation. It's completely fine. Ugh,
All right,
sorry.
there's that.
Revolution.
I also liked this question, the association between atrial fibrillation and heart failure. I think this is like, which came first, the chicken or the egg? Now, I don't know, I can't remember what you said today specifically, but there was a question about, it seems like it was stated that it was the opposite, that heart failure will lead to atrial fibrillation versus atrial fibrillation leading to heart failure. I think they're both true.
No, I just kind of made the point that if
Oh,
you
or
have
was that Rick?
atrial fibrillation in the setting of heart failure, that you just gave up your atrial kick, and everything's supposed to be working together to make this stuff work, and so that may have precipitated this episode of pulmonary edema.
And they're actually two different things. They really are two different pathophysiologies here. And people may have both because they happen in older people, and they may have both, but they actually have, one doesn't really cause the other or vice versa. It's just somebody who has the bad luck of having both. Because they're two separate pathophysiologies.
One's a pump problem, one's an electrical problem.
Right.
Okay, last two questions. Oopsie. Forearm, oh, sorry, they started with forearm, etc., immobilized. What it is.
When is it necessary?
Good God,
Read.
When is it necessary to consider a gutter splint an ACE or just an ACE? No doubt we will use a sling, just wanting to know when you consider advancing to a splint in the future. Okay, so I answered this a little bit earlier, just with our last question about the humeral fracture. Anytime you can take it a step up and you're not sure, why would you not want a better splint? However, the one-size-fits-all mentality for like a volar splint or something along the lines of that doesn't always work for every patient. And ACE wraps, they can have some benefit, but if you're questioning the diagnosis or you're uncertain, maybe there's a scaphoid fracture or something like that, then you should err on the side of caution and splint.
They're more comfortable.
Yeah, it's also more comfortable. Any suggestions on negotiating time off after 24-hour shifts with administrators who are out of touch?
So I'm not kidding about this revolution thing. The paper pushers and the bean counters have taken over what should be taking care of us and our patients, and I'm not exactly sure how to get back there, except that there is really good data that says a lack of sleep is dangerous for you, and it is a harmful thing as far as patient safety. Are you going to talk about it?
In terms of sleep deprivation being equal to alcohol intoxication if they have had less than 2 hours or
Right.
3 hours.
Right. So I think all you can try to do is educate. And the other hard part about all of this is if you're being put in a situation that you think is dangerous, either to the patient, because of either medical practices that are happening or this kind of thing, or to you, sometimes the only way to fix it is to leave. It is just not worth the car crash, the depression, the harm to a patient. It just isn't. And I know that is a very hard thing to do, to change a job. But I'll tell you, we are in a situation right now in emergency medicine where there is using of people happening all the time, where people are just being pushed to do things that are just not right. And it's just time to either push back or don't stay there if you can.
If you work a 24-hour shift and are awake that entire time, you are unfit to drive a car at the end of that shift. And once you get into an accident in which you're culpable, because it'll be clearly shown that you were awake all that time, there'll be a suit against you that will basically help you get some sleep in the future because
You won't have a job.
yeah. So
Yeah, there's a
that's-
reason they don't let pilots. So if you take a long flight, so you fly to Australia, the pilot has a little place to sleep on the airplane. They won't let a pilot fly.
And those planes fly themselves.
Yeah, they won't let them fly. So industries where people's their health, like your life in the air, makes a difference. They don't let them fly. They do let firefighters work these crazy shifts. I mean, that is insane. They let them work 48 hours straight with no sleep. That is ridiculous.
crazy.
So, yeah.
This is the last question here. What would you tell your younger selves?
That's a great question.
What were the most important factors for long-term success when finding a good fit group hospital early in your career? Sincerely, a new grad. Who'd like to go first?
So I actually had a great job. I got hired out of residency in a killer job. I had a very supportive chair who let me be my best person, my best physician, my best educator, and did what he had to do as far as like, here are the hoops I had to jump through, but was extraordinarily supportive in letting me grow. And that was just immeasurably important. And I stumbled into that, but I would, if I were to go back and do it now, look for that. Here are the things that are important to me. And I would pick a job where I could talk to my boss and say, it is equally important to me to have a 5-year plan in my job as it is to have time with my kids in their soccer games and a date night with my spouse. And that is equally important, so this balance has to be part of it. So if I were starting fresh, that's the kind of thing I would want to know my boss values the same way I do, so that we're on the same page at least when those kinds of issues come up.
Yep, that's good advice. Rick?
The jobs in academics are all taken.
I know.
So you have to go somewhere else now and be a pit person.
But Pitt's good. Pitt's good. It's fine.
I think that the pit's good as long as you are wired in such a way or allowed yourself to become in such a way or find outlets in such a way that you can do this for a career. Because unfortunately in emergency medicine there is no clear career ladder. It's more of a pyramid. If you want to be the director of the group, it's a pyramid rather than where everybody can go up the career ladder. So, I think that it's very difficult to tell you the truth. Some jobs are going to be. I think that basically you have to shop around till you find a job that you think is a good job, but that may not be the prerogative from some people because of where they live and their options to move and those kinds of things. So sometimes you just have to learn to love the one you're with.
So I think the advice, though, loving the one you're with, okay, sure. But for me, the first 1 or 2 years, I thought to myself, well, I really want to work hard here, and I really want this pension, and I have to get 5 years in before I'm vested, and that was really stressful for me. And I see people working in jobs that they hate 15, 20, 25 years, and then when it's been 30 years, they're like, it's just 2 more years, it's just 2 more years, it's just 3 more years, so that they can get this big cash payout. But to be honest, I mean, I left that first job very upset about, not being able to be vested, but it was so not worth it to stay there. It was not worth that payout later down the line. I found other things that I enjoyed. I worked in jobs where I had more fun. I didn't stay in a job that I hated because I thought, well, this is a good way to retire. You have to think about your finances, but you have to think, as Diane said, about your current state of health and your mental health and your mind, your body, your soul. You'll make up that income somewhere else. You'll figure it out because you'll be doing something that you love somewhere else. And so I wouldn't waste time in a job that sucks the life out of you.
And you?
Gooch?
There's always room for negotiation.
There you go.
Don't take the first job that comes along. Look, and instead, you got to make time for yourself. Most of us are very career oriented, we're type A's, but sometimes it's not worth it. And you're looking at, is this worth that many hours of my life to be miserable? And of course, right now is a bad time. It's a horrible time for comparison compared to 3 years ago. But there's always room for negotiation. If you don't like somewhere, go somewhere else.
Yeah.
If you can't make things change. And sometimes just talking to people, as Diane mentioned as well, ask them what they expect, and here's my expectations as well. And it seems that longevity doesn't matter to most people anymore. I mean, I'm in my position now 20 years, and probably couldn't care less. If we look at the big upper level people, they're like, oh, he's just another person. But negotiate and take care of yourself.
And realize that negotiation is more than just money. I think that people think about negotiation as negotiating my salary, but think about the things that are important to you and negotiate. You can say, if you say full-time is 12 shifts a month or whatever, I'll do 10, but I'll do all nights because that gives me time off with my kids.
I like that.
That's the kind of negotiation that you can do. I don't hit my salary for that either. I want the same salary, but I'm going to take 10 nights off your hands because that fits with my life. So negotiation is more than just money or pensions. It actually, there are soft negotiating points that you can actually use very well to get what you need in your life. I need 2 weeks off a month because I have a kid who's disabled and needs such and such, but I can work these 2 weeks and I'll put all my shifts in those 2 weeks. Can we work that out? So those are the kind of things where it's not a measurable pay thing, but it's something you can get what you need. And that's something that's in negotiations that people don't think about, sort of the soft negotiation stuff.
All right. We'll see you back at 1:30.
1:30. Thank you for sticking
Thanks,
around. Okay. Time for some hypertension and some fainting. Okay, we're going to talk about hypertension and syncope. This sort of is a theme today of cardiac things. We've been through myocarditis, pericarditis. We've been through sort of the dysrhythmia stuff this morning. And now we're going to talk about hypertension and syncope. Two pretty disparate topics, but kind of decent to lump together. So let's talk about elevated blood pressure. So hypertension is a very specifically defined thing. We tend to use it in this broad brush term for everything where the blood pressure is elevated, but it's kind of not that. It actually is very specifically defined by the American College of Cardiology. And the reason that they do that is to help guide all of us in which patients need to get what kind of interventions done. And we do know that elevated blood pressure is the single most changeable healthcare condition we have in this country as far as an impact. So it is a healthcare condition that someone will get, a disorder that they'll get, that if we can get their blood pressure controlled, the impact on the healthcare system and that individual's life is extraordinary. Renal failures, strokes, heart disease, all of this stuff. It's the single most adaptable thing, which is why the American College of Cardiology gets so into this, and so into the definitions and sort of what approach we should have. So what they did with this last set of guidelines, and they have a guideline that they update on a regular basis, is they added a couple new things to the definitions. And I mentioned this yesterday in the vital signs talk, but they added this concept of white coat hypertension, that people can have stress-induced bumps in their blood pressure that turns out is not necessarily benign. So the reason that they brought that up is that if someone really does have, every time they go to the doctor's office, their blood pressure up, but at home it's okay, that means that during whatever stressful events they have, their blood pressure can be bumping up, and that can have a long-term outcome problem. Same thing with what's called masked hypertension, where as they just randomly check their blood pressures at home, they will find that sometimes it's up and sometimes it's not. It's the same concept, where they end up with hypertension that just isn't picked up at the office, but is picked up when they just check their blood pressures at home. For us, that doesn't really have a lot of impact, but it does mean that they're trying to do their best to kind of gather the people who might be at risk to help us figure out which people we should actually help with. And one thing to know that for all of these guidelines is the first thing to do for somebody who has an elevated blood pressure is not to put them on a medicine. And in fact, what you're supposed to do if you're office-based is, okay, today your blood pressure is high. I want you to cut back on your salt, start to exercise, maybe lose a little weight. Let's check it again in a month. And we'll check it again in a month. And if all three of those times you're still elevated and you've tried to do these lifestyle things, now we'll call you whatever category you fall into, and we'll consider meds at that point. So I think because we're in the emergency department and we're sort of fix-it people, it's hard for us to realize that sometimes all we need to do is say, your blood pressure's up today. While you're getting an appointment with your physician to double check on this, you might want to watch your salt intake, get a little exercise, and maybe consider weight loss kind of thing. And by the way, the weight loss thing is huge. It turns out that if somebody is overweight, and this includes overweight or obese, your BMI you can divide into overweight or obese, it turns out if that person who's hypertensive loses only 10% of their body weight, a very significant portion of those hypertensive people become not hypertensive anymore. So it turns out weight loss is an extraordinarily impactful thing, way better than pills can be. It can take them totally out of being hypertensive at all. Now, these are the definitions that came out in the last set. You will notice that they have normal, if you're sitting here with a blood pressure of 118/78, you have normal blood pressure. Good for you. But if you're sitting here with a blood pressure of 122/82, you have basically an elevated blood pressure. Now, they don't call you hypertension yet. They don't call you hypertension until you get into the sort of 130/90 range. Now they'll call you hypertension stage 1, and if you sit over 140/90, now you're hypertension stage 2. So if you have in your head 140/90 is the cutoff for hypertension, that has changed. And what this definition does, so you know, is basically classifies more than half of Americans, half of adult Americans, as hypertensive, or as elevated blood pressure at least. So what they're trying to do, again, I think the point of this is not to sell drugs and not to put patients on, it's not pharma going wild. This is basically to say to somebody, your blood pressure is a little up. Your blood pressure is 129/85. You probably should have it a little lower than that. So let's talk about how do you live? What's your weight? What do you exercise? What's your salt intake, et cetera, to kind of help people focus on that. The whole point, again, is this is a very adaptable thing that we can fix and really address that will really impact somebody's health. So that's the whole reason for all these categories. Couple things for us in the ER. We talked yesterday about making sure that the cuff we use is the right size, to make sure it's not too small, because too small will make it falsely elevated. And to also know that people are people with hypertension, a lot of them are who are into their hypertension, who understand it, have the measuring thing at home. They will often correlate symptoms that they have with an elevated blood pressure. You've all seen it. Person comes in with a headache and says, my blood pressure is high, this headache must be from my blood pressure. You need to understand that when they've looked at research on this, when they've looked at the correlation of the headache complaint and the patient's blood pressure, when the patient doesn't know what their blood pressure is, there is no correlation. But that being said, I really think that people do know their bodies. Some people know their bodies extraordinarily well, and somebody might come in and say, every time my blood pressure hits 160 over 100, I get a headache. That's cool as long as you pay attention to the headache as a separate complaint. Don't blow it off to that elevated blood pressure if it's abrupt onset and severe. That's like, oops, you have subarachnoid, and oh, your blood pressure was also up as well. So separate the two out. Don't attribute one to the other. And don't treat the number. I'm sorry to beat this to death, but treat the patient, not the number. Because it's the end organs we really care about acutely in the ER, and so the number really in and of itself shouldn't be the driver. Now, what they did in this guideline that I really take umbrage with is they defined a blood pressure of a greater than 180 over greater than 120, either one of those. So diastolic greater than 120 or a systolic greater than 180 as a hypertensive crisis. They use the word. That's not true. That is completely misleading, and it leads us to this idea that we need to abruptly bring down somebody's blood pressure just because of a number. It's not the number that makes a difference. What makes a difference is the end organs. So this is extremely controversial, and don't go crazy with a single number. What you really want to do is look at those end organs and see if there's a problem with the end organs. Now, if somebody comes to the ER, and let's say their blood pressure is 170 over 110, definitely high, definitely high. They have a history of hypertension, definitely high. What you don't want to do is go charging ahead with 1 billion tests. Oh my gosh, you're sitting here with an elevated blood pressure for an ankle sprain. I'm going to get an EKG and a chest x-ray and a renal function and a UA. Don't do it. ASAP has a guideline they put out probably five years ago or so, half a decade ago, that basically says do not chase the number. If somebody is asymptomatic, that's fine. Note the high elevated blood pressure, make sure that they're taking their meds appropriately, make sure they have follow-up, but don't go crazy treating the number. Just don't do it. Treat the patient, not the number. And don't order 1 million tests for it either. If the person comes in saying, I'm having chest pain, and their blood pressure's up, certainly go ahead and do the chest pain thing. But otherwise, please do not order 1 million tests. It turns out that it doesn't really help you at all to do so. If you get an EKG, it may show LVH. What am I going to do with that? Most chest x-rays are completely normal. Even if their heart's a little big, what do I do with that? So make sure that you don't have to order tests. Now, there are true hypertensive emergencies that we are going to focus on. So what this is a severely elevated blood pressure, not just 140 over 90 or 140 over 100. This is 190 over 140 and end organ damage, or 190 over 130 and end organ damage. And when your blood pressure is that high, especially acutely, your heart suffers, your brain suffers, your eyes suffer, and your kidneys suffer. Those are the end organs we know chronically can be a problem, and acutely, if somebody's blood pressure goes up acutely, can definitely have issues. So let's talk about the kinds of things we see. We see encephalopathy, I'll tell you that's extraordinarily rare. Absolutely happens, but rare. That is not as common as it was before we were really aware of blood pressure in this country. Stroke syndromes you heard about. So Britt told you about the stroke syndromes, and that's one of the things you can see with elevated blood pressure. You can see acute pulmonary edema, but that is usually not the blood pressure that caused that. That's usually the heart had a problem, the person went into acute pulmonary edema, they're drowning, their catechols go sky high, and they have elevated blood pressure with it. So it is usually, we often have the chicken and the egg there. Did the blood pressure make it happen? Did the heart disease make it happen? 99 times out of 100, it's the heart disease that started first, flooded the lungs, and now the blood pressure is up. We'll talk about how to approach that in a second. You got a little bit of information from Rick. Aortic dissection definitely is a hypertensive emergency. You do not want a high pressure head going through a tearing aorta. You don't want that to happen. So we'll talk about that too. That is a true hypertensive emergency. Renal failure, acute renal failure from hypertension is extraordinarily rare. But what can happen is somebody who has chronic hypertension with renal disease gets a bump in their blood pressure, and they can take what few nephrons they have left and really tip them over. Just renal failure is more of a chronic problem with hypertension than it is an acute hypertensive emergency. And then we know pregnancy has its own things. You're going to hear from Jan Schonberger about this. But hypertension in pregnancy, preeclampsia, eclampsia, all of that stuff happens in pregnancy, a very unique situation. And children's blood pressure should be low. And you can look at whatever age they're supposed to be, but no child should have a blood pressure of 140/90. That is like alarming in a kid, no child. And children don't get hypertension. They're getting more now that they're more heavy, but the reality is most kids don't get hypertension. If they do, it's usually nephritis, renal vascular disease, or they have some sort of thing like a PHEO. So hypertension in a kid is rare. It's the adults that this happens to. So malignant hypertension, which is actually kind of not really the right term. What we really want is the end organ that's involved to call it hypertension. This is basically malignant hypertension with some bad end organ problem. It's really not defined by a number. It's defined by the end organ deal. But if you do end up with an end organ, particularly the brain, that's involved, you are going to want to get that blood pressure down relatively quickly because you see this end organ problem. And you're going to do that in a titratable way, and you're going to drop the MAP, the mean arterial pressure, by about 30% in about an hour. So and we'll talk about the syndrome specifically in a second, but that's kind of your goal. And you have several drugs to choose from, which we'll also talk about. True hypertensive encephalopathy is uncommon but can occur, and there's a syndrome called PRES, posterior reversible encephalopathy syndrome, which actually, this is somebody who basically sits around at home, gets a little confused on Thursday, a little more confused on Friday, and on Saturday, they're unarousable, they're comatose, they're really encephalopathic. That's somebody whose hypertension got to the point where their brain can't do it anymore. They can't autoregulate anymore. Those people, by the way, on CT scan have posterior changes. They have basically white and gray matter changes posteriorly that reverse when you bring the blood pressure down. And that altered mental status, when you bring the blood pressure down, reverses very quickly, within a matter of hours to the longest is a day. They end up really reversing. That is an acute encephalopathy from elevated blood pressure. That's treated with nicardipine usually, sometimes nipride, sometimes labetalol, but usually nicardipine. Hemorrhagic strokes, also you guys heard a little bit about. Ischemic strokes you heard about, I'm not going to focus on that. Jan is going to talk to you about the pregnancy-related stuff, but the drug here is hydralazine for the most part, sometimes labetalol, but usually hydralazine. And again, this is an emergency, and Jan will get into the details of this, of preeclampsia and eclampsia with you. The cardiac stuff you heard a little bit about from Rick. So people who have congestive heart failure, acute decompensated congestive heart failure, or who have ACS, I'm having an MI with this, and my blood pressure is sky high. The treatment for that is nitroglycerin. Not nipride, nitroglycerin in high doses, especially for CHF. We're talking high doses. We're starting at 100 mics or even 200 mics, starting really, really high for this if the blood pressure is really high. It is like magic. You will take somebody who looks like they're going to drown and die, and 5 minutes later they're doing, Sudoku puzzles. They look like a rose. So but it's high doses of nitro, IV nitro for that. And dissection, where my two walls of my aorta are splitting. My intima is pulled away, and I'm splitting down that muscularis wall. I'm basically dividing my aorta, splitting it, like taking a Ziploc bag and opening it up. I want to decrease that pressure head. And I need to do that with two things happening. I need to not only decrease the pressure hitting there, I need to decrease the number of times it's hitting it. So I need to slow the heart down, and I need to decrease the blood pressure. So that's why a lot of people will default to something like labetalol for that, because it actually gives you a little bit of both. But if not, then you definitely need to use something like esmolol, short-acting beta blocker first, so I don't get a rebound a rebound tachycardia from dropping somebody's blood pressure. So first, beta block, then add whatever antihypertensive med you're going to use. The choices you have include sodium nitroprusside, which has been around forever. It works beautifully, works great, has a few downsides. It's very titratable, but it has a metabolite that's toxic. Thiocyanate is actually a metabolite that's toxic. Fortunately, most of the time that is not an issue. That takes a while to build up in somebody's system, but this is something you can absolutely use if you're comfortable with it, good to go. It can cause this reflex tachycardia though. So again, with dissection, you're gonna block them first and then add this. Labetalol is a beta blocker. It's a beta and an alpha blocker, and I will tell you it is primarily a beta blocker. It also has some alpha blocking effect. So you kind of get a double whammy there. That's why people choose this in dissection, because you get it beta blocking, slow the heart rate down, and the alpha blocking, dropping the blood pressure. Has a half-life of about 5.5 hours, doesn't cause reflex tachycardia because it's a beta blocker. So this is something that's not a bad choice at all in people that have a dissection, unless they have terrible asthma. Remember, it's a beta blocker, and we get kind of complacent sometimes with our beta blockers, but if somebody has really bad asthma or really terrible cardiac squeeze, terrible, it basically HR, HF-ref, heart failure, reduced ejection fraction, that person has no squeeze left, it's not great to use this beta blocker. So labetalol is fine. Dissection is probably its biggest use. Not a bad choice there, just be careful of the contraindications. And the drug of du jour, the drug that we all love these days, the drug our neurosurgeons think walks on water, is nicardipine. So this is basically a calcium channel blocker. It works great. It's titratable. It kicks in really quickly. It lasts an hour to 4 hours. It's actually a fine drug to use primarily for hypertensive stuff. Great in the brain for sure. And it actually probably would be fine for even something like PRES, posterior reversible, the encephalopathy that goes with this. So you have choices in medicines here when it comes to treating somebody acutely with hypertension. And remember, most cases of somebody with an elevated blood pressure in the ER, you're not going to go anywhere near these drugs. It's the person that has those end organ things that tells you you need to do something about it right now. So to put it together, you're going to treat the patient, not the blood pressure. Okay, most elevated blood pressure in the ER, you're not going to do anything about except note it, make sure the patient has follow-up, and talk to them about lifestyle changes. Know which are the hypertensive emergencies, we just talked about that. And it's probably best to write on the chart elevated blood pressure rather than hypertension, especially if it's new. If somebody knows they have hypertension, that's fine. But if it's a new thing, the reason for that is that insurance companies still own the world. We still have protection for pre-existing conditions at the moment, but I don't know if that will stay. So it's probably best to be as accurate as you can be, which is just elevated blood pressure for today. And then as far as outpatient meds are concerned, I used to give outpatient meds all the time in our system because we had no place to send anybody for a long, long time. When the ACA came in, we actually suddenly had medical homes for the patients that we took care of. They actually had doctors. So we had patients, people we could send them to. So I don't give meds as an outpatient anymore because I have a place to send them. You're fine to do it. Just make sure you know what you're doing when you do it. It's not rocket science. You can start with a low-dose diuretic. That's safe in virtually everybody. But it's up to you to decide if you want to give meds or not if you're discharging somebody you think truly has hypertension. All right, that's hypertension. Let's switch over to syncope. And I want to first of all, basically, please do not shoot the messenger on this when it comes to syncope. I do not have a magic answer for you, a wonderful algorithm that is perfect all the time for syncope. It just isn't. And syncope ranges from benign, we know, the person who watches blood get drawn and passes out, to truly kills you kind of syncope, life-threatening syncope. It is really, really tough sometimes to differentiate between the two. We're really good at some. We're really good at the, oh my gosh, it's clearly you've had a PE, that's why you had a syncopal episode. Or, oh my gosh, it's really clear that you fainted because you were standing at your kid's graduation for hours. We're good at those extremes. It's this blob in the middle where they have a couple things that are concerning, and we know that there's still some risk of death in that group that we have trouble with. Because there is no good decision rule out there to help you, decision tool to help you with this, and there isn't, there are too many of them out there that tells you none of them works well, you're gonna have to be a good, astute clinician on this. You're gonna have to go back to using your logic and using what you know medically, really important. So these decision rules that are out there, and there have been so many, San Francisco syncope rule completely fell off. That didn't work. That none is really highly accurate. I'm gonna tell you though why some of them are helpful to you in a minute at the end of this thing, but just know there's no magic one here for you. There's no algorithm like we have for PE, where when I do miss it along the way, I have a really good system where I got there that's validated and it's been looked at and the research is great. There's nothing when it comes to syncope. There just isn't. It is important to know the causes. Now, there's a mnemonic that some people like called pass out for remembering the things that cause people to syncopize. And this encompasses all kinds of syncope. Okay, I'm going to tell you at the end of this, the one that I like to remember the things that kill you. But this is pass out. So one is pressure. So anything that causes vasovagal problems, so I watch somebody get their blood drawn and I pass out, and by the way, that is probably 30 to even 50% of syncope is some sort of vasovagal related thing. So, and that's benign. As long as they don't fall down 25 steps when they faint, that's benign. Orthostatic hypotension is common, particularly in the elderly. And we do this with medicines with them. So they get a new dose of nitroglycerin, or they get put on another medicine that's a vasodilator. The common one of these, by the way, is an older gentleman who ends up with BPH, who gets put on tamsulosin for the first time, goes home, stands up, that alpha blocking agent makes his blood pressure fall through the floor, and he faints. So this is often something we do with a medicine to people. So check meds when somebody's had a syncopal episode. Check their meds and see. We know volume loss will do this. Occult bleeding will do this. So this is the person who's had a GI bleed and they don't have melena yet, or they don't have bright red blood per rectum yet. They've had the GI bleed and they passed out. That can occur definitely. Dehydration too. And then the situational stuff. The person who has micturition syncope, when they pee, they pass out. The person who has carotid sinus sensitivity. My favorite case of this was a guy who came in and he said, I get really lightheaded and feel like I'm going to faint every time I'm driving. It's like, well, you probably shouldn't be driving, but tell me more about that. He said, well, actually, it's not when I'm driving. He said, it's when I'm backing out of my driveway. It's like, wow, really? Why? He said, well, when I back out of my driveway and I'm going like this, I get really lightheaded. And I'm going like this, and I get really lightheaded. I said, what do you wear to work? He said, I wear a tie, a shirt and tie. It's like, you've got a tie and a shirt, and you turn and you push on your carotid sinus every time you look over your right shoulder. This is where backup cameras may have totally taken that out of the loop, where people could just look at their camera, but he told me what was wrong. He basically told me. But it was awesome. It was just great. So that's considered a form of situational syncope. The thing we worry the most about, honestly, is arrhythmias, right? That is the thing we're terrified of. We're really worried about that drop-dead 30-year-old Asian guy who has Brugada. That's the thing we're worried about. That's the syncopal person we really just want to try to catch. So we'll talk about the dysrhythmias in a minute that we have to all really look for specifically in a syncopal patient. Now, one of the differentials of syncope is seizure. And I'll tell you, one of the things the reason that's a problem is that when people have a syncopal episode, and you've probably seen this in your practice, you may have even seen it in like a pre-arrest person, they will often get rigid and even jerk a couple times as they syncopize. Okay, that looks like a seizure to somebody who doesn't know what they're looking at because they're moving, right? They're jerking and they're moving. So that can be interpreted by a witness as a seizure. Sometimes we can't tell. All we have is the person who was down, now is fine, and we have to try to figure out, was that a seizure or was that syncope? One of the best things you can do to help you with that is if somebody is post-ictal. A syncopal person usually wakes up right away and they're with it. A seizure person is usually a little groggy for a while. And if you get a history of a post-ictal state, that's virtually always a seizure. That's what caused that episode. Things like urinary incontinence or tongue biting or cheek biting can be helpful, but the clearest thing is a post-ictal state, because people can have a syncopal episode and have incontinence. That's not common, actually, but they can. They can bite their tongue or their cheek depending how they fell. So just know that the most helpful thing there is basically the post-ictal state. Sugar. We absolutely know that people who get hypoglycemic can have a syncopal episode. They absolutely can, which is why anyone in your practice, anyone who has altered mental status, syncope or a seizure, should have a sugar checked. Just routinely. Just do it routinely. You'll be amazed how often you find their sugar is low. So make sure you check a sugar. That's the other S of pass out. Output, cardiac output is also a problem here. So people can have a syncopal episode because there's some problem with their heart getting blood out. The valvular disease that does this is aortic stenosis. And it turns out that the trio of symptoms of chest pain, shortness of breath, and syncope in somebody who has aortic stenosis means they will die within a year if they have all three of those and they don't get that valve fixed. Syncope is, and what happens is that their bodies need, their brains need for blood and oxygen can't be kept up with by this tiny valve that's getting tinier and tinier and tinier, so they pass out. So you can hear that, you can listen for that. So listen, your exam in a syncopal person is gonna include a really good cardiac exam. You're going to listen for aortic stenosis on purpose. That crescendo, decrescendo murmur, you're going to listen on purpose for that thing up here at the top of the heart. MIs definitely do this, right? Somebody has an acute MI can do this. Dissections can do this. So people can end up with output problems, cardiac output problems because of, and dissection, by the way, when that happens is usually a dissection that comes back, ruptures into the pericardium, and they end up with tamponade. That's the thing that usually happens with that dissection. The other output thing, though, is PE. It's actually an input thing. I have a big enough problem that I'm not getting blood through my heart here, that can also cause syncope. Again, that's rare as an isolated symptom. Usually there's other things that go with it. A big leg, I'm short of breath, I'm tachycardic, usually something else with that, but that's the O part of the pass out mnemonic. Then there's some unusual things, some transient things that are in there as well. I really like to I think of this as a pumps and pipes problem. The things that I really care about that might kill somebody is a pump problem or a pipe problem. The pump can either have a rhythm issue, so that's a rhythm problem there. It can have a distensibility issue. It can basically have I just don't put out enough issue, so it's like an output problem. Or I can have a valvular issue. So my heart can have those three things. Sometimes tamponade too, but basically those three things. The pumps thing is they're either a pipes thing, the pipe is torn, aortic dissection, the pipe is leaking, I'm having a bleed, or the pipe is blocked, I have a pulmonary embolism. So I think about the life threats as the pumps and pipes. The pass out gives you the entire differential here. But I keep my pumps and pipes as my life threats to make sure I keep track of all of those things. So keeping those differentials in mind, those things that can happen, your history exam and EKG are really the vast majority of the things that you need to figure out what's wrong with somebody. And your history is going to include things you might not otherwise think about. So now when you go back to work after this course, your history is going to include asking them about chest pain, asking them about shortness of breath, asking them about meds, right, if their meds have changed, recent illnesses, prodrome, did you have any warning this was happening, family history of sudden death, right? You're going to ask that now. Remember, Brugada is a familial thing. You're going to ask and find a nice way to say it. It's kind of terrible to walk up and say, "Did anybody like drop dead in your family?" You just don't know why. It's probably worth saying something like, "Did anybody in your family ever die and nobody really ever knew what happened? And was it anything like that happen in your family?" Find a way to say it's nice. And then your exam. Your exam in a syncopal person needs to be really good, and it needs just to specifically focus on a couple of things that you're going to document on purpose. So the heart rate is key. Is it regular or irregular? You're gonna check that rate. You're gonna listen for it. You're gonna see what that rhythm is. Is it sinus rhythm? Do they have a run of V-tach? Find out what their rhythm is, and find out about those murmurs. Remember, aortic stenosis. You're gonna listen for on purpose. On purpose. Listen in the carotids for bruits. Do a good neuro exam. Syncope is a big deal. And to catch those things that can cause syncope, you need to do a good exam. And then you're going to get the EKG. And on that EKG, you are specifically going to look for and document that you looked for certain things. Ischemia for sure. Remember, ischemia can cause people to have syncope. Dysrhythmias for sure. You're going to look at those. Do they have blocks on there? Is there any evidence of a block on there? Oh my gosh, I see that they have a P wave with no QRS. Maybe this is type 2, second degree block. Maybe that's what's happening here. Intervals in particular. Look at the QT interval. A long QT, and go ahead and look up in the box at the top that tells you what the number is. A prolonged QT greater than 480 milliseconds, definitely more than 500, you should raise an eyebrow about. There are it's another familial thing, familial syndromes of prolonged QT that basically, it's the reason we're not supposed to go randomly giving droperidol, for instance, because you can actually cause someone to go into cardiac arrest, which is their syncopal thing. That's the problem. So you're also going to look in the intervals for a short PR, maybe that's your indication of WPW. We talked about that. So you're going to look for that as well. You're going to look for hypertrophic cardiomyopathy, which gives you really dagger Q waves. You'll see it's like, wow, these really deep Qs. What's up with that? And Brugada, which we talked about. That funny looking, almost right bundle branch block pattern in V1. You're going to look for that. And you're going to say specifically, examined EKG, no evidence of prolonged QT, Brugada, short PR, boom, you're going to document exactly what it is, because that means you looked for it. The biggest killers are the dysrhythmias. You look for it. Please do not routinely order a head CT scan for people that have syncope. Please don't do it. If they have a neurologic finding, either before or after, a true, like a hemiplegia or a bad headache, that's fine, go ahead then. But it turns out the yield is extremely small if it's ordered just routinely. Please don't do it. Now, as far as rules to help you, there have been a lot. There have been more than a handful of these things. The one that's currently de jure is the Canadian syncope rule. And it is, the Canadians are really good at these decision aids out there. And this one seems to be panning out. I am not going to belabor it though, because I really need this to be a little more ready for prime time before I'm going to put any real stock in it. It has been validated and it has been tested outside of the system that developed it. It seems to be having some traction, but just know it's there. Don't base anything in your practice on it yet, because I don't think it's quite ready. Now, this horrible, awful, icky, my God, what are you kidding me, algorithm is actually not so horrible and icky. In the syncope patient, we only deal with the top half of this algorithm. Everything else is our colleagues in cardiology or wherever else. In this top half of the algorithm, what you're going to do is if you know for sure what's wrong with somebody, why they had a syncopal episode, I saw blood drawn, I fainted, I had palpitations, I fainted, my EKG is really abnormal, whatever, I'm going to go ahead and do what I need to do in those people. Done. Easy. If it's suggestive, gosh, your EKG isn't exactly normal, a couple symptoms that you have that make me worried, you have a family history of sudden death, I'm worried about this, you're going to go ahead and do any additional testing that's necessary, but you're going to basically usually keep those people around. And if you don't know why, I have no idea why you had syncope, break people into 3 groups. If somebody basically has organic heart disease, they have heart disease and they had a syncopal episode, assume the worst, always. Please assume the worst. If they're older, assume the worst, always. Please assume the worst. Syncopal, if you're just not sure, if you're sure of what it is, that's one thing. If you're not sure, that's people you're going to be worried about. You are going to keep in the hospital, or at least get into OBS with consulting. People that have suggestive stuff where I'm really worried it's something bad, I can't confirm it, or people who have organic heart disease, and maybe even people over the age of 60. And you're using your smarts here. There's no decision rule that's telling you this, you're using your smarts. So the disposition of a syncopal patient, most people go home fine. H&P, EKG, you've convinced yourself it's whatever that's benign, no big deal, fine. Decision rules in general miss some serious cases, so I don't put all my stock in that, but the things that they derived to use in the decision rules have some validity. So, older patients with really bad coronary artery disease or congestive heart failure, those people I'm going to worry about. New anemia, wow, your hemoglobin was 12 2 weeks ago and it's 8 today. Maybe they had a GI bleed that caused this. Pacemaker patients, a pacemaker patient who faints needs to have that pacemaker interrogated. We used to admit them all. What they need to do is somebody needs to come in and interrogate that pacemaker and see what happened in there so we can figure out what's wrong. So pacemaker, they need interrogation at least, if not admission. Concerning EKGs, consider keeping them around. And abnormal exams, of course you're going to keep them around. Aortic stenosis and they syncopize, certainly. Bruising, they syncopize, certainly. Do the right thing for these folks. So the best decision rule for you is using the brain that you have with the knowledge you have and a logical approach using H&P, your EKG, and you're good to go in most of the cases. That is it for me.
I want to thank you, Diane,
Yes.
for being with us.
I'm going
Diane is
home.
our co-director, and she's out of here for a big family event.
I'm out of here because tomorrow morning I get my second grandson. I'm very excited, so I'm going.
Thank you.
Bye, Andy.
Martha.
Bye, Diane. Thank you. All right, let's have some fun. We're going to switch gears. We're going to talk about pediatric rashes. Tomorrow, Chip is going to talk to you about some other rashes in adults as well. But today we're going to talk about viral exanthems. This is the time where you want to bring a friend into the room again and say, take a look at this rash. What do you think? I need a second pair of eyes. Does this look like roseola to you? Does this look like rubella to you? Does this look like Kawasaki's to you? The key to pediatric rashes is knowing the bad ones and knowing the ones that need treatment. And then, of course, how to prevent certain ones with vaccines or other ways to do that. So we're going to talk about a few of these. The first one we're going to talk about is that poop oven, right? It's basically a diaper that causes a contact dermatitis. That's diaper dermatitis. What do they say? Once an adult, twice a child, right? So you start in diapers, you end in diapers, I guess if you're lucky, right? And it could be a lot worse. This is the dermatitis that is caused from urine, the dampness, feces, kind of just sits in there and bakes. Sounds great after lunch, right? So sometimes oral antibiotics can predispose this and cause this. Basically, you can get a secondary infection from this, a MRSA infection, and then you're going to need to treat that not only with topicals that we're going to talk about in a second, but also with oral antibiotics. Candida infections are very common. They have these papules, these little satellite lesions that go to various parts on the buttocks, and I'm going to show you some examples of that as well. The first treatment is to dry, clean, and breathe. So you got to get these kids to have a little naked time, have them run around and get that diaper off. Or maybe you have to put a sheet down for them. But really, the best thing you can do is keep that diaper off and keep them dry. There's some barrier creams that you can use for the future. But also, if you want to treat the fungal infection, you can use meconazole or clotrimazole. If the mom comes in the first time and the rash looks a lot like this in the top 2 pictures here, you can start possibly, you can see some of those satellite lesions there with the diaper dermatitis. If it looks like the lower one, you're going to need to go to steroids and potentially treat this for MRSA for MRSA. But really, I would reserve steroid treatment for the second or third visit and not the milder cases. All right, so let's talk about scabies now. This is the severe pruritus that comes from these little mites that bury into your skin and then more pooping under the skin, all right? So we start off the talk here with poop. This is what causes the itching, the feces from these actual scaby mites. That is what's causing all that concern. They like to bite and kind of get you in those areas of your web spaces. So between the fingers, in the folds of your skin. And a really bad case of scabies is this Norwegian scabies. You ever have one of those homeless patients that comes in and they have this rash that no one's ever been able to figure out. It just looks really bad. And you're like, God, that looks awful. And they're constantly itching. It's probably Norwegian scabies. I have a good picture of that coming up as well. A picture can tell 1,000 words, right? The treatment for this is the permethrin cream. You can also use oral ivermectin, and there's some other treatments out on the market. But the thing about this that you need to tell patients is that the itching can last for 2 weeks after treatment. The mites might be dead, but they could still be itchy. The other really important thing that you need to tell patients is that you do the first treatment, and you treat yourself with the permethrin cream from the neck down, avoiding the face and the genital region. Then you take your shower, you put the cream on from the neck down, you go to sleep. You wake up in the morning, you take a shower, you wash it all off, wash your sheets because the scabies mites can live for up to 72 hours. And then you go on with your life, okay? Don't burn the house down yet. You basically wait 2 weeks after that and do an additional treatment, same steps again. Now, this is a great smart phrase that I have for patients because that's a lot of steps, a lot of things that you have to tell patients to do. So maybe that's a good one to make a smart phrase for in your paperwork. This is actual footage of me this morning. Okay, some scabies skin lesions. You can see this Norwegian scabies in this patient here, really just excoriated. He's scratched, and now the skin is just scarred over. And then the linear burrows of the scabies infestation. Okay, pediculosis, lice, delicious. Oh my goodness, they just love your hair. They love anything that's hairy they can climb onto. They hang on to that shaft of the hair, and that's how you make that diagnosis. You're not going to see scabies. You're not going to see the little bugs. And the scabies, they don't like to go in the hair. They don't like to go in the face. They like other parts of the body where they can kind of go into those crevices. So lice, these little black nits that you'll see on the hair, sometimes they're gray or translucent. They can be anywhere where there's hair. So if you have hair up here, they're here. If you have hair down there, then they're going to be there too, right? So it's possible to get pubic lice as well as body lice. The treatment is extensive cleaning of the clothing and putting the bedding in the dryer. Real hot heat helps get rid of that. And you can use RID or permethrin, again, the nicks. Same type of deal for the treatment of leaving it on, washing it off. Now, you don't need to repeat this in 2 weeks like scabies. It's just a one-time deal. They'd be dead. Here's a good picture of what these little lice nits look like on the hair shaft here. And let's move on now to our classic childhood exanthems, our viral exanthems that we have typically a fever and then a rash. Now, back in the 1700s, we started naming these rashes 1, 2, 3, 4, and then we got to the 4th disease, and Dukes was like, yay, I found another rash disease. Turns out it was just scarlet fever again. So we had to stop giving them numbers. We actually gave them names. These probably sound familiar to you. Measles, scarlet fever, rubella. Dukes disease, like I said, is just repeat of scarlet fever, which is associated with strep. We're going to talk about that. And then, of course, there's Fifth disease and roseola. Let's first talk about the measles. I don't want to spend too much time on the measles because as the time has gone by, we didn't vaccinate for a little while, but then we got back on the train and seemed to get vaccines back in place for measles. But there were a lot of outbreaks. It is still there, unfortunately. And, when people ask me, vaccines can cause really bad things, right? Vaccines can be terrible for you. You know what I say? Vaccines cause adults. That's what vaccines do. They cause adults. So if we just continue to vaccinate for this, we're not going to see it. There is a small percentage of patients that still might develop it despite the vaccine, but it is a tiny, tiny percentage. So measles, fever, cough, conjunctivitis, and coryza, so rhinitis or runny nose, the 3 C's. A couple of days before you get this rash, you develop these spots called Koplik spots in the mouth. They're non-tender. They're in the buccal mucosa. They're tiny white-gray bumps. Every time a patient comes in with a rash, you should always be looking in their mouth to take a look. It should be a full body scan. They should be in the gown. You should look in their ears. You should look in their mouth. You should look at their whole body. It's super important. This rash is a macular-papular erythematous rash, and it starts from the head, starts and spreads caudally. It's initially blanching, but then later you can't. It just kind of stays red. This is just symptomatic treatment. The problem is that there are some serious life-threatening complications that come from measles, including encephalitis, pneumonias, even otitis media and conjunctivitis can be troublesome for many people. So they'll get this conjunctivitis. They're not going to have any purulent discharge, just these red eyes. Here's an example of the rash. Very classic picture of that little baby up in the top right corner. Again, the back, that is a perfect example. These are all exactly what measles looks like. And I'm going to show you a couple of pictures of chickenpox at varicella towards the end, which is a totally different looking rash. And once you've seen that you will not get them confused. You will remember. But I'm not going to confuse you now with varicella. But this is the measles rash, rubeola. Again, examples of the Koplik spots. They can be a little insignificant, kind of hard to pick up, so you really have to look there back by the molars. Get your tongue blade in there and open that kid's mouth up if they're not already crying or trying to spit at you. Again, just more a little about the outbreaks. This is prevented with the MMR vaccine, measles, mumps, and rubella. And what we found in 2019 that there were quite a few states, almost 30 states that developed cases, and about 1 in 1,000 cases are going to develop things like encephalitis, which cause brain damage. 2 in 1,000 kids are going to die from some kind of respiratory or neuro complication. And then there's this subacute sclerosing panencephalitis that is very rare, but it can occur years later, decades later. Just some statistics about where we were at with measles and how we saw this rise in cases due to unvaccinated children and families. And the CDC wants you to report anytime there is a case. And they specifically say healthcare providers should consider measles in any patient presenting with a febrile rash illness that's clinically compatible with measles symptoms, especially if the person has traveled internationally or was exposed to a person with a febrile rash illness. So this needs to be reported, and it needs to be done within the first 24 hours. So lab testing for this, very specific IgM antibody, which is a blood specimen, and then there's also a measles PCR test, which is a respiratory specimen. There is also a urine test that is not as accurate as the other two, so caution that, but if that's all you got, that's all you got. If you are exposed, what do you do? If you're a healthcare provider and you're like, oh my gosh, I just had a kid with measles, what do I do now? Well, you're going to get some PEP, this post-exposure prophylaxis, and that is the MMR vaccine within 72 hours of the exposure. Or you can get IG within 6 days. You can't do both, don't want to do both, just pick one or the other. And maybe people's time frames are a little bit off. Maybe it's 4 days. Maybe it was 2 days. Sometimes they don't really know. Just give them the MMR. And if you have any concerns, you can always talk to infectious disease about this. There's going to be someone on call that you can discuss it with. And people always get really excited because they haven't seen measles in a while, which, is a good thing to not see it. Let's talk about rubella, which is the German measles, a little less severe, but still an annoying febrile rash illness. This is a pink pinpoint macular papule 3-day measles-like rash. And you get a low-grade fever and this lymphadenopathy. Some of the complications from this type of rash can be arthritis from the virus itself. You can have encephalitis. And then, of course, we have these concerns, the torch illnesses that affect our pregnant women. That's toxoplasmosis for T. Other is syphilis, the parvovirus. R is for rubella. C is for cytomegalovirus. And H is for herpes. So these are all things that we are concerned about in our pregnant patients. They can cause serious congenital defects. Again, treatment symptomatic. Here's a good picture. See, a little less severe than that rubeola rash. Here it is, very light on the skin on an adult patient. Okay, moving on to scarlet fever now. This is a very specific toxin that's produced from group A beta hemolytic strep. So you get strep throat, you get a fever, and then you get a rash. It is a sandpaper-like rash. It starts within 12 to 72 hours after the fever. So asking patients, again, this is key to your diagnosis of rashes. Getting a good history, time of onset, associated symptoms, and knowing the severe key words that say, oh, this doesn't sound good. Because 5-day history of fever, we're thinking Kawasaki's and something totally different, which we're going to end the talk with. So stay tuned for that. But scarlet fever, it causes the sandpaper rash and these flexor creases, these pastillas lines, which I'm going to show you, this Romanian doctor that named them. It moves to the trunk and the extremities. They get this strawberry tongue, and then they get this peeling of their skin on the palms and the soles. It doesn't look like it hurts, because it doesn't, but it looks almost like when you put one of those foot treatments on and your skin does that natural peeling. It's not really itchy. It's almost unnoticed sometimes by patients, which is very different than something like a Stevens-Johnson syndrome where the skin is peeling off and it's painful and red. And we know Stevens-Johnson syndrome is a reaction to a medication typically, and the body's immune response goes all out of whack. But for scarlet fever, you're not having that crazy burning skin. This is a less severe desquamation of the skin. You diagnose this with your throat swab, or you can use the ASO titer. The treatment is oral penicillin for 10 days or a single shot of bicillin. You know, there's a debate all the time about should I give the shot, should I give the pills. I'm a big fan of the shot. I think that it's a great treatment. It's hard to get someone to take antibiotics for 10 days, but you do get to give the patient and the family a choice. Here's a good example of the strawberry tongue and that sandpaper-like rash. These are the pastillas lines. They kind of look like creases, not to be confused with the scabies rash that are the little bumps. This is the kind of like crease marks where you would bend your arm. Here's an example of the desquamation. Can be subtle. There it is on the feet. Also can be subtle. Again, that's why you're taking your patient's clothes off. That's why you're looking at the whole body. Okay, fifth disease. This is caused by the parvovirus. Again, one of our torch issues for pregnant women. So if a woman comes in and you're thinking that this could be fifth disease, erythema infectiosum, then you're going to have to worry about mom. All right, because if she's pregnant, then you're going to worry about her and what this could potentially do for birth defects. But regardless, the symptoms of fifth disease could be a fever, but not always. They might have myalgias, diarrhea, upper respiratory symptoms. Is typically in preschool age children. The rash is an abrupt onset. It comes right out on the face, the slap cheek of the child just kind of appears, and then it spreads to the arms and the legs on the second day. It's almost lacy-like. This is that lacy-like rash that goes on the limbs and the trunks, and it may come and go in about 1 to 2 weeks. Self-limiting, symptomatic treatment. Here's a great picture of that rash and that slap cheek appearance. Roseola infantum overview here. Okay, so again, this is another rash that's caused by the herpes virus, not the herpes virus that's caused for shingles or chickenpox. And it's really important that you tell patients, families that. So when you say the words herpes to a non-medical person, they immediately think, oh my gosh, how did my kid get herpes? What's going on? What's happening? So reassure them that the herpes virus is a virus that comes in many different flavors, and this one is not the one that they're thinking of. This is common in ages 6 to 18 months. So remember that you're using the age of the child to help you make your diagnosis as part of your decision-making tree. What rashes happen at certain ages and which ones don't? Which rashes happen when kids are vaccinated and which ones don't? So this roseola, pink macules and papules on the trunk. And again, this one may spread to the face and the neck and the extremities. Again, symptomatic treatment for this one. The high fever usually lasts about 3 to 5 days, and these are the kids that sometimes have febrile seizures. And one interesting thing about febrile seizures is that it's not the actual temperature that causes that child to seize. It's the quick change in temperature and the release of catecholamines that causes someone to have that seizure. So something interesting to think about. Here's the roseola infantum. See that rash. Another good picture here. Let's talk about hand, foot, and mouth disease. The Coxsackie virus is what causes this, the enterovirus. It occurs in outbreaks. You might have families or whole towns that come in. It seems like one time during the year, they sort of just all come in with this. This is transmitted by the fecal-oral route. Like, poop to mouth should never happen, right? But with Coxsackie, that is what is happening. Good hand washing can help prevent that. And it's unfortunate over the last 2 years we've had to teach people how to wash their hands again, but it's never a bad thing to do. So you get these oral lesions of fever, sometimes sore throat, and they can be painful vesicles in the mouth, on the tongue, the soft palate. The lesions can also go on the feet and the hands. One thing that people who have the lesions in their mouth want to think for kids is to give viscous lidocaine, which is a mistake, and I would not suggest that you do that. If the kid is really having a hard time, you could do cool liquids and popsicles. You could also do a little Benadryl if you want as a one-time dose. Here's an example of hand, foot, and mouth on the hand. Very subtle one on the foot here that, again, if you didn't get that person with their socks off, you wouldn't have caught it. And here it is on the tongue. Now, this is not to be confused with herpingina, which are painful ulcers in the reddened base involving the posterior soft palate, usually the anterior 2/3 of the tongue. Excuse me. And this is also caused by the Coxsackie virus, but this is just limited to the throat. Usually the fever is very sudden, very high temperatures, and everything might look okay at first, and then all of a sudden the kid just stops eating. So again, that's why anytime you have a fever or a rash, you want to take a look in somebody's mouth. Supportive treatment, let the disease run its course for about a week. There you go. It's a great example of herpingina there. All right, chickenpox. I promised we'd talk about this. This is the zoster virus. Super contagious. As some of you may know, your parents may have sent you to a chickenpox party. Like, that was the cool hip thing to do, where everybody went and got chickenpox. You know, that's what my mother did. I will never forgive her for that, but, you know, we're finally talking now 30 years later. No, I'm only kidding. She did actually make me go to a party. My mom is a great mom, but I did get the chickenpox, and it was awful. I got them everywhere, and I was super sick. So now there's a vaccine, and people should get it so that you don't get chickenpox or shingles that can appear later in life. This is the dewdrop on a rose petal, right? That's your board question that you always get. That is that clear-looking circular vesicle on top of that red skin. Very classic, very easy to identify once you've seen it. Always consider it when you see something like that on a patient. The treatment is typically acyclovir or valciclovir. Definitely a conversation with infectious disease. There can be complications from varicella, including pneumonias, encephalitis, otitis. And remember to avoid salicylates, to avoid Ray's syndrome. Again, prevention is key. Here it is. Dewdrop on a rose petal. Look at that. Very classic, great example of what chickenpox looks like. Lastly, I just want to end with Kawasaki's disease, because remember at the beginning I said there's only a couple things that you really need to think about when you see somebody with a rash. What are the really bad and scary ones? What are the treatments? What are the prevention? Have a friend come in and take a look at them and make sure that you're asking the right questions about history and getting the age of the patient. Kawasaki's, now I work in pediatrics. I see patients with Kawasaki's, and I have seen it several times in my career. You may never see a case, but this is actually something that is very scary, and it can be very, very bad for kids. This vasculitis is previously mucocutaneous lymph node syndrome. That's what it used to be called. And there are only about 20 cases in about 100 kids a year. But at Davis, when I work there in the PICU, we tend to see them. Some patients are transferred there. Incidence is highest in males, East Asian populations. And this is an acute febrile illness where it continues on for days. And the cause isn't really well known, possibly in an immunologic response from a variety of different triggers, but it is important to make this diagnosis. Now, there is a major criteria list that you need to look at when you're trying to make this diagnosis. The fever for 5 days should always get your bell ringing. Should always think, ooh, I need to be worried. Why is this somebody have a fever for 5 days? That is not normal. They also have to have 4 of the following: conjunctival injection, oral mucous membrane changes, so that could be anything from a burn looking like mouth or a pink tongue, strawberry tongue, peripheral extremity changes, so you might get that sloughing of the skin, but then you get this polymorphous rash, this erythematous rash that may start and kind of just disseminate into the peeling skin. You also will have cervical lymphadenopathy. If you have a patient that is experiencing all of these symptoms, consider getting a white blood cell count, an ESR, platelets. The problem is that Kawasaki's can lead to coronary artery aneurysms, and we do not want that because that can be life-threatening. The treatment for this is actually aspirin, an IV immunoglobulin, and sometimes both together. Here are the classic 5 pictures of kids that are concerned for Kawasaki's disease and should get your radar going. So this is just a summary here now of measles, the rubeola and the rubella, not to be confused with each other, but can be prevented with the MMR shot. Scarlet fever, which is associated with strep throat. Erythema infectiosum, which is Fifth's disease, that was the slapped cheek. And then, of course, roseola and chicken pox. I put it in a little graph for you. I don't know if it blew up on the page or not. All right, good, it did. Yay. So you have that as a reference. And that's it for pediatric rashes. Hello, my friend.
Hello, hello. All right.
Here's the clicker.
Woohoo. Thanks, Martha. All right, guys, we're getting into the home stretch of the afternoon. We're going to continue on talking about some hip and pelvis disorders, the ones that we see in the emergency department. This is a little bit of a shift from the shoulder lecture that we had earlier. We talked about that shoulder being a joint that was really mobile and prone to injury. This joint is a little bit the opposite. It's a very structurally intact, strong joint that rarely gets injured, and when it does, it's because of high force mechanism. So we're going to spend the first half of this talk talking about hip disorders in children, and then we're going to move forward, and then we're going to talk about hip disorders as a result of trauma. We're going to talk about some dislocations and fractures. So let's start out with the kids. This is a pretty good list of all the reasons that kids might come in with hip pain or with a limp. Now, one important concept to understand for these hip disorders is that in a very unfair way, the way the nerve distribution works, the afferent and efferent nerves in the hip, a kid might come in actually complaining of knee pain or medial thigh pain, which actually could be a harbinger of hip pathology, which might not be so readily apparent. So when we're evaluating kids that are coming in with a limp or coming in with hip pain, it's imperative that the physical exams start from the low back and go all the way down the leg, into the thigh, into the knee, and all the way down. Kids can have spiral fractures of their tibia and all kinds of reasons that they limp as well. So a really good thorough exam. Now, you're not going to want to memorize this list right off the bat. It's going to be hard to keep this differential straight. But I'm going to try to work through this list with you guys, and we'll come up with some frameworks to think about pediatric hip and limp. So the first two disorders here, the slip capital femoral epiphysis and leg calf perthes, SCFE as you hear the first one called, are degenerative diseases of the hip. The next two, septic hip and toxic synovitis, are sort of brother and sister, one really bad one, the septic hip, and one that's more benign, that's toxic synovitis. Those are inflammatory and infectious disorders. And then you have hip dysplasia, which is a condition of neonates, which we'll talk about in a moment, and then the dislocations. So the limping child, I'm gonna give you a mnemonic, and we're gonna talk through a few of these, and then I'll give you a nice little mnemonic to think about. All right. So in terms of understanding the anatomy for these kids, these are the ossification centers that children have. The times when the hip is most susceptible to injury are at the extremes of age, when kids are young, and then when we grow older and we get osteoporotic. All in the middle, the hip becomes a really stable and strong joint. And so these ossification centers, has anybody ever looked at a pediatric hip x-ray? It's just like, there's nothing there. It's as if like there's just open space. And the reason for that is because it hasn't laid down quite enough bone for you to be able to see it. These ossification centers start out with a very shallow acetabulum. The kid, you won't be able to get that bone until the kid has really started to bear weight on the bone at about the age of 1 when they start walking and grinding on that hip, and then they'll start to lay down bone little by little. The implications of this are, before that bone is completely laid down, is that kids can get contiguous infections. They can get an infection in the joint. If they get hematogenous spread, it can get into the joint and get into the bone. When you're an adult, you get one or the other. You can get a septic joint. You don't typically get osteo with it, or you get osteo without a septic joint. Kids can actually get both because of the vascular continuity. So let's start at the very, very beginning of life, this neonatal congenital hip dysplasia. These hip dysplasias, if you can look at this photo over here, a normal hip will have the femoral head sitting nice and snug into the acetabulum. But somebody with hip dysplasia, the acetabulum is really shallow, and so the femoral head doesn't sit quite snugly in there. Who gets this? This tends to be firstborns, kids that come out breech, or first-time deliveries because of the narrow vaginal canal. And the way to test for these are the Barlow and Odolani test. Now, these are tests that should be done right away after the baby's born. You'll see the pediatricians oftentimes when the baby comes out, they'll do these little maneuvers just to make sure they don't have this hip dysplasia. But sometimes they are missed, and this is really a primary care maneuver, but it's a good practice to get into for neonates. This should really be a part of our exam, checking their hips. The same way we're checking the reflexes and everything else. When you see a neonate, especially in the first 6 weeks, this is a nice set of examinations to do. So I'm actually going to start with the Barlow, and I'll go backwards to the Ortolani. Why? Because the order and sequence of these should be Barlow first and then Ortolani. So the Barlow test, the way I think about it, is Barlow back. So what you do is you have the baby sitting down, and you have them flex their knees, and you do one hip at a time. You push down, you push back. And if you hear a clunk and it pops out of place, that's indicative of hip dysplasia. So I'm going to go backwards now to the Ortolani test. The Ortolani test, the way I think about it, Ortolani out. If you start by pushing back. If you dislocate the kid's hip, you do the Ortolani. That's actually a reduction maneuver. So you pop it out. Thankfully, you just pop it to the side and you can pop it right back in. If you don't get instability with the Barlow, you pop it out, and if they get resistance with the abduction, then that's indicative of hip dysplasia as well. So either of these being abnormal will clue you into some hip dysplasia in a kid. We'll get urgent referral to their PMD and ortho. Has anyone ever seen the treatment for these kids with hip dysplasia? They put them in this harness that looks like the lederhosen that you get for Oktoberfest. It's really cute, but also really sad until they get their acetabulum sort of forms the right way. So this is a chart that outlines all of the different pathologies that we had put on that first slide, and it organizes them by age and when they're most likely. So I have this as a reference slide for you guys, and we'll talk about the age sequences as we go through the individual pathologies. But I'm going to give you guys a little mnemonic that I find to be very helpful, and the mnemonic is LIMPS, L-I-M-P-S-S. If you just Google LIMPS, L-I-M-P-S-S, emergency medicine, an Annals article will come out. One of my colleagues actually developed this mnemonic, and it's pretty good. LIMPS is, it starts with the L, leg calf perthes. I is intoxication, inflammation or infection, which would be either the toxic synovitis or the septic hip. The M is malignancy. The P, it's kind of soft, pain from trauma, but like we were talking about, fractures and things like that. The S is skiffy, and then the S is somewhere else, coming up from somewhere else in the body. But pretty nice mnemonic. So let's start with left calf perthes. This is avascular hip necrosis. This occurs in kids in the preteen, sort of toddler to preteen ages, 4 to 10 years old. These kids may present with a unilateral limp, and the way that these kids will present will be, progressive pain that starts to get worse as they're, like having worsening and worsening degeneration of this hip. It can start out on an X-ray. You may be able to diagnose it with something called a crescent sign, and as it gets worse and worse, it can degenerate into this moth-eaten appearance. Now, the question is, how bad is this for the kid? These kids can develop arthritis later in life, but actually most of these kids end up doing okay, and even if you diagnose this on an X-ray in the ED, you can refer them as an outpatient and they can get treatment as an outpatient. ICU, limit their mobility, and they tend to do okay. Here's another X-ray. You always want to make sure you're looking at both sides. The kids that get this on one side, they're unlucky. There's a subset of kids, about 1 in 6 or 1 in 7, that get it on both sides who become super unlucky. So even if you don't see it necessarily on the X-ray, it doesn't mean they haven't had symptoms or have disease on the other side. All right. So now we're moving forward in age range. The slip capital femoral epiphysis, the SCFE. This is the more concerning one of the two. This happens more in the adolescent age, and mostly in sort of like the adolescent portly patient. More than 80% of these happen in kids with BMIs greater than 95%. This tends to happen more often bilaterally, more than 30% of these, and these kids will also come in with either unilateral limp or difficulty walking. Oftentimes they'll be presenting in an externally rotated position, as you can see, sort of a Charlie Chaplin style walk over here. And on the X-ray, you will actually see the junction between the epiphysis and the metaphysis, this scooped ice cream, like an ice cream falling off a cone, that you can see that's not subtle at all in this X-ray. So let's go through a couple of X-rays and show you what it looks like. So this one here, again, you can see that epiphysis just literally falling off in this concerning way, but a lot more times it's more subtle. So look at this X-ray here. This is a more subtle version of that last X-ray that we saw. And we talked about in orthopedic complaints, there's always gradations of conditions and injuries, and there are always lines associated with these on the X-rays. The line that you want to look at for a SCFE is called the Klein's line. And what the Klein's line is, you track a straight line at the level of the femoral neck, and you extend it all the way up. If it intersects with any portion of the femoral head, then that is normal. If it doesn't, then you probably have some subtle slippage of the epiphysis. Here's another example, kind of blown up. If you want to Google, there's also something called an S sign. And if you combine this Klein's line with an S sign, the sensitivity goes up tremendously in identifying these SCFE patients. Now, SCFEs, let me just head back here real quick. The SCFE patients, you have to call ortho. These patients require urgent referral. The orthopod may want to admit them, depending on the severity, for immediate repair, or they may want to do something and set up an urgent follow-up. But these need to be repaired more quickly than compared to the left calf perthes patients. All right, this is the one that we don't want to miss, the septic hip. The septic hip is the one condition in the limping child where it is extremely time sensitive and can cause tremendous morbidity and maybe or even mortality if we don't pick it up. So these kids, the risk factors are kids less than 2 years old, kids that are immunocompromised, and these kids, if they come in having any of these sort of, in addition to the limp, say you got the X-rays on a limping kid and it doesn't show SCFE, it doesn't show leg calf perthes, the X-rays are negative, and then the nurse comes up to you and tells you, hey, this kid also has a fever. Whoop. All of a sudden you're starting to think about something a little bit more dangerous. All these criteria that you see here are positively predictive for a septic hip. Fever greater than 38, white count greater than 12. The kid is non-weight bearing, literally cannot bear any weight on that extremity. And then you get the CRP or the ESR, and those are elevated. this is problematic. This is called Coker's criteria. These criteria were derived and validated in the late 90s, early 2000s, and it's the test characteristics of it are pretty good. If you have all the Coker's criteria, it's highly positively predictive. If you have none of them, it is pretty negatively predictive. However, there isn't a lot of literature out there externally validating these criteria. So if you have somebody who you're really, really concerned about, even if their Coker criteria is 0, they still warrant further workup. What do we do in terms of workup? We already talked about, you've gotten the x-rays. It's a good first line sort of test for kids that are limping. If those are negative, then you move on to the ultrasound. If the ultrasound shows an effusion, that is very concerning, and that effusion should be tapped, not by us, by orthopedics or by somebody in the radiology department. If that gets, you tap that joint, and if that shows septic joint, then obviously that patient is going to be admitted and possibly operated on. Now, if the x-rays are negative, the ultrasound doesn't show an effusion, but your suspicion is still high, the next step would be to move to an MRI. How does septic hip happen in kids? We talked about the ossification centers earlier. Those ossification centers can cause a contiguous spread. So kids can get it from hematogenous spread through sepsis, et cetera, or they can get it from osteomyelitis tracking up into the hip. Most of the cases are staph, but not all. You can see some of the other etiologies here. And it's rapidly destructive, like we said. These kids, this is an emergency condition. And so we talked about the kid with the fever. You're thinking about septic hip. You're thinking about some other things as well. You want to expand your diagnosis, your differential diagnosis to a lot of these things that are going on over here. We talked about getting an x-ray and then an ultrasound ruling out septic hip. If the kid is persistently febrile and having a limp or having pelvic pain and maybe some lower abdominal pain, that MRI not only can help you diagnose the septic hip, but it could also help diagnose a lot of these other conditions that you see here. Same goes for adults. If you have really bad hip pain that you can't figure out why they're having the hip pain and the fever, all these etiologies are worth considering. Toxic synovitis. Okay, so this is the more benign partner to septic hip. It literally exists to make every ED provider's job even harder. This toxic synovitis is actually a non-toxic condition. The kids that come in with toxic synovitis actually should look pretty good and non-toxic. It's called an irritable hip. This is sort of overlaps in the same age range where we see a lot of septic hip patients. The thing that's different about this compared to septic hip is these kids should really not have a lot of those Coker's criteria. The white count should be normal, ESR, CRP should be normal. They might bear a little bit of weight. If a kid comes in and is limping and is having pain, one of the really nice ways to differentiate the two, you give them some NSAIDs, the kid won't walk at all, they're in a lot of pain. You give them some Motrin, and all of a sudden they're running all around the ED, more likely to be toxic synovitis. If you're in the sick patients that are febrile and whatnot, it's easy to kind of like admit the patient and know that it's septic hip. The really challenging cases are the kids that, they're not really having a fever, but they're still not bearing weight on that leg. The x-ray is normal, you're still worried, is it toxic synovitis, is it septic hip? The ultrasound would be the next thing to order, and if there's no effusion, it decreases your pretest probability, doesn't eliminate it, and then depending on sort of how the kid is presenting, you may admit the kid for observation to see how they do, or you could send the patient home if they look really well. Just making sure you do some shared decision making with the parents that if it gets worse in any way, shape, or form, that the patient has to come back. Avulsion fractures, this is another thing that we see in pediatric population, but really more in the adolescent kids. This happens in a lot of athletes where the muscular architecture is stronger than the bony architecture. And so if you see somebody, a soccer player, trying to kick a ball, they can get an avulsion fracture where it rips a little bit of the tendon off the bone. Track players, they can get ischial tuberosity, avulsion fractures, ASIS, and ballet patients that do ballet. And then you can see here in this photo all the different places on the x-ray. If you see a little chip avulsion fracture, usually not a big deal. A lot of these patients will get PT and do well. But if it's a severe avulsion fracture, sometimes they will be operated on. Let's transition from the pediatric population to now the adult hip. And this, we were talking about the architecture being a lot stronger in the adults. So let's talk about some of the conditions that adults may experience. Hip dislocations. This is one that, has anyone seen a hip dislocation? Posterior? Could you tell right from when they came in through the door? These are pretty dramatic sort of presentations on exam. The way that these happen is a lot of times will happen because of MVA, high energy mechanisms. And most of these cases will happen when somebody is not seatbelted. So somebody will be sitting, they'll get into a high-speed MVA, the dashboard will push against their knee and really just drive their femoral head posteriorly behind their acetabulum. The way that these patients present, if you see them on the gurney, they'll come in shortened and then a little bit internally rotated like this. And so this is critical to diagnose both clinically and radiographically because it's a time-dependent reduction. If you don't reduce these in a timely manner, the way that the circulation works at the proximal femoral head, patients can develop AVN if it's not done quickly. So the number that you'll often hear cited is 6 hours. So you really want to get these in as soon as possible. Get the x-ray. You don't want to be messing around with waiting 4 hours for the orthopedic doc to get into the ED for them to do it. You want to get these in as soon as possible. And because of the strength of the architecture of the hip, it's really important that you get really good sedation. We talked about the shoulder, that you might be able to get away with like an intra-articular injection or maybe not even any injection at all to get it back in. The hip, you really do need to procedurally sedate these people. Good medications for that could be propofol, assuming they don't have multi-system blunt trauma where you're worried about bottoming their blood pressure out. So a couple of images here of a posterior hip dislocation, what it looks like clinically, internally rotated and shortened. And then on the x-ray here, you can see it kind of popped up posteriorly, superior and posterior to the acetabulum. All right, here's another blown up view of the posterior hip. Now, we'll go through a couple reduction techniques. One more image that we don't have an image of here is a CT scan. After the hip is reduced, you really want to get a CT scan of the hip in patients that have had a traumatic injury to a native hip. Why? In as many as 90% of these, they will also have associated fractures of their acetabulum that may not be readily apparent on the x-ray. All right, so a couple of hip dislocation reduction techniques. The most well-described, if you just open up a textbook for posterior hip dislocation to see how to put these back in, the thing you're going to see most often is the Alice maneuver. The Alice maneuver, if you talk to a lot of ED docs that have been doing this for a while, they will recommend against doing the Alice maneuver. The Alice maneuver is the one where you're seeing on the gentleman that's sitting up on the gurney holding the patient's leg. Ergonomically, this is not a really comfortable position to be in on the gurney. Also, as you're pulling, the stability that you have on these gurneys isn't great. I don't know about your gurneys, but our gurneys don't always lock so well, and there's a chance that you get a second patient in the provider that's trying to pull up on these things. And I'll tell you, one of my colleagues that actually had done a lot of lectures and was really well versed in disorders of the hip. I watched him in our resus bay on a 21-year-old girl doing the Alice maneuver and just yanking up on this person's leg and just fractured her femoral head, taking this dislocation and kind of converting it to a fracture dislocation, obviously suboptimal. There are much better dislocation reduction techniques out there now. If you can see the other photo, the Whistler method, the doctor looks far more comfortable in this photo. The patient has the posterior hip dislocation. He's put one of his arms underneath the patient's knee and has the other one on the patient's ankle. And what really he's doing is he's using his arm as a fulcrum. He's pushing down on the patient's ankle and lifting up with the arm to allow for that posterior dislocation to come back into place. Two other techniques that you may want to write down that are very much in vogue and I think are really nice techniques to be able to use. One is the Captain Morgan technique, developed by Greg Hendy, who's the chair right now over at UCLA. If you Google the Captain Morgan procedure, what you do is you actually put your leg on top of the gurney, and then you use that as the fulcrum instead of the arm that he's using here, and you kind of use your calf to raise up while you're pushing down on with the other hand. Now, a couple things to make your reduction a little bit easier. One thing you can do is you can lay a backboard underneath the patient, which gives you a little bit of a better sort of stepping off point, so you're not pushing down on the gurney as much, you're pushing on the backboard, and you're able to get a little bit more lift on the patient's knee. And then as you push down, you'll get them back into place. and then you got to really immobilize these patients. Another technique that you may want to read about is the East Baltimore technique, where you can imagine if you're not that tall. We have some very tall patients coming into our ED. I'm about 5'8". Sometimes my leg won't kind of reach and be able to function as a fulcrum on their leg. And so there's a technique called the East Baltimore technique. You need an additional person, and really what that is the two people, they kind of lay their arms on each other's shoulders, and you get underneath the leg, and then you just kind of lift up together in kind of a synchronized way to use that as a fulcrum. So there's some nice techniques out there. I wouldn't recommend the Alice. There's Captain Morgan, East Baltimore. There's also a rocket launcher technique that you can look into. But look at these, they're good techniques, all variations of the Whistler. What about the anterior hip? The posterior hip, remember, is the far more common one. In the shoulder, the anterior shoulder dislocation is the more common. In the hip, the posterior hip is the more common. But you can get an anterior hip dislocation, and it looks very different clinically than you see on the posterior. The posterior, the femoral head gets driven back, and you get internally rotated and adducted. For the anterior hip, they kind of look, they're frog-legged when they come in. They're externally rotated and abducted. And there's a couple different sort of subtypes of this I'm not going to get into. But the way that you relocate these, the way that you reduce these is, you can get a little bit of inline traction and just kind of pull where their femur is. You give a little bit more external rotation, abduction, and you can just pull some inline traction. We recently had a case like this in our ED, an anterior hip dislocation, and you had the orthopods coming down, and both of them are 6'2". And they're jacked, and they're getting after this anterior hip, and they're pulling, and they're sweating, and they're trying to use the Alice technique, and it's just not going in, and they try again, and it's not going in. One of our other attendings, who's about, maybe 5'7", 5'8", probably weighs about 130, 140 pounds, hasn't lifted a weight in a while, and he was watching this whole thing happen, and when the orthopods were done, and they were about to call their attending, he's like, do you mind if I just give this a shot? And he just went in there, he did some inline traction, did a little of external, internal rotation, and it popped right back in without any force at all. So just a little bit of a different technique. And both of these can get AVN, so you want to reduce both of them in a timely fashion. The other thing other than AVN that these patients can develop is some sciatic nerve injury as well, so just make sure you're doing a good neuro exam. Here's a x-ray of that anterior hip dislocation. You can see the femoral head just kind of kicked out to the side. Then the last subtype of dislocation that we're going to talk about is the prosthetic hip. These are patients who have had prosthesis placed in their hips, and it's just unfortunate. A lot of them will dislocate doing just basic things, like going to the bathroom, they'll kind of squat down, they'll flex a little bit past 90 degrees, and all of a sudden the hip pops right back out. The good thing about these patients is that they are not going to get avascular necrosis, right? They have a prosthetic hip, so when they come in, the urgency to get these back is not as strong as what the first two conditions that we talked about, but it is important to get it back in. They can also get sciatic nerve injury. The one sort of caveat for these is that they have these either titanium or plastic cups, and what you don't want to do, the big risk of these actually go in a lot easier than the native hips. But there is a risk that if you pull on it and you catch resistance on one of the cups, that you can pop that cup out and the whole thing needs to be revised, which is a problem. And so it's advisable, and I would recommend for every single dislocated prosthetic hip patient that you get, that you call ortho. You ask if they want to do it. If they want to do it, great. If they don't want to do it and they're okay with you doing it, just let them know, hey, I'm going to do it. I'm not going to push against resistance, but I just want to let you know that if anything, if there are any complications, I'll call you back. It's just important that they're aware of these patients. All right, let's move on to hip fractures. There are a variety of different hip fractures, starting from the femoral head, going all the way down into the femoral neck. And so I'll show you, let me jump into the diagram. I'm a very visual learner, so let's look at the subtypes here. There's the femoral head up top, and then you can see all the different places where you can get fractures of the hip. That line outlined by number 1, that's sort of where anything proximal to that is in the femoral head and femoral neck. That's called an intracapsular hip fracture. Those patients are at higher risk of AVN. Anything distal to that, those are your intratrochanteric, subtrochanteric fractures. Those have less risk of AVN, but the big point for all of these is all of these really need to get repaired and get repaired early. So when a patient comes in, you may see a patient that has a shortened extremity. You're thinking, oh, maybe it's a dislocated hip. But a lot of times with these hip fractures, you'll also see shortened hips. And then you get the x-ray, you see a hip fracture. One of the really nice things that we can do for patients is get their pain under control when they come in. And if they have multi-system trauma, you don't want to be giving them morphine and Dilaudid and all these things. A really nice block for these hip fracture patients is a 3-in-1 block. Fascia iliaca block. So take a look. Write that down into your notes. Look at the video. These do a really nice job of controlling people's pain, decrease the need for opiates, and patients are overall a lot happier. These patients will get IVs, blood tests, everything, and they'll get admitted. Who will they get admitted to? For the most part, and especially in elderly patients, you're going to want to admit these hip fractures to the medicine service, not the orthopedic service. They tend to have a lot of comorbidities, these elderly patients who get hip fractures. And patients have been shown to do much better on the medicine service when they have all their comorbidities addressed and taken care of compared to when they're on the orthopedic service. All right? And if these fractures are non-displaced, you want to make sure that that's when they get operated on. You don't want to be sending them home for urgent ortho referral, have them like bear weight on the thing and have them displace that fracture, then it becomes a much more complicated procedure. Which brings us to this occult hip fracture issue. You may get the x-ray on a patient that you are suspecting a hip fracture in, and you don't see anything at all on that hip, and the radiologist reads it as normal. In about 1 in 25 cases, you'll get an occult hip fracture, which means there are no great radiographic findings, especially in these elderly patients where you're seeing all this osteoporosis and rattiness in the x-ray. And the patient, you try to do your ambulatory trial and they're starting to walk out and they're still sort of limping and having pain. It is not okay to send that patient out. We have to go on and get advanced imaging, either a CT, MRI, MRI being the best possible test that you can get to make sure that there's not an occult hip fracture in there that could be intervened on early. Here's a little algorithm of all the imaging that we talked about. Start with the x-ray, and if they're still not walking, move on to advanced imaging. Here's a couple nice photos kind of outlining how difficult it can be to see a hip fracture on an x-ray. You see that little arrow, that's where the fracture is. Really tough to see with all the osteoporosis. And then that fracture looks readily apparent on the MRI on the adjacent photo. All right, and we are on the last slide. This is the greater trochanteric bursitis. This is called a hip pointer. You'll see this either in athletes, or it's also common in sort of middle-aged, usually females, who don't have the best posture. It puts some strain on the greater trochanter. So this is at the level of the proximal hip. If someone's having pain with direct palpation right here, if they're an athlete, that could be from a result of direct blow. Like I said, in females that have sort of like chronic pain, could be males too, but if they're having chronic pain with direct pain and pressure right there, this could be a case of greater trochanteric bursitis. These are patients that are going to get NSAIDs and get worked up as outpatients. That's all for the hips. And next up, we have Dr. Jan Schoenberger.
Thanks, Raman. All right, thanks, Raman. Good afternoon, everybody. It's my first time greeting you. Hello, welcome to boot camp. Very happy to be here with you. And I know Rick did introductions the first day, but just to refresh your memory, my name's Jan Schoenberger. I come from Los Angeles. I'm the chief of the emergency department at LA County USC General Hospital. Raman's one of my colleagues. And I'm very happy to be here with you. And so, for the next 30 minutes, we're going to talk about sexually transmitted infections. Fantastic. You ready for some disgusting genitalia? Yes? It'll wake you right up, I promise. These days, the more PC term is STIs, not STDs. It's an infection. We have treatment. Let's not stigmatize. It's a much more gentler term for, if you're old enough, you remember the days where we used to call it VD, right? Who remembers what it was called VD? That was a long time ago, right? And then it was STDs, now it's STIs. And there are some good recent recommendations in here, so there's some updates here if you haven't reviewed this in a while. Now, in terms of sexually transmitted infections, you can really kind of divide these conditions into two different categories. Those that cause ulcers, or painful lesions. Some of these are painful, not painful, but ulcerations, versus those that don't cause ulcers. They cause discharge, they cause dysuria, they cause other symptoms. That's one way to think of these. If you look on the column of ulcerating, the two most common by far are herpes and syphilis. The other three listed here are much more unusual, but they do ulcerate, so we mentioned them here, but they're much more unusual. And on the non-ulcerating side, we have things like gonorrhea and chlamydia, which we think about a lot if we're talking about STIs. We've got non-gonococcal urethritis, we've got PID, and we've got late syphilis. We'll talk about those things. And we're going to start with gonorrhea. Now, gonorrhea and chlamydia are BFFs. They go around together all the time. Like half the time somebody has one, they have the other. So we have to think about both. And usually in the emergency department, we are not blessed with the luxury of having that test result back that confirms to us this person definitively has GC or chlamydia. So we are often making the decision to empirically treat based on what we clinically see and what we clinically hear from the patient. And that is totally okay. These are very infectious. We see these in adolescents and young adults, but really we see it across the whole age spectrum, to be honest. In men, it causes symptoms. They usually have some dysuria, they have some discharge, they have something that brings them into the ED. Less so in women. Women will have cervicitis, but they often don't have overt symptoms of this disease. They may start to have pelvic pain, and it can ascend to become PID, which we'll talk about. Now, wherever you have sexual contact, you can get gonorrhea. So you can get proctitis and you can get pharyngitis. I've seen both of those in terms of gonorrhea infections. And it can cause conjunctivitis if it's inoculated into the conjunctiva as well. Now, in terms of testing, yes, you can do gram stains, but these days we have these nucleic acid amplification tests that we can do. The most optimal way to test for this is to do a urine sample in males and vaginal swabs in women, but you can do urine samples on women as well. That is definitely an option as well. And if you do suspect this in the rectum or in the pharynx, you're going to need to culture it. Now, this is where the CDC has actually updated their guidelines. This is important to know. The treatment for GC has changed. This changed just a few months ago. The treatment now for gonococcus, when you're treating empirically, is 500 milligrams of ceftriaxone. It used to be 250, now it's 500 milligrams of ceftriaxone intramuscularly. And they do have a weight-based adjustment for our bigger friends. If you're over 150 kilos, you go up to 1 gram. So there is a weight-based dosing adjustment. If you have not excluded chlamydia, which again, in the emergency department, we typically have not, we do not have those test results back, we are treating empirically, then you're gonna add 100 milligrams of doxy twice a day for 7 days. This used to be a Zithro that we used to treat them together. That is no longer the recommendation. So the recommendation is to do ceftriaxone 500 plus doxycycline. And I can get into in the Q&A if you want to know more about why this changed. I'm happy to get into it, but I have so much more to cover. I'm going to move on, but there are some good reasons why this was changed. If they are pregnant, you can use azithromycin, so it still is a possibility. So this is a new recommendation. Good to put a big star by it. Note to self, it's 500 milligrams. It is changed. Okay. Now, gonorrhea can disseminate. It can cause more than just the genitalia infections. It can disseminate. This doesn't happen very often, but it does happen. And when it happens in a few different forms. It causes a few different syndromes, if you will. It can cause an isolated arthritis. So when we talk about septic joints, septic knees, septic hips, things like that, gonorrhea is one of the organisms that can cause a septic joint. So it can cause an arthritis syndrome. It can also cause an arthritis dermatitis syndrome, where you tend to get these little rashes. And I have a picture of what it kind of looks like here. It's a little pustule, a gunmetal gray pustule. It's a hemorrhagic pustule on sort of a red base. And you will see this little rash usually on the extremities. That's where it commonly is seen. And there won't be very many of them, so you have to look for it. But when you see one, you will remember this picture. Like, I think that might be a gonorrhea pustule on their finger. And you should think about gonorrhea in the right scenario. Often they'll have fever, they may have some arthralgias, they may have tenosynovitis, some different joint pain here and there, they have these skin lesions. And so if we think that's what's going on, you have to think, wow, this could be gonorrhea. And I have to go looking for it in the sites where it may have entered, whether that be the pharynx, the GU area, the rectum, etc., and start culturing different areas looking for this. But we're going to treat this with ceftriaxone. Now on this slide it says azithro, but as I just mentioned, that's actually out, and they updated this just a few months ago before I made these slides, after I made these slides. So this is actually just ceftriaxone that we're gonna treat it with. So it's a higher dose, it's 1 gram, it's parenteral, it's either IV or IM that we treat this disease with. So if we have disseminated GC, we are also treating it with ceftriaxone. GC, ceftriaxone, GC, ceftriaxone. Now, chlamydia is actually the most common STI in the United States, and it causes, again, urethritis, cervicitis, very similar things to what GC causes. And in women, again, this is much less symptomatic than it is in men, so often women don't know they have it. And that's one of the reasons that the guidelines advocate for screening in young sexually active adults. Now, we don't do screening in the emergency department, so I'm not advocating for that in the emergency department, but know that that is kind of why that you do this, because it's really out there and it can be asymptomatic. Again, we talked about nucleic acid testing that we do in men and in women, and this can be treated with azithromycin or doxycycline, which is really kind of more preferred these days, kind of leaning toward the doxy side of things, twice a day. And remember that partners who may have transmitted these diseases also need to be treated. Now, there's a whole different topic about whether you treat partners in the emergency department, and that can vary state by state, institution by institution, but expedited partner therapy is a very hot topic about making sure that we treat both parties. But you're going to treat the patient in front of you. There's more to discuss if we want to talk about treating partners. Now, PID. PID, if you think about the words PID, pelvic inflammatory disease, it's kind of a wastebasket term in the sense that, what does that mean? Where is the infection? And this is an ascending infection into the pelvic organisms or organs, and it can be the fallopian tubes, it can be the endometrium, it can be kind of all of the above, and it usually presents with pelvic pain. It can also cause abscesses. So you can see tubo-ovarian abscesses in this condition, not always, but sometimes, and we'll talk a little bit about when to image looking for those. But the biggest concern here is that as you have this ascending infection kind of sitting around in these sensitive areas, if it goes untreated, it can cause scarring, it can cause infertility, it can cause chronic pelvic pain, and in general, the WHO thinks that we, as the medical professionals, underdiagnose this condition. We underdiagnose PID. And so we really want to think about it, and if we are on the fence about treating, err on the side of treating, you know? We don't want to miss this disease. It has some really bad outcomes long term. Now, PID is not just a result of the typical STI organisms like GC and chlamydia. There's also things like mycoplasma and lactobacillus. It's a multi-organism infection. Now, people who get diagnosed with PID can look anywhere from pretty mildly ill with some, general pelvic pain to really, really sick. So there's quite a spectrum of illness. And our goal is not to miss those mild ones, to catch the ones that are just, kind of early in their symptoms and make sure we're treating them, and make sure that the ones that come in with a lot of lower abdominal pain and look really sick, that we're making the right diagnosis in those patients, that we're not missing something else. So we want to catch the mild cases. We also want to make sure we're catching the sick cases and not missing other things. Now, this is a clinical diagnosis. To diagnose pelvic inflammatory disease, you need to have the right symptoms, the right exam, and you can call it PID. You don't need any specific diagnostic test to make this diagnosis. Importantly, you need to know if they have cervical motion tenderness or uterine tenderness. If they have tenderness of those pelvic organs, you got to think about PID or adnexal tenderness. If you see any of that on your exam, then you're going to go looking for organisms to make a definitive diagnosis, and you're going to move forward and treat them empirically. So you're going to culture them for gonorrhea and chlamydia. You want to think about HIV and syphilis in terms of what their history tells you, if they're at risk for those things. And if someone is very focally tender, like one adnexal side or the other, or they're quite sick, they have a fever, they have more pain than you expected, those are the patients that I would advocate for imaging. They don't all need a pelvic ultrasound, they don't all need a CT scan unless you're unsure of the diagnosis. But if you think there could be a TOA involved, and again, I think those are the patients who are more tender than I thought they would be, they're really in a lot of pain, they look sicker than I thought, those are patients I would image, going to look to rule out for a TOA. Now, some of these patients can go home, and some will be admitted. So it depends on what their comorbidities is, it depends on what their clinical condition looks like. If they are sick, if they are pregnant, if they are immunocompromised, I'm admitting them. But if they look pretty good, they're tolerating POs, their pain is controlled, they can go home. So you can really go either way. There are a lot of different treatment regimens for PID. It's easy to look these up. You have time to look them up. And so you can choose which one, depend on their allergies and what you have on your formulary, et cetera, to treat them with. But in general, you want to use ceftriaxone. The dose is 500, crossed through 250 milligrams. It is 500 milligrams intramuscularly, updated with the other gonorrhea guidelines. It is 500 milligrams IM, plus you add the doxycycline. And in this case, you treat for 14 days. It is longer than we treated for the cervicitis and the more outpatient garden variety of things. This is 14 days. Azithromycin is definitely not first line here, and you want to add metronidazole. It used to be that the guidelines, if you remember PID guidelines, it said kind of plus minus metronidazole, and there's been a few recent papers that have come out saying that metronidazole probably is really more indicated. You have longer tests of cure, more success when you add it, so add metronidazole. I advocate for that. If you are sending a patient with PID that you're making that diagnosis home, you want to make sure they have a follow-up in 48 to 72 hours. There are definitely outpatient failures with PID, and so you want to make sure that patients know that they need to be rechecked. And if people are having an outpatient failure, that's someone who you want to bring in and you want to consult GYN. So you will have some treatment failures. It's few and far between, but they happen, so make sure you have a follow-up plan and tell her that she needs to come back and get rechecked. Now let's move on to herpes. So we're now moving into the ulcerating conditions of the genitalia here. This is the most common ulcerating STI in the United States. It's 1 in 5 sexually active adults, so it's very, very common out there. If you were to differentiate between HSV 1 and 2, it is HSV 2 that is the more common of the two varieties, but either one is actually possible. If you've seen someone who comes in with their initial herpes infection, you know that they usually don't feel good. It's not just the painful, awful, ulcerating lesions that they have, but they often have some more systemic symptoms of fevers and not feeling well and arthralgias and fatigue, that kind of stuff. That's really kind of common in the first episode as it gets started. And then a couple days later, in the first week or so, they start to get these shallow vesicles, these shallow ulcers that are really, really painful. And in some cases, these multiple ulcers can coalesce and look kind of maybe what you're not exactly expecting. You're expecting kind of these isolated ulcers, and they can coalesce and cause an even larger ulcer that can be extremely painful. It can be extremely painful to urinate, extremely painful just to sit, just extremely painful all around. I've even admitted people with bad primary herpes outbreaks when it's that bad. When they're sick, they're in so much pain, it's just impossible to think about sending them home. The pain control is so difficult. So these can be really, really awful. These peak in 8 to 10 days. It will go away in a few weeks. That's the good news. The bad news is we don't have a cure for herpes, and so people definitely have outbreaks that happen later. So as they have recurrence, they can be shedding virus, and that can be a problem down the line. And that's part of education with the patients, making sure they know that this is something that can come back. Again, this is going to be a clinical diagnosis. You do an exam, you take a look, you see the ulcers, this looks like herpes. You're not going to have a confirmatory test in the emergency department to tell you that's what it is. So you're going to do your education and your diagnosis clinically. If you are in some certain situations, you can do some viral testing if you have that available to you where you work. Not every place has the nucleic acid testing that you can do for herpes. Not every place has it. And it's not going to be something that you get back in the emergency department, so we don't often order it. Most patients will have these symptomatic recurrences, and often they kind of know it's coming. There's a bit of a prodrome, there's some itching, there's some burning, there's some symptoms there that tell them, okay, here it comes, it's coming back. What about treating herpes? We said we can't cure it. Should we treat it? Is there any benefit to doing so? And the answer is yes. It usually will shorten the length of the outbreak, and it will often make the symptoms a little more mild. So the recommendation is to, yes, treat with antivirals. And we know that people who get frequent relapses, they also can be treated to basically kind of suppress those relapses. There are a variety of antivirals you can choose, again, maybe depending on the formulary, where you work, et cetera. Acyclovir is fine. That's kind of the old school. It has more frequent dosing. So some people like the valcyclovir because it's less frequent dosing, and there's other ones too as well, famciclovir as well. And there's different doses and duration depending on whether you're treating it as an initial outbreak or recurrent, or you're suppressing the therapy, et cetera. All those things are a little bit different in dosing, and you can always look those things up. Some of these, as I said, you might have to admit somebody with this, but depending on their clinical scenario, and they might have complications like disseminated infection, if they're immunocompromised, if there's any suspicion of a pneumonitis or a hepatitis or something more invasive. Those would be people, obviously, that are going to come in. Syphilis is definitely still out there, very, very common, have to keep it on our radar. It is the spirochete treponema that causes it. We know that the primary syphilitic infection is the painless ulcer. So often one of the reasons that syphilis progresses is because the ulcer that appears first is painless, the chancre. So often people don't present for care because it's like they see it, that bothers them, they may not know but it's not painful. So they kind of like, oh, and then it goes away, great. It's really syphilis that now is going to progress to something else. So we know this heals spontaneously in 4 weeks or so. We know that we can do testing for it to find it. We diagnose it using a combination of RPR and VDRL testing. Depending on your institution, it depends on how they do this protocol. They recently changed it at our institution to now start with the treponemal antibody, the more specific testing, and then go backwards, versus where we used to start with the RPR, which is very non-specific, and then go to the more specific testing. We do sort of a reverse protocol now. So your lab may have a way they want you to order looking for syphilis. So if you miss the primary syphilis, you don't get the opportunity to treat it, it will move on to secondary syphilis. So some period of weeks afterwards, it's a bit variable, they will have some kind of a rash. Now this rash is very nonspecific. I cannot give you a description of this rash that will definitely tell you that this is syphilis. So what's my take home from that? What I take home from that is that we see a lot of rashes in the ED. We are not dermatologists. I will tell you, I've been doing this for 20 years. I don't often know what the rash is that I see. That's okay. You don't have to know all the rashes. It's impossible. But if you don't know what it is, think about syphilis. So when I see things that are maculopapular that I'm not sure, I have syphilis cross my mind. Could this be syphilis that I'm looking at? And when it comes to rashes, one of the old mantras that I learned, which is, if you know what it is, why touch it? And if you don't know what it is, don't touch it. So either way, don't touch it. And that is true with syphilis for sure. You don't want to be touching it. So it can come in a lot of different forms, secondary syphilis, and think about it in those rashes, which you don't know what's going on. They may have other accompanying symptoms like fever and arthralgias. This can be a rash that involves the palms and soles, but it doesn't always involve the palms and soles. And then later on, again, if we miss it in the secondary phase and syphilis progresses onto the tertiary phase, it can do a lot of crazy stuff way on down the line, decades after that primary infection, causing neurosyphilis and heart problems and all kinds of interesting findings where syphilis is left to be untreated. So we want to make sure that we catch it. We want to think about it when we have those opportunities. The treatment for syphilis has not changed in all of these years. It is still penicillin. The treponema has not evolved to be resistant to penicillin. So benzathine penicillin is still the treatment for syphilis. It's a dose of 2.4 million units. It's given IM. And then if you move on to more advanced forms of syphilis, the dosing will change a little bit. Remember that when you give the penicillin shot for the syphilis, people can get the Jerix-Hersheimer reaction, which is basically, think about the penicillin going in and all those treponemes, the spirochetes just exploding and causing this kind of general inflammatory reaction where they just don't feel well. They get a fever, they kind of ache all over, and that you have to tell patients that that can happen, and that is expected and normal, and it is not uncommon for that to happen. Now, talking a little bit more of the exotic conditions here, we've got chancroid and LGV. These are not common in the United States. These are not the first things you're going to think of when you see ulcerating infections, but if you have a patient who may have been internationally, like out traveling internationally or comes from somewhere else, that kind of a thing, you might see something like this. Or you work internationally, you'll see this more commonly in other places for sure. And it does occur in sporadic outbreaks in the US in certain cities, and you might get a little, one of your public health notifications telling you that we've seen some cases of this. Usually these are very painful genital ulcers, plus on one side they'll have like an inguinal node that's fluctuant, and that's kind of diagnostic for chancroid. And so this is a clinical diagnosis because you will not have that test to tell you this, so it's part of the history, part of the exam, and getting into the treatment, it's not common that you'll see it, so you'll look up the therapy if you think that's what's going on. LGV is caused by chlamydia. These are painless, shallow ulcers that usually heal pretty quickly, but then you get these buboes, these big bulges in the groin that can be there weeks later, and if we think that's what's going on, we're going to treat it with doxy. So this is sort of a summary slide going through these ulcerative sexually transmitted infections. We've got herpes, we've got syphilis, we've got chancroid, we've got LGV, whether or not we see any systemic symptoms, whether or not we see adenopathy, what that initial lesion is expected to look like, and what those lesions are in general. This is kind of like a good money slide, like good reference if you ever want to go back and see a summary of all these things. Now let's move on to some other conditions that can present with vaginal discharge, et cetera, that we might want to also consider in addition to our STIs. And one of those really common ones is vulvovaginitis. When you have someone coming in with genital pain, they're telling you about some discharge, some itching, some other symptoms. Let's talk about the differential there. So you could have an infection there. But don't forget there's other things that could be going on. It could be something like atrophic vaginitis. It could be some kind of a foreign body that's stuck there. It could be some kind of allergy that they're having. It's a really, really common gynecological complaint. Now, if we're talking about candidal or yeast infections, candidal vulvovaginitis, this is really, really common, right? We see this all the time. It's kind of the white, cottage cheesy discharge. They have a lot of discomfort and itching, and this happens for a lot of different reasons. It can happen because they were on antibiotics. It can happen out of nowhere. It can happen because they have undiagnosed diabetes or diagnosed diabetes that's just not very well controlled. So I definitely advocate for checking a glucose in patients that come in with a new candidal infection and you're not really sure why. That is also true in males who have balanitis or penile infections. Just do a quick glucose check and you will find new cases of diabetes in those patients for sure. You'll find a glucose of 300 in a patient who had no idea they had diabetes. People who are on oral contraceptives, et cetera, can get this as well. Now, they often get itching. That's the most common symptom that they come in with. They may have some discharge. They may have some other types of pain. And usually, if they're telling you about dysuria, you can differentiate this from a true UTI if you really ask specific questions about when they feel the burning. Because the burning that you have from this condition is kind of as the urine has left the urethra and is passing through the other tissues, that is when they feel the burning in this particular case. And if you take a look, it'll be red, it'll look irritated, and you may see that discharge that usually is not malodorous like some other types of discharge. If you do a wet mount, which you're sending your wet mount because you're usually looking for bacterial vaginosis and other things, they may report to you that they see the yeast and that can make the diagnosis, but you can make this diagnosis clinically. You don't have to have a wet mount confirmation to treat it. In general, if you happen to find that on a wet mount that you're doing for whatever reason and they're actually not symptomatic, you don't want to treat things in general if people are asymptomatic. And so this is one of those conditions as well. And you have some treatment options. You can go for one of the azole creams, the meconazole, clotrimazole. One of the creams is fine. Or you could go through the fluconazole, the diflucan PO route, which is one dose. 150 milligrams, one dose will be effective. So you can go topical or you can go oral, and I usually give patients the choice of what they would prefer. If it's pregnancy, you want to use the topical ones. That's the way you want to go if you have a pregnant patient. And then again, I recommend highly to check a glucose level. You will find undiagnosed diabetics out there. The other thing to think about in candidal infection, if it's recurrent, is HIV. That can be another thing that you want to consider when you see someone who's having recurrent candidal infections, is an immunocompromised like that. Okay, trichomoniasis. So trich is an STI. Of the vulvovaginitis things that we're talking about, this one is sexually transmitted, so it has to be considered that the partner needs to be treated as well. This is a protozoa, and it can really range in presentation from just sort of general discharge to really kind of a lot of discharge. It's really kind of all over the place. Classically, when you learn about trich, you learn about the strawberry cervix, but it's actually not that common. It's very uncommon, in fact. You'll see these every once in a while, these little punctate submucosal hemorrhages. They're really interesting when you see it, but it's not that common, so you shouldn't be really looking for it. It might be there. And you do the wet mount swabs from the vaginal walls, you send it off, they'll see the white cells, they'll see the little motile trichomonads, and there's your diagnosis of trichomonas. You'll get that off the wet mount. If you do diagnose trich, you want to treat it with metronidazole. You can also use tinidazole. That's another option as well. The gel is not effective. You want to do the oral therapy. And again, it's transmitted sexually, so you want to treat partners and you want to advocate to your patient to advise your partners that they should be treated. This is the most common non-viral sexually transmitted infection in the United States. And then BV is another really common one that we see. And this is really referred to as a dysbiosis, or basically, an alteration of the normal vaginal flora for different reasons. It can be associated with sexual activity. It can be totally unrelated to sexual activity. This is not a sexually transmitted infection, to be clear. It is not sexually transmitted. And your exam may be relatively normal, but you may find when you do your wet mount, that you do your vaginal swab, that you come back with clue cells, and that is your BV diagnosis. abscess. The CDC says there's a list of criteria here. It's described really as a thin, like a milky-like discharge that you will see on the vaginal walls, milk-like, think about that. That's the copious, thin, white, homogeneous discharge that they describe. But the clue cells that you'll get back on your wet mount, you have pH changes, and you have the whiff test, which we typically don't do at all. So that's on the list. Anyone who has symptoms we're going to treat, and certainly any pregnant women, whether they're symptomatic or asymptomatic, will be treated for this. We know that BV in terms of pregnant women is associated with poor outcomes, lower birth weights, premature delivery, et cetera, so we want to treat it when we find it. And in terms of asymptomatic women, this can be a case where you also don't treat if it happens to come back on your wet mount. And this is another case where we treat with metronidazole, and an alternative to that would be clindamycin cream. So here's another little summary slide kind of going through these entities we've just talked about and sort of going through the different symptoms and how common they are with these different diagnoses, which one you might expect depending on what your patient is presenting with. And this is about the diagnostic testing. You've got BV, you've got Trick, you've got Candida, and what you would see when you send your wet mount. Do you see white cells? Do you see clue cells? Clue cells, that's BV. If you see trichomonads, that's Trick, that's an STI. If you see yeast, that's Candida. And so that's a little summary there. And we'll close with a couple other little tidbits about this area of topic. And so let's talk a little bit about Bartholin's cysts and abscesses. This is the poor person who comes in with a swollen gland. It can often be infected and red and very painful, and this is something you need to drain, and it can be, very, very uncomfortable, and it can be recurrent, unfortunately. So you have these normally occurring glands that get blocked, that get infected, and it could just be a cyst. Sometimes they're not infected, they're just swollen. They say, I got this swollen thing down there. Sometimes it can be really infected. The abscesses are more painful, and they have a variety of flora in them, including anaerobes as well. And like all other skin abscesses, ultimately the treatment is IND. So you want to open these up and drain them. And if they are recurrent, you want to refer them to a gynecologist for a more definitive surgical procedure to take care of it. Other things that we might see patients who come in with warts. Warts are usually not painful, but cosmetically they can really bother people, and so they may come in seeking your opinion. And this can be due to HPV. These can also sometimes be due to syphilis if they're also more flat and a little bit wetter looking. That can be syphilis as well. And you can see them anywhere from the perineum to the perirectal area. I recently saw a poor, unfortunate gentleman who had these just really all over the place. He had waited a long time before he came in, and they were like super infected and weeping all over the place, and it was really, really sad. And it was like, just so awful. And he didn't want to come for so long until he just kind of couldn't take it anymore. But usually they're pretty painless, but they, again, are kind of disfiguring to some people, and they can present some complications if they're let to go on a very long time. These are not in the emergency department. This is not an emergency for you to treat. You do not need to address this in the emergency department. You can, usually I recommend, there are some topical things we could try. There are some freezing treatments that a dermatologist or different doctor will do. This isn't something that you usually have to treat emergently in the ED. And we know that HPV vaccination will prevent a lot of these things, and so we want to advocate for that where we can and do those good preventative recommendations. And finally, let's close by just talking about some recommendations for victims of sexual assault that we might encounter in the emergency department. This is by no means a comprehensive, little talk on sexual assault. There's a lot that goes with talking about victims of sexual assault and how to examine them and how to deal with them and how to help them. But in terms of the STIs and what we should treat and how we should preventively treat them, there are a lot of different guidelines. They're going to need a lot of testing to definitively decide to figure out what they exactly have, but we're going to do a lot of empiric treatment in the emergency department to address the possibilities. They're going to have a wet mount sent. They're going to have the nucleic acid test sent. They're going to have all that stuff done. It may be by you. It may be by a sexual assault team. It depends on how it works at your institution, but they get all the stuff, all the serology, all the HEP screening, et cetera. And then in terms of the guidelines, the ceftriaxone, it's 500 milligrams IM, put a line through the 250. It is 500 milligrams IM, just like the other gonorrheal infections that we've talked about in this talk. It is 500 milligrams is preferred, plus metronidazole, plus doxycycline is the recommendation for chlamydia. We're going to give them all the stuff for GC and chlamydia. Some people would advocate for giving also some herpes empiric treatment, valcyclovir, whatever antiviral you have. That's not technically a CDC rec, but something that some people will do. And then we also want to think about emergency contraception as another thing that we offer. So they're going to get a lot of different medications to try to prevent these different infections, whatever we can address. In addition, we talk about HIV prophylaxis, and the truth is that not everybody needs HIV prophylaxis. It depends on what type of contact was had and what we think the risk is. And the risk varies for acquiring HIV infection depending on the type of contact that was had. So it takes some specific questioning about what happened and to assess the risk in that person. And so evaluating the characteristics of what the risk is for that individual. And if you do consider post-exposure prophylaxis, it's easy to give it early if you're going to err on the side of giving it. And these days, the toxicity is a lot lower than it used to be. So, it's a little bit easier to tolerate for patients. There also is a great 1-800 number to call. I can't remember the exact number, but it's easy to Google. If you want advice on, like, should I treat this person, should I not treat this person, there's some free advice lines for post-exposure prophylaxis that you can call if you have questions. And that is sexually transmitted infections. Thank you very much. We have a 15-minute break right now, so enjoy your break, and we'll see you after, and we'll continue talking about some GYN topics. All right, welcome back. We are in our last little bit for the day, and you get to be free in Vegas to do whatever you want. My favorite thing to do in Vegas is people watching. It's just such good people watching in Vegas, right? Like from all over the world, all walks of life. It's just fantastic. The ED is good for that too. I guess those interests overlap. Okay, we're going to talk about pregnancy and vaginal bleeding, and there may be some of you in the audience who have experience coming at this from primary care or a women's health clinic, that kind of thing. And from the ED mindset, we think about a lot of these complaints differently than you may be used to thinking about them. And we think about them not from a more frequent, what's the most common thing that causes this, but more like, what's the worst thing that could happen? What's the worst thing that could cause this? And so that's kind of the angle that we're going to come at here in addressing these types of complaints, these patient complaints, is, what is it that we really need to be worried about here? And so let's start with a patient who comes in with a chief complaint of vaginal bleeding, everybody's favorite chief complaint. You're so happy to pick up that next patient that's complaining of vaginal bleeding. I know that you are. But let me tell you that in the emergency department, you probably work at a place, if your place is like my place, you have like a room where you send these patients because it has the right exam table, it has the right equipment, it has all your supplies. And that's where you send everyone who has vaginal bleeding. And for a lot of the patients, that's an appropriate place to send them. But every once in a while, you're going to come across a patient that comes to the emergency department because the people who come to the ED are sicker than the patients who come to other types of clinics and settings where they actually are unstable, and that is the wrong place to have them. They should be in your resus bay where other patients are who are bleeding a lot. That's where this patient should also be. So when we have a patient coming in with vaginal bleeding, we think worst first. Could this be a really life-threatening vaginal bleeding? That's not the most common thing, but it happens. If we have that chief complaint, we need to first verify that that is indeed where the blood is coming from. Is it coming from there, or could it be coming from somewhere else? And then if it's a patient who has a real tachycardia, a soft blood pressure, doesn't look great, we want to treat this patient like a hemorrhaging patient. We want to put in 2 large bore IVs. We want to send the type and cross, the type and screen. We want to think about pre-op labs because this person probably will need an intervention. So we want to think about this patient a little differently than we're used to thinking about all other vaginal bleeding patients. These are patients who often need a transfusion, and usually sooner rather than later, because they are losing red stuff. You need to put red stuff back in. And then, of course, any patient who comes in with a complaint of vaginal bleeding, one of the first things we need to know is, are you pregnant or are you not pregnant? Because those are 2 very different pathways. So we have to know how to get a pregnancy test the fastest that we can get it. And that may be sending serum for a quantitative beta quant in terms of, what you may not get urine right away in a person who's really sick. That may be the fastest way that you can get it. It depends. If you have a bedside ultrasound, you have those skills. This is a patient that you want to lay the probe on early. You want to look and see in terms of a fast scan and looking to see if there's intraperitoneal blood. You want to assess for pregnancy. You can take a quick look in the pelvis to see if you can see anything there. And if this is a person who's unstable, you're going to reach out to your consultant sooner rather than later. As I mentioned, this is someone who's probably going to need an intervention that you cannot do. So you want to call whoever it is in your institution that can support you, whether it's OBGYN, whether it's general surgery, whether it's IR, whether it's whatever it is. They may even need an operating room. So thinking about what am I going to mobilize next to help this patient. Now, for the most part, most patients with a chief complaint of vaginal bleeding are usually pretty stable. And so in those cases, it's a similar type of algorithm. Is the bleeding actually coming from where she thinks it's coming from? And then we take a step back and say, okay, wait a minute, this person's not that sick. I don't need to throw an IV in this patient necessarily like I do in so many other of my ED patients. Maybe this is someone that doesn't need an IV. Maybe I can go ahead and go through this assessment without throwing an IV in. So depending on whether you need one or not. Again, pregnancy test is very high up there in the algorithm. Right after vital signs is going to be a pregnancy test in this individual. So whatever point of care test you can get to make sure you're going down the right algorithm and you're not overlooking a pregnancy that's not known to your patient. A type and screen, maybe you send a CBC, maybe you have a point of care hemoglobin test that you can use to expedite the care of this patient. So if this is a patient who's not pregnant, then we're talking about, okay, how much blood have you lost? Is this something that we need to emergently consider? Are you symptomatically anemic? How anemic are you? And a lot of those patients can have an outpatient referral. Now, if they're pregnant, if they come back with a positive pregnancy test, now I'm thinking about, okay, now I have to assess a pregnant patient with vaginal bleeding, so I'll probably add on a few tests. I'll add on a quantitative HCG, I'll add on a type and screen. I want to know what her RH status is, and I may be ordering an ultrasound in that particular case or doing one myself, depending on what my skills and my resources are, so I can assess for an intrauterine pregnancy. So let's start first with the patient who's not pregnant, because that's a little bit more straightforward. Patient comes in with a complaint of vaginal bleeding. She's not pregnant. Remember, we're in the emergency department. We're not in primary care clinic or a women's health clinic. We're in the emergency department. What is emergent about that we need to address right now? Well, we do want to consider what might be causing it, just to take a moment and think about it. Could it be something like fibroids? Abnormal uterine bleeding can be a lot of different things. It can be endometriosis. But we also want to consider the more unusual things like trauma. Could there be some kind of laceration? Is there some kind of a foreign body? Do they have a medical cause for bleeding? Some kind of a coagulopathy, thyroid dysfunction, other kind of endocrinopathies that can lead to excessive menstrual bleeding? Or could it be postmenopausal bleeding, which is not good. You know, you want to, in the emergency department setting, in terms of thinking worst first, this is cancer until proven otherwise in this patient who's postmenopausal. So we want to consider that as a possibility, and that's someone who really needs close, urgent follow-up. It's not something that I'm going to work up in the emergency department. I don't need to make that diagnosis this second, but obviously it's an important one that I want to make sure she has access to care. These are patients that rarely need an emergent intervention. For the most part, someone who's not pregnant, who comes in with heavy vaginal bleeding, we want to think about the anemia, we want to think about she may need a transfusion, but even after we transfuse her, she may be able to go home and have outpatient follow-up because there's nothing acute that needs to be done at this moment. So usually these can be referred as an outpatient to a gynecologist for definitive evaluation and treatment. And I would also add that for the most part, these are patients who do not need a pelvic ultrasound in your emergency department. It is not going to change what you do in the end. Yes, would it add information as to figuring out whether it's fibroids or something else? Yeah, sure, it would probably tell you more about why she's bleeding, but it doesn't need to be done right now. That's probably more appropriate as an outpatient to be done. So it is not a case where you need to automatically check pelvic ultrasound to go looking for the fibroid. It's not emergent. I don't need to know it right now. I have other patients in the waiting room that I have to be concerned about that I need to be getting back. That is part of emergency medicine, is changing that mindset to be thinking about not just the patient in front of you, but those patients that need the room as well, and that you're responsible for all of them as well. So that is not something I have to figure out right this second. It is rarely emergent. Now, abnormal uterine bleeding or dysfunctional uterine bleeding is really in the absence of any organic disease that you can find. This is usually related to problems, hormonal changes that relate to ovulatory or anovulatory states. And this is really the most common reason you'll see people who are not pregnant walking through your door with abnormal uterine bleeding. So you want to ask questions about what's normal for you. How many days is normal for you? What is your flow normally like, and what are we looking at right now to kind of get an idea of what's abnormal about it? We want to also ask in our history of present illness about signs and symptoms of anemia. Are you having shortness of breath? Are you having palpitations? Are you feeling, weak, that kind of thing? And then we want to also do a good review of systems, thinking about those other medical causes, thinking about thyroid disease, other endocrine problems, liver disease, coagulopathies, recent medication changes, recent illnesses, things that could play into why this person's having excessive bleeding. And we can consider occult bleeding disorders, things like von Willebrand's or other coagulopathies, and often you'll kind of tease that out in the history that they have abnormal bleeding in other settings as well, whether it's easy bruising, epistaxis, et cetera, that might make you think about that. Not every patient needs, a full CBC and a pro-time INR to go looking for coagulopathies, but if there's something in the history that suggests that to you, then go ahead and order those tests. And then we're going to do an exam. We're going to look for lesions. Does this person have a fungating undiagnosed cervical cancer that's bleeding? What else do I need to be thinking about? And then in terms of testing, as I mentioned, pregnancy test, CBC for anemia, point of care hemoglobin is fine. Coagulation studies, checking platelets if indicated. And then the pelvic ultrasound, but it is rarely emergent. Because think about what you're looking for. It does not need to be diagnosed right now. Now, if someone's bleeding a lot, what can we do for this patient to stop the bleeding? Well, really, since I mentioned it's a hormonal problem, this is really about manipulating the hormones. So there's some options that we have to treat really heavy bleeding in terms of our patients. We can give something like IV estrogen that will help slow things down. It won't happen right away, but it will happen in several hours. Or we can start patients on oral contraceptives so that we're kind of regulating their hormonal balance on an ongoing basis. That is what most OBGYNs would recommend in terms terms of getting people on something like that to get things regulated. It'll slow everything down, get things more regular, and you can refer. So you may, in fact, start a prescription for that if that's what your institution likes to do, if that's what's the normal practice in your group. That might be an option. Some patients aren't going to want to do that, so you also have to think about what other options do you have. So there's a bunch of hormonal options. Know that just NSAIDs alone can actually reduce the blood loss by a good margin, 20 to 50%, depending on different studies that you read. And there are other things like tranexamic acid. There's some other options available. Don't be afraid to call your consultant and ask for some advice on cases that are particularly tricky. Now let's talk about the patient who does have a positive pregnancy test. What are some of the basics to know about that? Well, remember that in terms of beta HCG and getting those levels, that in general in a normal pregnancy, the HCG level will approximately double every 48 hours in early pregnancy. So if you're looking at patients serially in time, which we do in certain circumstances, in general every 48 hours that HCG level should be doubling. Remember that the uterus, you will start to be able to palpate it above the pelvic brim at about 12 weeks, so that can give you a little clue there sometimes. If you get up to the umbilicus, we're talking about 20 weeks. That's when usually things are pretty visible, and that can be helpful in patients who come in with altered level of consciousness, can't give you a history, trauma patient, whatnot, that you can find these physical exam clues that could tell you all of a sudden, wait a minute, this person could be pregnant. Knowing that about 1 in 100 women of childbearing age at any given time is pregnant, and there are a lot of undiagnosed pregnancies out there, so always be suspicious. Whether you follow the mantra of test everybody from age 8 to 80 or whatever it is that you learned, what it means is be generous with your pregnancy testing. There's no harm in checking a pregnancy test. You may always be surprised with the result. So that is always a possibility. Now, in terms of patients who come in early pregnancy with vaginal bleeding, okay, from the emergency medicine perspective, we think worst first. Not what's most common first, but what's the worst thing this could be. And in our minds, the thing that we are going to rule out until proven otherwise is ectopic pregnancy. That is the most life-threatening cause of vaginal bleeding in early pregnancy. So our biggest concern is I need to rule out ectopic pregnancy. And the question I need to answer there is, where is this pregnancy? Is this an intrauterine pregnancy or is it not intrauterine? That's really what I want to be worried about. Now, early vaginal bleeding in first trimester could be due to a variety of different types of abortion, whether it's a threatened abortion where on your exam you see a closed os. In those cases, there's not much that you can do to prevent it. You educate patients. There's nothing that you did that caused this. This may be a very desired pregnancy. Do a lot of counseling, pelvic rest. Let's see what happens. It could be an inevitable abortion where someone's already either passed tissue or may have an open os. That's someone who may need a DNC, may need more of an urgent intervention, or someone who's had an incomplete abortion where some of the POC, the products of conception, have passed. Maybe not everything has passed. May also need a DNC, may need an intervention. So there's a bunch of different possibilities that it could be, but sort of in our minds, ectopic pregnancy is at the top. We want to talk ourselves out of that. So this is a little chart kind of going through the HCG levels at different weeks of pregnancy. This is easily referenceable, not something to know, but know that you could look this up if you got a number back and you were kind of curious about where it fits in terms of the lineup. But there's big ranges as to what the HCG will be at different levels of pregnancy. What's important about this, as I mentioned, is about ectopic pregnancy and knowing whether or not this pregnancy is intrauterine or not, and the ultrasound is going to tell us that. So we have to be experts at interpreting that ultrasound. We have to know a lot about when the ultrasound should show us something, what type of ultrasound will show us something at what time period, and that's really where our knowledge needs to be to know this problem well. So if you're ordering a transvaginal ultrasound, you should be seeing an intrauterine pregnancy at about 5 to 6 weeks in a normal pregnancy, and that will be at an HCG level of about 1,000 to 2,000. 1,500 is kind of a good compromise there. 1,500, if your beta HCG is 1,500, you should be seeing an intrauterine pregnancy on a transvaginal ultrasound, right, in a normal pregnancy. So that's an important threshold to know. That's a number that we call the discriminatory zone, that around 1,500 should be the discriminatory zone. Over that, I should be starting to see an intrauterine pregnancy if it's a normal pregnancy. If I'm looking transabdominally, I need a little bit more. I need 6 to 7 weeks, and I need a higher HCG. I need 6,000 to 7,000, where in a normal pregnancy, I should be seeing something. So these are important numbers for us to know. We also have to know that when interpreting an ultrasound, there are pitfalls to interpreting an ultrasound and looking at very early intrauterine pregnancies. There has to be certain elements on that picture that the radiologist sees or that you're interpreting to interpret that as a definitive intrauterine pregnancy. It has to be a gestational sac that has a yolk sac, and you have to know a lot about looking at those images. So in general, when you're looking at one of these images in an early pregnancy, you'll see this. You see the whoosh of uterus around, and you see this black circle, and within it, you see this little ring. You see the fetal pole, you see the yolk sac, and around that is the uterus. This is looking like an intrauterine pregnancy, a very early intrauterine pregnancy. So any woman who comes in the first trimester who's got vaginal bleeding or abdominal pain, we're thinking about ectopic, we have to know a lot about this disease. So we know the fetus isn't implanting normally in the uterus. We know that it happens about 1 in 50 pregnancies. There may be patients who have no risk factors. There may be patients who've had previous ectopics, or they've had PID with scarring and different risk factors that can make her more predisposed to have it. And what we do know is that they usually tend to rupture between about 6 to 8 weeks. This can be somewhat variable, but most patients before that life-threatening event happens have some symptoms, which is when they're walking through your doors because they're having a little bit of bleeding or a little bit of pain, and we have the opportunity to make this diagnosis early or to at least consider it and get her on the right track. So to rule this out, I need a quantitative beta HCG. I need a type and screen because this is someone who could bleed, and certainly I need to know RH status. I want to know a CBC, and I want to know an ultrasound. These are kind of the essential elements of evaluating someone for ectopic pregnancy. And then I have to know, when I get that HCG result back and I get that ultrasound back, I need to know how to put this information together to inform my decision as to whether this is an ectopic or not. I need to know about that discriminatory zone. I need to know that if I'm seeing a beta HCG over 1500 and I have a transvaginal ultrasound result, I should be seeing that pregnancy. So knowing these things are really, really important. This is one of the pitfalls, is misinterpreting this information. Now, every once in a while, you'll get lucky, and the ultrasound will actually definitively diagnose an ectopic for you. It'll see embryonic cardiac activity outside the uterus. It'll have the empty uterus on transvaginal ultrasound, and you've got your HCG, which is high enough that you should be seeing something. Or you might have an empty uterus and have some ultrasound signs that tell you that this is not a normal pregnancy. And sometimes every once in a while you'll see an adnexal mass. You might even see free fluid. So, the ultrasound will be very, very informative to you. And these are some different images of what that might look like in terms of adnexal masses and cardiac activity. Or they find the empty uterus and there's free fluid floating around in the pelvis, which is highly suspicious for a ruptured ectopic pregnancy, of course. These types of things. But what if I don't have those things? What if my HCG is below 1500 and my ultrasound's inconclusive? Then I'm in the situation that I have a pregnancy of unknown location. This could be an early pregnancy that's normal, and I just don't see anything yet, and it's more of a threatened abortion situation. Or it could be that it's an ectopic, and I don't know that yet because things haven't played out yet. So often we're stuck in this scenario where it's too early to tell either way. And so in those circumstances, we have still not ruled out ectopic. We still have to consider that, and we have to make a plan to make sure that as time marches on and this thing sorts itself out, that I've got a good plan of what's going to happen next. So if it's a stable patient, this is a patient who it's really important to have good follow-up precautions and a plan of where she's going to go next. Usually it's going to be in 48 hours, she gets a beta HCG check. And the reason is because we mentioned at the beginning that in normal pregnancy, your HCG should be doubling about 48 hours. And if it's an abnormal pregnancy, it doesn't usually follow that pattern. So that's one of the early clues. So having a follow-up appointment in 40 hours to get the beta check and see how she's doing in terms of pain and bleeding, et cetera, is important. And that might be coming back to the emergency department if there's no other option for her. That might be the plan for her. Or it could be that she has a private physician that she can go and see. So having a good plan, and this is one of those patients where I personally will go in and do the discharge instructions and make sure that she understands this is a high-risk situation. I want her to understand what the possibilities are here and how important it is to follow up. So good discharge precautions. Now, someone who's like unreliable for follow-up, or they're really symptomatic, they're having a lot of pain, or they're unstable, obviously that's someone you'll bring in, you'll observe, you'll call your consultants. You're not sending that one home. Now, there are some options for treating ectopic pregnancies. These days, it's not all surgery. There are medical treatments as well. Most people are aware of that, and that's really usually, that should be something that you decide with your consultant. That is not something that emergency physicians are making, the decision on their own. So we are consulting and we are going into this with our colleagues, and it may be an option to do surgery, it may be an option to do medical therapy. So if it's methotrexate, there are lists of specific criteria that a patient has to meet to be able to be eligible for that therapy. And there are failures of methotrexate as well, so that needs to be known as well. So that may be something. I don't order methotrexate myself. I usually have the consultant order it. It may be done differently at different institutions. So this is a nice summary algorithm to go through first trimester vaginal bleeding, kind of walking you through like how does this play out over time. We start with that ultrasound, then we're going to kind of fall into, does it tell me that it's an ectopic? Is it indeterminate, or does it look normal? And then sort of following from there. So it's really dependent on that ultrasound and seeing what that image looks like to you. If we're in that indeterminate part of the middle, if the report tells you like, we can't tell, there's nothing there yet, it could be early, we don't know, then you have to go to you got to rely on that beta HCG. You got to follow up that beta HCG in 48 hours to see what happens, knowing that normal pregnancy follows a certain pattern. And you want to interpret that ultrasound in the context of the beta that you're presented with at the moment. Is your beta HCG over 1500 or under? Should I be seeing something, or is it okay that I'm not seeing something? And then follow from there. So this is a nice sort of summary algorithm in terms of making decisions with the patient in front of you. Now, in terms of patients who are pregnant, coming in with vaginal bleeding, there are some other emergency things we need to talk about. One of them is placental abruption, or abruptio placentae, whichever one you want to call it. This is another cause of abdominal pain and vaginal bleeding, usually in later pregnancy. This is when the placenta that's in that uterus starts to tear away from that uterine wall. That placenta is like the life of the fetus, right? It's got all the neurovascular, all the nutrients coming through it, and so you can imagine that if the placenta starts to tear away, that is a bad thing. It can happen spontaneously, or it can be related to trauma, and it can even be pretty minor trauma in late pregnancy. You may or may not see vaginal bleeding with this, so this may be a patient who's come in after a trauma, she's in later pregnancy. This is one of the things that we're really, really worried about. And what's important to know about ruling out this diagnosis is that ultrasound is unfortunately not sensitive enough to completely rule out this diagnosis. And the reason is because the ultrasound, the placenta goes all the way around the fetus, and you can't see those back corners of the placenta. You could have abruptions happening behind the fetus that the ultrasound can't see. So it is not a perfect test. You'll still do it, but it's not a perfect test for this. The thing that we need to do to rule this out is to fetal monitor. And so patients who come in who are over viable age of pregnancy, which depending on your source is usually 20 to 24 weeks, somewhere in there is viability, that person needs fetal monitoring right away. And what we look for is we look for changes in the baby's heart rate to tell us that there's a problem with the placenta, that there's a problem with the vasculature that's coming in and feeding that pregnancy. So this requires fetal monitoring to make this diagnosis, which means they need some extended period of observation, which is not going to happen in the emergency department. It's going to happen up on L&D. So that's really the ultimate. And one of the pitfalls in managing patients in later pregnancy who come in after trauma, et cetera, or with a medical condition is not putting the fetal monitoring on right away. It needs to go on right away so that we have an idea of the baby's heart rate from that point forward. So here are some images of placental abruption. You see the fetus, you see the dark stripe behind on the ultrasound, and that is hemorrhage back there. So you see that on the ultrasound image. But again, ultrasound is not perfect for this diagnosis. We may still see it on ultrasound, but if we don't, it doesn't rule it out. Now, placenta previa is another thing that can happen. This is when the placenta implants near or over the cervical os, which is obviously just too close to the outside world for comfort, and you can get bleeding from that as well. You can have painless, even massive bleeding from that placenta previa. Often patients, they know that they have this, they've had their prenatal ultrasound, and they may also already be on bed rest and be aware of it, but we see lots of patients in the emergency department who do not have that type of prenatal care, who didn't even know they were pregnant, and so we have to know about these types of conditions as well. And this is one of the reasons that in advanced pregnancy, if a patient comes in bleeding, it is contraindicated to do a vaginal exam because you don't know if there could be previa right there behind the cervix. So we don't want to go anywhere near that. We could make the bleeding worse if we did that. In this particular case, ultrasound is very accurate. It will tell us whether or not this is going on or not. We can see everything. So this is a case unlike abruption, where we can really see everything with that ultrasound. And here are some images about what that might look like. There's marginal placenta previa, there's complete placenta previa, and this is very easily visualized on ultrasound. And some more pictures of what that looks like. You've got your normal placenta, you've got abruption where the placenta is tearing away and there's blood coming in behind it, and we have previa where things are right there over the cervical os. Now, preeclampsia is something we also have to have on our radar. We see pregnant women for all kinds of reasons, and we need to pay attention to their blood pressure. We need to pay attention to these other medical things that may be going on. We know that there are risk factors for preeclampsia, and in general, this is defined as new onset high blood pressure, which can be interpreted relative to her baseline pressure or by the absolute numbers that you're seeing. So it's new onset high blood pressure plus they have to have either proteinuria or signs of some kind of end organ dysfunction. So we've got blood pressure that we're looking at, and then we're also going to be checking labs. We're going to be checking CBC, checking their lights and their creatinine to look at that end organ function, looking at also LFTs because of situations that can occur there, and the urine protein. If we're suspecting this at all, if you at all are kind of this is crossing your mind, it is a good idea to call your OB consultant and check in and say, hey, this is what I got. You know, what do you think? I'm worried about preeclampsia. So you're going to check urine, we're going to check that blood pressure, we're going to check some labs if we think this is a possibility. Now, when we use the word eclampsia, we're talking about preeclampsia that we just talked about, plus now we have a seizure on top of it. This usually happens in the third trimester. I think we're all pretty familiar with the idea of eclampsia, but the thing to know from an emergency medicine standpoint is that eclampsia can happen up to 6 weeks postpartum. So if you have a patient presenting to you with a first time or new onset seizure, she doesn't look pregnant to you. You may not know that she's postpartum 1 month ago. It could be eclampsia. So in anyone who has a new onset, a woman who comes in of childbearing age with a new onset seizure, you want to ask about whether or not there could have been a child delivery in the recent future, because in the recent past, because it could be eclampsia, and she's not even pregnant right now. And I think that was something that, you know, when I learned it, I was like, what? I thought that eclampsia is only pregnancy. No, they can be up to 6 weeks postpartum. This can still happen. Now, in eclampsia, people can have headache and visual changes and signs of neurodysfunction coming on. And the treatment for eclampsia is magnesium sulfate. It's at higher doses than you may be used to using, up to 4 to 6 grams, or benzos are fine too. So you may be seeing this patient with a first-time seizure and walk into that case leading with benzos, and that would be okay. Benzodiazepines will also do the job. So that's another trick there. Now, the blood pressure is important to address as well, and typically in pregnant patients, we're walking into that with hydralazine and labetalol as our options to treat high blood pressure in pregnancy. But the definitive treatment here is delivery, and that is ultimately what they're going to need sooner rather than later. Now, a word about delivering babies in the emergency department, which nobody wants to do. Nobody wants to be in that scenario. Know that if you're faced with a delivery in the emergency department, these are by nature high risk. This is often someone who, again, didn't know they were pregnant, hasn't had prenatal care, or something's happening very precipitously, and so these are all by nature high risk. And so the patients who we see in this scenario, it's, you know, this is not the perfect place to deliver a baby, no question. But we want to use our protocare tests for pregnancy very liberally and using our ultrasound to try to find these and get in front of them before we have an unexpected delivery in some room in the ED where we were not expecting it. If somebody has the urge to push or you see the head crowning, that delivery is going to happen in the emergency department, so get ready for it. Know in your department, this is one of those unusual scenarios, but you want to know where is your OB pack, where is your neonatal warmer, where are the resources that you would need if this happens right away. Now, the good news is that most deliveries are normal, and so, it's very likely, playing the odds, that this will, be a normal delivery and things will go very well. But again, you have to know what your strategy will be if it turns out that you're seeing a foot coming out first, or you're having a shoulder dystocia. Knowing a little bit about what you would do or who you would call is something to think about in advance for sure. And finally, we'll talk about RH sensitization, because RhoGAM is something that we give in the emergency department. But RH sensitization is important. This is why we mention over and over with pregnant women to send the type and screen, because we want to know the RH status. RH sensitization is a big deal and can cause a lot of really unnecessary poor outcomes when we don't deal with it. And the issue is not with the first pregnancy. So this is the scenario where a mom is Rh negative, that's her blood type, and she, has a wonderful relationship with an Rh positive, and now she's got an Rh positive fetus. She's Rh negative, and her fetus is Rh positive. And this is really kind of incompatible. That fetus is going to expose Rh positive to that Rh negative mom, and she's going to make antibodies against that Rh that is unfamiliar to her. It won't cause a problem with the first pregnancy, but later, if she has another pregnancy, this could be a big deal, because now she's got antibodies that could be targeting that fetus. And this is what RhoGAM is all about, is to not allow that to happen, to not have hemolytic disease of the newborn if you have antibodies that are going after that unfamiliar Rh positive fetus, when you have fetal-maternal hemorrhage and you have blood mixing from that baby to that mom. RhoGAM is IgG anti-Rho antibodies. It prevents her from sensitizing and developing these antibodies, and so we give it very generously. There are a lot of indications for it, things that we see in the emergency department. So anytime there's a chance there could be mixing between fetus blood and mom's blood in an Rh negative mother, we want to treat with RhoGAM. And that may be in the case of a spontaneous abortion, that may be in the case of trauma. We want to be generous with this and treat when we can. And so there are a lot of things that we see where this applies. Now, you do have up to 72 hours to give RhoGAM, so if there's any question about it or you want to take your time to think, this is not one of those scenarios where, like, the faster you give it, the better. You have time to give it, so you have time to consult, ask questions, but to think about it, and you want to not miss the opportunity to give RhoGAM when it's indicated. And the dose is 300 micrograms. Really little downside to doing so. Thank you very much for your attention for pregnancy and vaginal bleeding, and Raman is back up for some ortho.
All right, here we go for and disorders. We're going to be talking about the pain in the neck lecture. The focus of this lecture is not going to be on the major traumas, the bad C-spine injuries, the patients that come in paraplegic because of their neck trauma. We're going to talk about the subtle ones, the ones that we tend to see coming in from paramedics with their C-collar, what to do about those patients. So here we are, minor C-spine injuries. The thing to think about when you're seeing a patient coming in from EMS, one of the first things that you want to have go through your mind is, has this patient been appropriately immobilized, or are they immobilized and we can take the C-collar off? So what we want to go through in our mind is this C-collar necessary, and are we going to need to do imaging on this patient? So here's a term that you've probably heard, cervical spine immobilization. The term immobilization is probably a misnomer when you put a C-collar on. It doesn't actually immobilize your neck. The term that EMS agencies are using now and the trauma societies, surgical societies are using are spinal motion restriction rather than immobilization. Why? If you take somebody and you put them in a C-collar, there have actually been studies on this where you kind of fluoroscopically take a look and see how much mobilization there is, and you can get quite a bit of motion within these C-collars. So why do we put these C-collars on in the first place? So it turns out in the 60s and 70s, when there were case series coming out looking at all these cases of missed cervical spine fractures and spinal cord injuries, the EMS agencies took a look at this and said, well, we need to do a better job of immobilizing these patients before we take them to the ED. And so what happened was their practice started to develop where they put all these patients on backboards and in C-collars, and it sort of became an indiscriminate practice. Anybody that was involved in a trauma would start to show up in the ED like this. Now, is that without harm? Or is there any harm to doing this? Just taking every patient, putting them on a backboard, putting them in a C-collar. And it turns out there is. For backboards in particular, those hard backboards that you see, those backboards, not only can they cause pain if you sit on those backboards for enough time, somebody that may have had no C-spine, T-spine, or L-spine pain in the first place, if you put that patient on a backboard for long enough and then you take them off, they will be complaining of pain all up and down their spine, which may actually lead to increased imaging. On top of that, they've done studies on patients with COPD and respiratory problems, and they looked at, well, does this cause problems with the respiratory status? And it can actually cause problems with breathing. You can't expand your lungs quite as well. So these backboards now are really, depending on the EMS agency, coming out of vogue. And a lot of the EMS agencies now, their ACEP had a white paper on this, recommending that instead of using a backboard, what we can do is either use those ambulance cots, or the softer cots, the things that are a lot less painful for the patients. So backboards, bottom line, we don't need to use them, especially the hard ones, except if you're transporting the patient out or extricating them. How about the C-collar? My personal take on this is there isn't a whole, just to put this out there isn't a whole lot of evidence supporting the use of C-collars, looking at patients who didn't get C-collars versus those that did, preventing injury. But I'll tell you, just kind of anecdotally, and on face, it just makes sense. I would rather have someone sort of immobilized than somebody just kind of like being able to do this throughout their ED visit if they have their broken neck. So there probably still is a role. The question is, how do we make sure to responsibly use the C-collars in the patients that actually require them? All right? So how do we selectively immobilize? So selective immobilization and C-spine clearance sort of have a lot of overlap. In the ED, when you see a patient coming in with a C-collar, you want to know which patients you can take out of the C-collar safely. The bottom line is that you're going to want to use one of two rules that have been really well validated to mitigate medical legal risk. Either you're going to use the Nexus criteria that was developed here in America, or you're going to use the Canadian C-spine rule, which was developed up in Canada. Both of them have been well validated. Both of them have been studied in large populations, and both of them are well accepted in the emergency medicine community. So let's start with the Nexus cervical X-ray criteria. How were these criteria developed? They were developed in the late 90s by a gentleman named Jerry Hoffman. You may have heard him speak or heard of him over at UCLA. It was a multi-center study of about 34,000 patients. They applied all of these criteria, and they found that if you applied these criteria appropriately, the negative predictive value of a true C-spine injury, a fracture, spinal cord injury, was exceedingly low, approaching 100% sensitivity and very high negative predictive values. What are those criteria? Another mnemonic. I don't love mnemonics. I'm going to use them for this just to kind of, if people are into them. NSAID is a good mnemonic if you're going to try to remember all of the Nexus criteria. N for neurologic deficits. S for spinal tenderness, midline spinal tenderness. A for altered mental status. I for intoxication. And D for distracting injury. What is a distracting injury? Somebody's coming in, they have a C-collar, they have a broken femur. That injury is distracting them from the C-spine pain. You can't necessarily clear them. If you can't clear them using these Nexus criteria, the next step then would be to image these patients. Radiography. We're going to talk a little bit about the nuances of getting an X-ray versus a CT in these cases, but we'll get to that in a couple of slides. So there is some fine print to Nexus. If you're going to apply Nexus, you also need to understand some of the limitations of Nexus. The two criteria I think that cause the most confusion are intoxication, which is defined as any clinical evidence of intoxication, not necessarily using a number, or intoxication using labs but they didn't really reference any particular value. So intoxication starts to become a little bit subjective, but anybody who looks clinically intoxicated to you, or you happen to get labs and you see an E2H level that's positive, that's somebody you probably don't want to clear right away. And then distracting injury. Of course, distracting injuries mean different things to different people. A femur fracture, long bone fractures, things like that, huge lacerations, those obviously are going to be distracting injuries. But to some people, a finger fracture might be extremely distracting. Other people, it might not be distracting at all. So there is some subjectivity there, and there is some MD or provider discretion. The other thing that is important to know about Nexus is who was it studied in, and then who can we apply it to? It was studied in the age range between 1 and 101. So pretty good. You got a pretty good age range in Nexus. However, in children, there were, in the age range under 8 years old, there are very few patients that were enrolled in Nexus under 8 years old, and almost no patients in that less than 2 years of age range. And so many people will recommend, many experts will recommend that we can use it in the age range sort of 8 and older, but to be really careful in the 8 and below range. Similarly, on the other side of the spectrum, in the elderly patients, there have been quite a few studies looking at whether or not elderly patients, we can effectively use the Nexus criteria in elderly patients. And there's really been mixed results on this. There have been studies that have shown that Nexus works just fine in patients 65 and older. There have been other studies that have demonstrated that the sensitivity of Nexus actually starts to decrease when you get into that 65 and older age group. So that takes us forward to the Canadian C-spine rule. The major difference between Nexus and the Canadian C-spine rule is that Nexus does not use mechanism in their criteria, and Nexus does not use age in their criteria. Okay? And the Canadian C-spine rule, how many people actually use the Canadian C-spine rule here in this room? There's a few. You can see sort of a minority. This is pretty representative of how providers in the US. It's the minority of people that are using C-spine, the Canadian C-spine rule. It's a little bit more complicated. It's not just 5 criteria. You really want to understand and know it well. MedCalc is a really good site if you want to systematically go through it. But the very first step is identifying any high-risk criteria, which includes age over 65, or mechanisms that are concerning, like axial loads. If somebody gets spiders a windshield or has an axial load of their neck, or they have just very, very high speed MVAs, things like that. In the Canadian C-spine rules, you can't clinically clear these patients. And then it kind of goes into more criteria, and ultimately when you get to the bottom, you have them take off the collar and range their neck 45 degrees in either direction. You should be fine using the Nexus criteria or the Canadian C-spine rules. I'll tell you my personal preference, my personal practice is that I use Nexus, and I consider a couple of the things from the Canadian C-spine rules. One is, if I get somebody with a really, really bad mechanism and they still clear Nexus, I may consider imaging that person. Some people would disagree. I can tell you a couple anecdotal things, and you don't want to go on anecdote, you want to go on evidence, but I'll give you a couple cases where I've seen the Nexus rule fail. A young person on a horse that got thrown off the horse, flew, was found far away from the horse, was complaining of no pain, wasn't intoxicated, wasn't altered, really wasn't complaining of any neuro complaints, ended up having C2, C3 spinal fractures. There's other cases, like if I have somebody that gets actually spiders a windshield and isn't complaining of a whole lot of pain midline, for instance, I may still consider CTing that person. And in elderly patients, I have a lower threshold. That's me. If you talk to 10 different ED providers, you may get 10 different answers about what you do. But again, the bottom line is use Nexus or use Canadian C-spine, understand the differences, understand the limitations of the two rules. Nexus versus Canadian C-spine rule. We just did an informal poll in here. I think I saw about maybe 7 or 8 people that said they use the Canadian C-spine rule. Here you can see this is a survey of US physicians. Do they use Nexus? Do they use Canadian C-spine? As you can see, the majority of folks in the US are using the Nexus criteria, and the Canadian C-spine rule, about 70% state that they have never used the Canadian C-spine rule. Have there been studies comparing the two? In fact, there have. There was a nice randomized controlled trial looking at Nexus versus Canadian C-spine rule. It showed that the Canadian C-spine rule actually performed a little bit better. Problem with the study, it was actually conducted by the folks that created the Canadian C-spine rule, so take that for whatever it's worth, but both of them are very well validated and should be charted in every case that you're clearing somebody off of a C-collar. Here's an image of a institutional policy of how you might go through and clear somebody's C-spine. This is something that, I don't know how many of your EDs or hospitals actually have a policy anymore. I don't think we have them in a lot of the places that I've worked because the Canadian C-spine rules and Nexus are so good at achieving the goal that we're trying to achieve. All right. So we know what to do with adults. We have a couple of really good clinical decision tools. What about pediatrics? And I already told you that applying the Nexus criteria to patients that are 8 years and younger can be problematic. So what tools can we use? Are there tools out there that are going to help us? Unfortunately, there aren't any big, decision tools that are just specific to kids. There have been, however, multiple studies that have looked at other high-risk criteria that you might think about in kids. What are those high-risk criteria? In children, if you get somebody who's coming in with severe neck pain, and torticollis, they're just not moving their neck, that would be of concern in any age pediatrics. If you have a patient who has had ankylosing spondylosis or spondylitis or has rheumatoid arthritis or anything like that, those kinds of, Down syndrome, that's a risk factor that could make them more susceptible to C-spine injury. When you look at the studies that have looked at significant spinal cord injuries or fractures in children, the majority of these cases are associated with very bad mechanisms, really bad high-speed MVAs, typically with poor restraint, and or altered mental status or neurodeficits. The good news is for pediatric C-spine fractures is that the incidence of pediatric C-spine fractures and trauma is very, very low, very low. However, if we were to miss it, it would be catastrophic. So if you have any neurologic deficits, altered mental status, the kid's not moving their neck, they have some of these risk factors, they weren't restrained and they were in a high-speed, high-energy MVA, those are patients that you really want to consider getting films on. Now, we're going to talk about how in adults, the recommendation from the surgical societies, and if you, there's a couple of websites that are really nice to look at in any sort of trauma. The West Trauma Guidelines, the East Trauma Guidelines, they're sort of the West Coast Trauma Docs and the East Coast Trauma Docs. They have really nicely outlined guidelines of what to do in various trauma situations. And for adults, the recommendation from those guidelines is that the imaging of choice be a CT scan. So keep that in mind. The guidelines by the Surgical Society state that if you are suspecting you have moderate or severe suspicion for C-spine injury in adults, get a CT scan. In children, however, we can get away with getting plain films first, but if they're negative and you still have suspicion, that you would need to go forward with some more advanced imaging, either CT or MRI, depending on what you have available at your shop. All right, so let's talk about this, CT versus plain cervical X-ray. If you fail the criteria in CCR or Nexus, you have to get some radiologic imaging. Do we get X-rays? Do we get CTs? I guess the first question is, which is the better test? There is no question about this. The better test, the superior test, is a CT scan. What do the guidelines say? We just mentioned the surgical guidelines tell us that if we have moderate or high suspicion for a C-spine injury, you really should be moving to a CT scan because of the much higher sensitivities that we see. However, is there a role for getting X-rays? There probably is a role to get X-rays. We're going to talk about X-ray imaging in cases of minor C-spine injuries. But my general rule of thumb is, if I'm getting a CT head, for whatever reason, I'm worried about altered mental status or any kind of head injury, I'm just going to throw the CT C-spine on at the same time. It doesn't make a whole lot of sense to get a CT head and then send the patient to radiology to get 3 views of their cervical spine. All right, so here's a comparison of a couple of lateral views on imaging here, CT versus plain films. So if you are going to order C-spine films, you have to really understand how it works, what the ideal films are, and what the limitations are. So the first thing to know about C-spine films are that we need 3 views. We need an AP view, you need a lateral view, and we need an odontoid view. On the AP view, you can see right there, you want to make sure that there's symmetry all the way across, that there's no sort of broken fragments. On the lateral view, we're going to talk about some nuances, and on the odontoid view, we're going to talk about some nuances. On the lateral view, one of the really important things to note is that if you're going to get a lateral X-ray of the C-spine, it has to show the top of T1. If you don't see the top of T1, the risk of missing an injury is too high. and you have to send the patient back for x-rays, which is really honestly, I think a reason that a lot of folks don't get these x-rays, that if you've ordered these, and we used to order these when I was in training, you would send the patient to x-ray, they would get the lateral, it wouldn't show the top of T1. You'd send them back, they do a swimmer's view, it might show the top of T1, and you're kind of getting in this loop where you're sending the patient back and forth. So, but just note that the quality of the films has to be good for these to be interpretable. So let's talk about the lateral films, and you want to understand soft tissue anatomy of the C-spine. The most important thing, this only works in adults, on the lateral film, that you want to see the space in front of C2 be at 6 millimeters, and the space in front of C6 be 22 millimeters. 6 at C2, 22 at C6, okay? On the odontoid view, there are 3 sort of considerations that you want to have. You want to make sure that there's perfect alignment and symmetry when you're interpreting this film. So you can see the dens right there in the middle kind of going up. What you want to make sure is all these lines are symmetrical. On the sides, you want to make sure the lateral masses are aligned. In the middle there, you want to make sure that there's symmetry between C1, C2, and then you want to make sure that the dens is symmetric. Again, if you're at a shop where they don't do a whole lot of these films, sometimes you'll see really junky odontoid views, and they're not just, if you don't get a good odontoid view, it's hard to interpret. You probably got to move on to CT. All right? So before I move on to the physical exam, I just want to wrap that up. Guidelines say if you have moderate or severe suspicion, get a CT scan. If you're in a low-resourced area where you might not have access to a CT, x-rays are fine. You just got to make sure that all the views are appropriate and you're reading it appropriately. The only time, I myself have not been ordering C-spine x-rays for quite some time. Our trauma surgeons recommend getting CTs on patients that we have suspicion for. That's my practice. Other people, there is some variation in practice here where people will say if you have really, really low suspicion, maybe start with the x-rays, but if there's any concern, then move on to the CT. All right, neuro exam of the cervical spine. This is really, really important. In Nexus and in the Canadian C-spine rules, it is dependent, one of the criterias are dependent on having a normal neuro exam. So we gotta know what a really good normal neuro exam is. So as you can see here, these are all the cervical nerve fibers, C5, C6, C7, C8. What is the good motor exam for C5 through C8? There's a little bit of a saying, this might help you remember. C5, C6, pick up sticks, that is your bicep. C7, C8, set them straight, that's your tricep, okay? So you wanna make sure you're doing full range of motion of the arms, and then you wanna make sure you're checking your radial, ulnar, and median nerve motor exam, which we'll talk a lot more about in the hand lecture tomorrow. This slide talks about the reflexes that we have. C3, C4, C5 keeps the diaphragm alive. So if they're having trouble breathing, that could be a problem. C5, C6, C7, you can see the picture of all the different reflexes here, biceps, brachioradialis, and triceps. And then you want to do a really good sensory exam. A good sensory exam of the cervical nerve roots. C4 is right here in your traps. C5 is the lateral arm. C6 is the radial aspect of your forearm. C7, C8 are the fingers in your hand. So you want to go all the way down, checking every sensory level. So one more note about if you happen to get an x-ray and you happen to get a CT, and they're both normal, but the patient still has neuro symptoms or neuro deficits, you need to go forward and get an MRI in the setting of trauma. Okay? There's a couple of conditions. One condition that I really want to highlight is a condition called central cord syndrome. This occurs in elderly patients, typically patients that have cervical stenosis or some sort of baseline cervical disease. An elderly patient falls. You get an x-ray, you get a CT, and they're negative, but they're still having residual motor weakness in their arms. That can be central cord, and that is a condition that needs neurosurgical consultation, okay? So neurodeficits, despite having a normal x-ray or CT, move forward with the MRI. Cervical strain or sprain, the good old whiplash. So The majority of patients that we're going to see that come in with neck pain after MVA are not going to have C-spine fractures. They're not going to have spinal cord injuries. They're going to have whiplash. And the important thing, once you've gone through all your criteria and you've ruled them out for needing immobilization or x-rays, if they continue to have pain, mostly paraspinal, trapezius muscles, that kind of thing, that is indicative of whiplash. I'm sure you guys have also told patients this. They come in and they're saying, gosh, this really hurts after the car accident. And you have to tell them the bad news that today is probably the best you're going to feel in the next 3 or 4 days. It's only going to get worse. It's going to get more tense. It's going to get more painful. What do we do for these patients? I like to prescribe NSAIDs. Make sure they're doing good range of motion exercises throughout the course of the next 3 or 4 days. And if they're really, really kind of tight and stuck in a position or something like that, you can always prescribe some benzos, Valium, something like that to kind of loosen them up. I like to prescribe CBD oil or some kind of cream for these also, but that's that. Soft collars, do soft collars do anything? They let everybody know that you were in a car accident or some sort of accident of some kind, but they don't really demonstrate really any benefit in terms of making people feel better, pain-free, that kind of thing. However, if a patient has any kind of pain moving their neck in even the littlest of directions, you can put it on for comfort. Just let them know to take it off and do some range of motion exercises to prevent their symptoms from worsening over the next few days. Seatbelt sign of the neck. This is a flag. It's not necessarily a red flag, but it is a flag, and it should be something that if you see an abrasion over somebody's neck after a car accident, it should at least put your antennas up to make you think, is there something else going on? All right? The thing that we're worried about when we see a seatbelt sign of the neck is not necessarily a C-spine fracture, although that could happen. It's mostly to consider whether or not the patient has blunt cerebrovascular injury. Okay? Injury of their carotid or their vertebral arteries. So the really critical thing to do when you see somebody with an abrasion or something on their neck here is to look at that space. If it's massively swollen, that could be concerning. If the patient has neurodeficits in addition to that abrasion, that is concerning. If the patient has multiple fractures that you're kind of like looking at on exam, that is concerning. Those patients should get CTAs. There is a criteria. We talked about Nexus and again CCR for cervical spine fractures. Are there any criteria to look for blunt cerebrovascular injury? And in fact, there are. They're called the modified Denver criteria. And the criteria involve all the things that we talked about. Is there concern for arterial injury? Are there neurodeficits? Are there multiple fractures in the C-spine, face, neck? If any of those things are true, then you would move ahead and get a CTA. The Western Society, the guidelines that we were just talking about, they actually have an explicit guideline about seatbelt signs of the neck, and they state explicitly that an isolated seatbelt sign of the neck in and of itself is not a reason to absolutely have to get a CTA, okay? But if there are concerning signs or there's bad multi-system blunt trauma, add on the CTA to rule out cerebrovascular injury. It's worth looking at the modified Denver criteria. It's worth looking at the Western Society guidelines to see exactly what the language is. And if you are not getting imaging in a patient that has a seatbelt sign, I always document the guidelines on my chart just to say, per guideline recommendations, we are not doing a CTA for this very reason. Okay? We talked about cervical rib syndrome and thoracic outlet syndrome during the shoulder lecture, so I'm going to skip ahead. This is the East and Addison's test that we had talked about before. We're going to skip forward to cervical disc disease. Cervical myelopathy, you will see a lot of this over your career, patients that come in that are complaining of just sort of like bilateral tingling or unilateral tingling, and you're trying to figure out whether or not you need to get imaging in these patients. In general, my rules of thumb are if I get somebody who has some tingling in their arms that I think might be cervical myelopathy or cervical stenosis, as long as it's been sort of an insidious onset, it's been going on for a long time and slowly progressive, that's somebody I might send out for an outpatient MRI. However, if I'm getting bilateral symptoms and particularly I'm getting motor weakness on those patients are patients I have a much lower threshold on getting an MRI in the ED, particularly if it's a rapidly progressive course. If they're telling me, hey, yeah, I had a little bit of numbness like 3 days ago, but today I can't like hold a cup with either hand, that's somebody that I'm going to be thinking about MRIing, not just for cervical disc disease. If they have risk factors for other things like epidural abscess, for example, somebody who's a diabetic or IVDU or a steroid user, immunocompromised, and they're telling you they have motor weakness, you're not just going to do an MRI non-contrast. You're going to want to get an MRI with and without contrast to make sure they don't have epidural abscesses or any other concerning things. But if it is slow and unilateral, then typically outpatient MRI and outpatient follow-up is just fine. Cervical stenosis, same thing. These are patients that have a little bit of impingement on their cervical spine. Symptoms tend to be slow and progressive. Same rules apply. Bilateral motor weakness, rapid in onset, those patients I would MR in the ED. Otherwise, outpatient MRI, NSAIDs, and pain control with PMD follow-up. Cervical facet syndrome, so we're coming toward the end. Cervical facet syndrome is something that you may see in a patient that you discharged a week or 2 ago or 3 weeks ago who had whiplash, but now is coming in with persistent headaches, tension headaches, occipital pain that is just getting worse. It's not getting any better. The thing to know about cervical facet syndrome is you're going to give pain control. You may want to send them to their PMD or to a pain specialist. There are sort of intra-articular injections that people can do that can help these patients. So if somebody's coming in really sort of desperate with persistent pain after a whiplash, they're probably suffering some form of this, and they can get outpatient follow-up, and you can let them know that there are some injections out there that might help them. All right, last one, the stinger or the burner. It's Friday night, you're working the emergency department. You get a patient coming in from a high school football game, they're in their pads, they've taken off the helmet. The reason they're there is because they went head first and they speared and tried to tackle somebody, and they had what they call a stinger. Okay? What are the stingers that matter and what are the stingers that don't? The stingers that are typically okay to have, you went head first, you hit somebody, you get temporary numbness in your arm that has now since resolved, doesn't necessarily need further imaging in the ED. However, same thing applies to what we were talking about with cervical stenosis and cervical myopathy. If they're having bilateral symptoms or motor symptoms, you certainly would be wanting to get an MRI in that patient. All right? That is the end of our cervical spine lecture, and thank you very much for your attention. This out.
That was really excellent. Excellent. Those of you leaving now are going to get sued. So let's go through some literature about what you ought to consider trying to study up on. And this first study is a really good study. It was a really courageous study. It was a large ER group, took all of their cases over a period of time, 4.5 years, and looked at their number of, they were self-insured. These groups are generally insured for the first $500,000 or $1 million, and then the rest is Lloyd's of London. But they're highly motivated to have procedures and protocols and training in place to limit the likelihood of lawsuits. And so I think this group is probably pretty much at the top in terms of their care, and they've been good all decades since I've known them. So this is about, they're probably bigger than this now, but this is 87 EDs in the 15 states that they were contracting in. It's a little dated, it's 2010 to 2014, and we're 7 years beyond that. They found 98 claims by 90 doctors, so some doctors contributed more than one claim. They used to work with the group. 1 in 11 emergency physicians got sued after a 4.5 year period. That's kind of a little frightening because your career in emergency medicine as a physician at least is supposed to be like 30 years or something like that. And for those of you who are PAs and MPs, your likelihood of getting sued is so much less, largely because when there's an issue, it'll be because your error will be related to a lack of supervision, appropriate supervision, adequate supervision by the physicians that are working in the department. But this is what they found in terms of the things that were most likely to be sued on, of the claims that they had. It was surprising, 28 of them were neurologic claims. I would have thought in the old days it was cardiologic claims for sure, missed eyes, that kind of stuff. This is all about strokes, and this is all about failure to give thrombolytic therapy. And unfortunately, thrombolytics has become the standard of care, and despite the fact that there are cogent arguments why that ought not be the case, what people do de facto becomes a standard of care. And so if you were going to study something based on this list, you would study about how do I diagnose strokes, and how do I diagnose stuttering strokes, and how do I diagnose posterior fossa strokes, which are the most difficult to do for sure, because the issue will be failure to give thrombolytic therapy because the diagnosis of stroke wasn't made, or in a few cases it's fair that you gave thrombolytic therapy, the person has a bleed and they never had a stroke in the first place. And some of the biggest claims against in strokes has been getting thrombolytics and not having a stroke in terms of dollar value. So cardiovascular is, GI is next, and it's like, what could be in GI that would be, and it's surprisingly, year after year after year after year, people are still getting sued for appendicitis. And some of these cases who have a delayed diagnosis wind up having ruptures and getting abscesses and having nasty scars and multiple surgeries and the like. So it's still an issue. And you read cases all the time. And even when you read the case, it's like, what is the diagnosis in these cases? The diagnosis in these cases is gastroenteritis, gastroenteritis, gastroenteritis. So anytime you make that diagnosis, they have gastro, are they vomiting? Do they have enteritis? Are they having diarrhea? Have I missed anything that is of a surgical condition? Because that is the most common wrong diagnosis in these cases. So as you get better and better with ultrasound over the years, you get a little scan there, a little thing. But ultimately, and particularly in children who have abdominal pain, ultrasound is the first thing to do in children. It's kind of the ultrasound first protocol, and if that's indeterminate or you have a high degree of suspicion ultrasound is negative, then they get a CT, because they're really trying to decrease the amount of radiation that these little kiddies get. Although I must tell you, there's a whole bunch of protocols now where they're using less and less and less radiation, and where they're using more computer programs which basically reconstruct pictures with using less and less information. So that's largely missed appendicitis. Cardiovascular is going to be, most of them, heart does two things, pump and have a rhythm, and most of these are not related to rhythm, so they're generally related to ischemia or missed myocarditis. Remember, the idea here is an increase in the heart rate disproportionate to what you think it ought to be, shortness of breath, listen for some rails, particularly in little kiddies. This diagnosis is the one that's often associated with going out. I was at the ER for the shorter breath kind of thing, and there was a sudden death kind of case. And they do an autopsy, and that's the diagnosis. So I think that's pretty much it. Obstetric and gynecology, I don't have any number beside there. Maybe there wasn't that much. I think that we've got it down now how to diagnose ectopics. Before we used to do choledocentesis, what a brutal kind of thing that was. But now we have really good ultrasonography if we need it, but you have to think to order it kind of thing. Orthopedics, that was always there in the list. It's kind of missed fracture, and as a result of the fracture, there was some delay in healing or something like that, or there was some kind of residual arthropathy that occurred in the wrist as a result. But it's still, out of these 98 cases, it was 8. So it was talking about, something like 9% out of them, or 8 or 10%. So it wasn't a big deal. Respiratory, look how low respiratory is. I wonder why that is. Given the fact that the big misser there is pulmonary embolism, I think. I mean, it's not about missing pneumonia or maybe it's a bad asthmatic or something to that effect where they are desperate and you're now getting into the ketamine intubation kind of phase of an asthmatic. But pulmonary embolism is the killer of the asthmatic, status asthmaticus potentially. But pulmonary embolism and missed pulmonary embolism are, I think, from what I've reviewed, are the most common cases. It's really essential that you know the algorithm that I think Diane went through, where it's talking about you just can't order any test until you've done a clinical risk assessment in terms that you tried to determine whether they're low risk, and if they're low risk, then the protocols follow. If they're not low risk, then it doesn't matter if they're not low risk. They don't get any D-dimer kind of thing if you think that it's a high risk case. So you go right to CT pulmonary angiogram. So that's what they found, and that's what they contributed. And I think that I've never seen another study like that where a group kind of opens their books and says, here's what happened to us. The resolution, obviously, 70 of the 98 cases were dismissed. Man, those are good odds, and I think that attests to them in terms of their ability to communicate to their colleagues the issues that are of concern, so they got dismissed. Although most cases, certainly most cases that go to trial, if you go to trial, the doctors or PAs or NPs, whoever's going to trial, they generally win. Look at that. Defense verdict 4, plaintiff verdict 2, but only 6 cases went to trial. The idea is kind of like not to go to trial if, in fact, it's clear you made a mistake. Let's settle this thing, and kind of that's it. Now, one of the things that's kind of interesting is it didn't matter whether you were male, female, board certified or not board certified in emergency medicine. The only thing that mattered is how many cases that you saw, which meant that basically it was just a matter of time. The more cases you see, the more likely your risk is there. Not everybody's going to be sued, certainly, but the odds are not particularly good, and even in this exemplary group. So when you try to make the case for board-certified emergency physicians, can't do it with this. I mean, maybe there are other ways to do it, but this isn't one of them. What happened to those doctors who were sued? What did they do in response to their suit? Did they start ordering more tests or something like that? No, they didn't. They looked at the behavior of 65 of the sued doctors and compared it to the behavior of 140 matched doctors who were not sued. And there was no significant change in their medical behavior except one thing, and it changed immediately. It was their Press-Ganey satisfaction scores. What does that say? I think it says, if I'm nicer to the patients, maybe this will less likely to happen. Maybe if I don't have maybe there's a case where there's some antagonism that developed. Sometimes people just are not good at, seeing certain kind of patients, and if you're working with some other partner, maybe they could say, see that case or help you with that case, so that you don't have to get into any kind of issues. Press-Ganey scores. Now, being the skeptical person that I am, I basically thought it would virtually be impossible for doctors to order more tests than they do now. So you couldn't show that they ordered more tests because they can't order more tests. They order everything that's ordered. Shared decision making. This is kind of interesting. Somebody talked to you about shared decision making, did they? Well, here's some data about it. This is it's 804 adults who were sent a survey about a hypothetical case, and the case went bad. And there were 3 variations. In one of the cases, the clinician spent a lot of time on shared decision making, pros and cons, and here's the option, did it. In another scenario, the clinician provided a little bit of shared decision making with the person. In the last scenario, they had no shared decision making. They had no shared decision making. 41% of the people said, I'm going to make a complaint or talk to a lawyer. 41%. If you had a lot of shared decision making or little, it was both 11 or 12%. So it was virtually the same. So it doesn't mean that you have to give all the potential. Just talk about here's the options. What do you think? Do you have any preferences, et cetera, that kind of thing? Goes a long way into making people think that they were involved in the decision. And when they think they're involved in the decision, it's a lot harder to, cast aspersions on your care. So I thought that this is not the only article that talks about shared decision making. And even in emergency medicine, there's a lot of opportunities for shared decision making. Otitis, Mom, it doesn't look particularly bad now, but I can give you a prescription, and if Mary's not feeling better in a couple days, you can start it. I personally don't like that idea, personally, because now this kid is getting worse compared to when you saw them, and you better make sure your diagnosis is correct. So I just don't like the well, you decide if you want to use antibiotics. I think from a risk management point of view, that doesn't make a lot of sense. You're going to, what do parents know about this? They don't want to make another visit to you. They don't want to miss work, anything like that. So they're very prone to, or some of them, the minute they walk out of the ER, they're going to the pharmacy because I wanted the antibiotics all along. Although studies have shown that emergency physicians are not good at determining who wants the antibiotics, who wants the drugs. They've done this repetitively, and the people who we think want them often don't, and the other way around. So, the importance of shared decision making. The other thing that it resulted in were some good things as well, and this is maybe why these people didn't sue, because they had a higher degree of trust. They rated their physicians more highly and were less likely to find fault with the doctors when they had adverse outcomes because they were involved. This is another malpractice insurance company looking at, and these people are insuring hospitals. So this is it's not necessarily the providers, although if the providers work for the hospitals, if they were PAs, MPs, physicians working for the hospitals, then they would be thrown into this. So that's why the numbers are a little different, but I think the body systems involved still are important. So number one source of cases were surgery cases, number two, physician's office, number three, and number four is the ER. So we're only 13% of this insurance company's problem. But maybe the issue is, what is the magnitude of our claims? This is more consistent with ER, and this is ER specific now. They're trying to basically show what we found in terms of our ER cases, our ER hospital cases. But when you talk about cardiovascular, those are generally going to be clinician mistakes. They're going to be basically, we're talking about chest pain, missed MI, PE, those kinds of things. So, and the vast majority of analyses that looks at clinician behavior, it's diagnosis, diagnosis, diagnosis. 55 to 60% of all of these cases relate to diagnosis. So this is what they found. Infections, 18%. I wonder, many of the big groups, and I don't know if you've heard this or not, that spinal epidural abscess is a major source of big dollar suits for them. And the reason being is because by the time these people come back the second time, they usually have some kind of paralysis that wasn't there the first time, which is very difficult to undo even if they have surgery. So there's often some permanent residual from a delay in diagnosis. Then they're going to say, well, you really should have met a diagnosis the first time. Did you look at a temperature? Temperature 100.4? Well, that's a fever. Did you get a SED rate or anything like that? No. And spinal epidural abscesses, although are uncommon, so that's why everybody has to know about this uncommon disease, uncommon, they're becoming more frequent because there's more people on immunosuppressants. And all the stuff that you see on 6 o'clock news is all about immunosuppressants for inflamed bowel and psoriasis and rheumatoid arthritis and all of these things that they're direct-to-consumer ads. There are all these MABs that are antibodies decreasing your ability to respond to inflammatory processes, because all these things we're talking about are all inflammatory processes. So we're going to target this drug to the antibodies that inflame and the white cells that inflame the bowel, but that doesn't mean that all the rest of you has gotten a pass, that you have no inability to mount a serious response to an infection. So neurologic, medications related, I think this is medication errors on the part of the delivery. I don't know if you saw this case where this nurse, she was supposed to give something that began with S, that was, and instead she gave a shot of succinylcholine, and she killed the patient. And the nurse basically just lost her license in the state, and that was reported just a couple weeks ago. And it was thought that this was a major setback for this idea of talking about your mistakes, finding the system errors that resulted in the mistakes. It turns out that she just started typing in the first two letters of the drug into the Pyxis machine, and basically it popped up these, and she just picked the wrong one, and inadvertently killed this patient. So I think medication errors are going to be primarily on their side. This fracture dislocations, they're obviously not going to be on the hospital side. They're going to be on, what Raman was talking about. GI related, I don't know. Maybe that's appendicitis. Psychiatric related, it really gives me the heebie-jeebies to send out a person who was suicidal or did even suicidal gestures. You got to. I think these are all cries for help, but some people are more serious than others. Like around Christmas time, this is single men around Christmas time who are elderly, have no family, or are left alone, kind of thing. Bam is and it's generally by gun, some violent kind of way. And so you have to have a low threshold, because otherwise, what can you really do for these people? And you can't get them into a place and you're holding them for three weeks. But that's better than saying, let's sign this contract where you agree not to hurt yourself. Don't do that. That is a fundamental error. These people are suicidal. You think, I'll sign anything, I'm gonna get out of here. Have you thought about, I don't know, has anybody given any IV ketamine for suicidal patients? Anybody do that yet? Well, considering the fact that we can't do anything substantial for these folks, it's so hard to get a psychiatrist to see these people. Then you get the, this people who come in and investigate potentially suicidal people, and then they give those people, generally give you an opinion. Here's what we think. Well, how is their opinion any better than what you think? It's like 2 third graders don't make a 6th grader. So it's like, I don't know. So I think that within a short period of time, I'm not sure, that people will start trying to give infusions of IV ketamine for suicidal patients in emergency departments. There's lots of reports of them feeling remarkably better in an hour and a half. Now, that doesn't mean it works on everybody, but considering that you don't have a lot of options here, and especially if you're out in the sticks or you can't transfer somebody kind of thing and the weather's bad, I would think it's not unreasonable. People often say, these are just nuisance suits. A nuisance suit, that's what that is. These people. Look at the severity of these suits, and this is showing up all the time. 36% of them died. A third died. These were nuisance suits that killed them. And grave injury, 2. Major permanent injury. This is not just giving anybody emotional distress. Significant permanent injury, 15. Minor permanent and varying degrees of severity, but temporary. Only 30% of these were temporary. 70% of the people had some permanent problem going on, and 44% had either died or had a serious problem persisting. Lawyers don't want to take cases that are kind of nuisance suits because there's too much money involved. They have to pay the experts, ridiculous amounts of money for depositions and all of this. This is the easiest $1,000, an hour some of these so-called experts make. So I think that that's kind of an issue. what are the sources of these errors? Clinical judgment is always at the top. In this case, there were both nurses involved who may have done medication errors, so that's not a clinical judgment thing. So the fact that this involves hospitals dilutes down the number that really is generally in the mid-50s for looking at clinician errors in emergency medicine. It is diagnosis, 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 diagnosis. Clinical systems, I guess there's one of the worst things that you can do seems to be one of the most technically sophisticated. It's the reporting from the lab or radiology electronically of results. And sometimes those results, and this has occurred, have been critical results. And critical results were, there they were, nobody ever said anything to anybody, they were the critical results, but there it is, it's electronic, it's potentially right in front of you, look for it. These things should be called. An old-fashioned thing, like a telephone call, should be said, Mr. So-and-so, bed 14 has a 1.8 potassium. And then you put down on a chart, who you spoke with when you got that information, and you time it, and that's the reasonable thing to do, just to kind of put it into some system. Well, maybe it flashes red or something like that, but you got to be there to see it flashing red. So clinical documentation systems have been the source of some errors. Communications, I think communications could be, pass-ons are considered by the Joint Commission to be a substantial source of error, pass-ons. And we do pass-ons depending on how long shifts are, twice a day pass-ons, or 3 times a day pass-ons. And pass-ons basically are, listen, Mr. Jones, we're waiting for his CBC results. If it's normal, you can send him home. I mean, how many times have you heard that in the past? Once you accept the care of Mr. Jones, you are totally responsible for the care of Mr. Jones. You might as well just go in there and start talking again. That's why it's one of these good things to do, is to have what it's called waterfall shifts, where you stop, your colleague comes in an hour before that, and so you finish all your charts and you finish up with Mr. Jones, so the opportunity to pass on patients is much less. You got rid of the stuff where, would you just check the CT result kind of thing? Because it's a new patient for you, frankly. The lab already may be there, but you've got to ask some history. You got to see how you're feeling now, Mr. Jones. And because you were totally responsible for the disposition and deposition of that person. So pass-ons are, don't think that you're not fully responsible. Well, my friend just said, look at a white count or check the urine kind of thing. You can get away with it the vast majority of the time, but when it goes bad, and medication-related, I think that's not clinician-related kinds of things. I think it's kind of on the nursing side. What do they say are the predisposing factors? Well, obviously the chaotic environment of the ER. Why is the ER chaotic? Why does it have to be that way? Why can't, given the charges that we're rendering in the emergency department, can't we just not have this chaotic environment? We're charging them $1,600 for a sore throat, sprained ankle, sore back. If I were an attorney and I was suing somebody, I would want to look in the logbook. How many patients were you expected to be seeing at that time, doctor? Did you have the opportunity to call in any help to help you out? Because you got this whole list, and it would be anonymized and shown to the jury. This doctor's being asked to see these 12 patients, ladies and gentlemen. Do you think it's a reasonable thing to do, ask a doctor to see 12 patients? I mean, that seems to me to be a pretty compelling argument. Oh, you had no backup? Why didn't you have any backup? Because it costs some money to have backup? What was your salary last year, doctor? I think you could make an embarrassing case if you just have too many patients, you're asked to be seeing too many cases, it's a dangerous environment, and you ought to fix it or get out of there. Everybody talks about these biases. Anchoring bias, that's kind of near the top of the list. You go in and see chest pain. Chest pain is generally, is it cardiac or not? But the big three are cardiac, PE, and dissection. And dissection is by far the least frequent, but you've got to address the big three. Whether it be clinically, I've checked the pulse, there's no evidence of no family history, those kinds of things, so that there's no pregnancy. Pregnant women are at increased risk of dissections. In any case, so the ER environment, that's for sure. And the idea is when you go to ER, you have to wait. Well, what other business makes you wait? You want to go buy a car and make you wait in the waiting room to buy a car? No, they don't. No. So why don't you have the help that you need so that patients don't wait, they get seen, promptly, et cetera, et cetera. Not using tools like Rahman was talking about some cervical spine tools. There's the Welsh, there's the Geneva scores, the Wells scores, all of those kinds of things that could be used. So to say, to defend your practice, I used this guideline. I used the PCARN score for head injuries in kids over 2. I followed them, so it makes it much more difficult to attack your practice because these are evidence-based guidelines that you're using. Communications. This is about I thought you were going to do that, Frank. No, Mary, were you? No. So this is often verbal communication. That's why handoffs ought to be done in the room with one person introducing the other person to the patient, and make it clear what the handoff is about. And they think that in terms of drugs, the top 3 errors with regard to drugs are antibiotics, opioids, and anticonvulsants. I'm not really sure how, antibiotics is a source of malpractice suit. Well, maybe allergies, and it says right there on the chart, and you've forgotten they were allergic kind of thing. Opioids, maybe because you didn't, I don't even know that it's really a standard of care that you can say, well, you're supposed to get when you leave your Narcan and everybody, and you didn't do that, and you violated standard of care, and one person went out and they overdosed. I would think that they would come back but the question is that the standard of care? Maybe you can get people to say, yes, it is the standard of care that you get your Narcan prescription when you leave. This is this is a doctor's company. This is the largest physician-owned insurance company, 332 ER claims. It's a little bit more, it's still dated a little bit, but I don't think it's really changed anymore. This is the list that you ought to learn. This is the list. Learn this. And it's, again, CVAs are there, spinal epidurals, PEs, meningitis. The other list didn't have meningitis on it. Meningitis is still occurring in 1 and 2 month olds. That's definitely sure. Why you get sued for torsion and missing a torsion, I have no idea. What's the damages in missing a torsion? Are there any damages? What's the damages? Can you not get somebody pregnant? You only need 1 testicle to do that. Is there anything like, well, when I go to the gym, I only have 1 testicle and I feel bad, and it's, well, we'll give you a prosthesis like a chicken egg, and you'll be the biggest guy in that gym, So where's the harm here, kind of thing? And when you don't get somebody pregnant, you let us know, and then we'll give you the money. Subarachnoid hemorrhage. We have now some protocols. I think the Canadian stuff about 6 hours, I think that's really being adopted, although people will say, I know of the case where the CT scan was negative within 6 hours and it was still positive. Lung cancer, it's hard to, this is the incidental findings. There's a little thing on there, would you call the patient up? That was an incidental finding. Over and over and over. ERs don't have solid ways of getting these incidental findings and culture results and acted on appropriately. Fractures, yeah, we missed a fracture, and appendicitis. Now, the list is kind of the same over and over again. I can't read this. This is the last thing I think we want to talk about. It's sleep deprivation. So this is a study, almost 7,000 drivers involved in a motor vehicle accident, self-reported. This was done by the AAA Foundation. And those, compared to people who have 7 or 9 hours of sleep, if your odds of being involved in a culpable motor vehicle accident, if you had, bottom line, if you had less than 4 hours of sleep, your odds were 15 times greater than if you had 7 to 9 hours of sleep of being involved in a culpable automobile accident. A culpable automobile accident says, get ready to be sued. Because they found out that you are a Dr. PANP kind of thing, look at the average salary, let's go after this one here. So this says 2 hours or less in the preceding 24, you're not fit to drive. This is the AAA saying this. Can you see the lawyer saying this? Are you familiar with the AAA? You know? So you need to know this, because this will be used against you. And you shouldn't be working unless you had some sleep. You're dangerous. You're not only dangerous to yourself, you're dangerous to everybody else on the road. In a driving simulation, 21 hours of continuous wakefulness was equivalent to a blood alcohol of 0.8. 21 hours of continued wakefulness. So it could be very costly to do this. So this law in New Jersey, driving without sleep for more than 24 hours, you are going to be arrested. You can be arrested. This is a crime in New Jersey. Don't read your proofreading. Almost 52,000 claims, closed claims. 9 cases with speech recognition felt to be a factor. 9 cases. So these people decided, well, if that's the case, you ought to read all your charts. This data would say that's just the opposite. Proofreading appears to be a waste of time. 9 out of 51,800 several cases. This is how you make $500,000 fast. Policeman says to draw blood on somebody, and they don't say it to the right person, and you're trying. In this case, this was a nurse who was asked to draw blood on a truck driver who was hit by a drunk driver, and the cop wanted blood on the truck driver, and she refused, and she was put in a police car, and she earned $500,000 for that. This was transmitted all over on the internet. $500,000 is what that cost. Prisoners, if you want them, the cops come and say, would you check? I think he stuck something up his rectum. You cannot do anything to these people unless they agree. That you can give them a laxative if you agree to that thing. You agree to a CAT scan, we can see maybe something down there kind of thing. Because you got to tell them that if any of this stuff breaks inside you, it may kill you. But you can't do, the cops can't tell you to do anything. You are not an agent of the police or the state. They can't order you to do anything. This is a couple interesting, this is the asymptomatic hypertension one, where they note that 4 years later, they note that I was in the ER and your blood pressure then was 160 over 100, and there's no documentation that we're given any referral or that you were advised. Let's just pick a couple of these. I think I went through these cases. Prescribing unfamiliar doses, that was the guy who gave the psychiatric medicine, who was lower than what the patient was using, and that was $1 million. I never understood why anybody would co-sign a chart for somebody else on a patient they never saw. Why would you put your name on a chart of a person you never saw? This is a chart. This is not a QA thing. QA stuff is done on separate pieces of paper that don't go into the chart. You're putting your name on the chart. I like the third one. Patient assumed that the caregiver was a physician because this was a nurse practitioner. And this person was seen multiple times in an orthopedic setting over and over and over. And this person, for multiple visits, thought they were being seen by an orthopedist. And then at the end here, basically said, I didn't know that you weren't a doctor. That's $500,000. Oh, nobody does this, acknowledging the policy manual. When you new clinician come on board, they know all the rules of your state and your department and your hospital that they must follow. There's a policy manual, but I don't think most people do that. Did you sign your name on the bottom of the policy manual that you read all of this stuff? I don't know that some of these are pretty self-explanatory, and I don't want to hold you any longer because all these people are waiting over here. So let's just go on to our review session.
Yeah.
Somebody left a phone?
Yeah, before you go, I have this phone. Whose family members or friends are named Chunky Head and Toto?
They may not be willing to acknowledge who they are.
Chunky Head.
Any family members for Chunky Head here? Paging Chunky Head.
Chunky Head and Toto.
Well, they must have left, so
Oh,
we'll keep it under those terms.
Looks like a brand new phone, too. Is it on yet? With a really nice case.
They'll come looking
I
for
feel
it.
bad having Mike. Look, we need to
Look at his poor
split these
kids.
chairs up.
Chunky
Where's
Head.
his
Look,
helpers?
see?
Where do you see the chunky head?
Chunky Head text message.
I'd like to
Yeah.
introduce you
Toto
to one of our
text
speakers for
message.
tomorrow, Chip Lang. Chip is a PA, and is going to be joining us and give us a number of talks in the next 2 days. So since he's here, I thought, another head, another brain. Thank you, Chip, for joining us.
2, 4.
Just
I'll sit.
anywhere,
Sit.
anywhere.
Are you gonna
Is
sit?
there anybody else
I'll sit.
coming here?
Okay.
You're sitting?
I'm sitting.
All right. Yeah,
This
take a
is
load off.
optional. I'm sure you've been through this.
Yes. Oh, yes.
Oh, yes.
Okay. Woohoo! We're just going to bring up the question bank. No one has admitted to finding the color manual, huh?
There was one out there? Oh.
I'm trying to get it back.
Oh, that's a bonus.
I know.
I don't know that I would say anything if I had it.
Yeah. Well, they probably put notes in it. So
Yeah.
but we also just wanted to kind of see how it turned out because we never actually saw it. So
Let's
yeah,
go.
there's that. Okay. Gosh. Okay. We have a ton of questions for Jan. Jan did a really good job answering a lot of these, but let's go right through them. We admit viable pregnancy abdominal pain to OB for clearance before DC. What evaluations are they doing up there to deem fit for DC?
Yeah, so usually if someone's over 20 weeks and they're in that viable range, often, before you clear them, OB would like to take a look at fetal heart rate and sometimes do some short monitoring depends on what their complaint was or what they were there for. But they're most likely doing sort of a fetal heart rate assessment to make sure that the state of that part of the pregnancy looks good. But there might be other things that they're doing depending on what they were there for. But that's probably the most common thing that they're doing that you're not doing in the ED. The thing that they can offer additionally.
Yeah, like in the setting of trauma.
Yeah, for example, that.
Yeah. Oh, this one was good. Comparisons and contrasts between Kawasaki's versus
Miss C.
a multi-system inflammatory syndrome. So yeah, this is a very complex set of diseases here. They have a lot of things in common. And I posted a couple links that help determine the difference between the two. Essentially, the Miss C patients, they're older, they're more likely to be hypotensive, they might have significant gastrointestinal symptoms, but this lymphopenia was a defining factor, and also the lack of coronary involvement as the issue, whereas in Kawasaki's, there is immediate and obvious involvement on echoes and coronary arteries. So those are the big differences. Of course, the treatments are very different. So you give steroids for the Miss C, and you give IG and aspirin to the Kawasaki people. So most likely, you'll be saying, my differential diagnosis includes, but is not limited to, Kawasaki's disease, Miss C, and then the patient gets admitted, and then you can follow up with the final findings. So I don't know if you guys wanted to say anything else about that.
Yeah, no, I think the age that the Miss Cs are a little bit older, we're still learning about Miss C, but, obviously the COVID history and is kind of part of it
Oh,
too.
yes. The COVID history is the big deal. I'm sorry.
That's okay. I
That
guess
is
that's, goes
super-
without saying.
Yes.
Yeah.
But, nothing is obvious here. So yes, the Miss C is absolutely related to COVID. Kawasaki's is more of a vasculitis related to some kind of inflammatory process, not COVID.
But you made the point, like, whether it's one or the other, from your perspective, that's a person who's getting admitted. You're not making that decision and sending them home. So it's okay that you may not know. That may be part of their admission, is to sort out which one it might be. But both of those are pretty serious conditions, so yeah.
I like this next question. How do you decide should you do a transvaginal or transabdominal ultrasound?
Yeah, I think the most standard protocols are to start with the transabdominal and see what you can see, and if if you can see it there, then you don't need to go transvaginal. But it depends on where you are in the estimated dates, et cetera. But usually people will start. The protocols are mostly to start transabdominal and move to transvaginal if you can't see anything.
Yep.
Yeah.
I have some STI questions. STI cases where you need to treat the partner. Do you prescribe to the partner if they're absent, number one, or
Yeah.
if they're present, do they need to check in as a patient?
So I did post a link on the Slido, which I think is a really useful link that talks about expedited partner therapy. The CDC recommends expedited partner therapy. Most states it's legal to treat the partner, not all states, however, so you have to know where you're practicing. And I think people's approaches to this are a little bit different, but in general, I think we all would agree from a public health standpoint, it's wise if you practice in a state where you can do it to try to treat the partner. Now, one of the questions that come up, a really common question that comes up is about gonorrhea, because the recommended treatment for gonorrhea is ceftriaxone IM. So you can't really send ceftriaxone IM home with somebody to give to their partner. You can give cefixime PO, that's a second or third line treatment for gonorrhea, but there is a PO option, or they could obviously come back and get treated. But in the states where you can do it, you can do it. It is kind of a hot topic right now because people are trying to educate more people about the fact that you can do this, and some people are uncomfortable with that, and that's okay. I mean, I think practitioners are a little different about that, but I think it's a pretty low risk thing. What do you think?
Yeah, and I don't know, even practically in places where you can do it, because in California we can do it,
Yes.
I've seen providers do different things where I've seen them write 2 prescriptions and you get, have them fill both prescriptions and then get that to the partner. How do you prescribe for the partner?
Yeah, I'm pretty liberal prescriber, so I will just get the partner's information and I'm happy to prescribe it. Some people are a little uncomfortable, treating a person that they've never seen, but so some people will put the prescription in the patient's name and then just document I'm giving them this
For
medication
expedited
for the
therapy.
expedited partner therapy. You can do it that way too, like you mentioned. Yeah.
Okay. Are we staying away from clonidine for blood pressure management? Well, I know Diane is gone, but I'm sure that you all have opinions on this.
I do. The answer is generally yes. It is not recommended in the JNC8 as like first or second line for sure, but there may be some situations where it could be useful. It's an alpha agonist. It can have some specific applications. People who have been on it forever and it works for them, I don't necessarily, insist that you change it. I would be happy continuing it. But if I'm starting someone on a new medication, I wouldn't start clonidine.
Yeah, I have the same
Yeah.
approach. If they're on clonidine, they're supposed to be on clonidine, and I'm putting them back on their meds, I have no problem. I'm not somebody, there's no real reason in the ED to add on clonidine for acute BP management.
It's multi-times a day dosing. It's not like a once a day dose.
Yeah.
You have to take it multiple times a day. But some people are on it. It's funny how people in clinics like to give it because it's like an easy PO med to give, but you get a lot of rebound hypertension, and it's not a great drug, so it's definitely not first line.
Okay. Next question. Would you repeat the LIMPs?
I actually put a link to the article. This was that mnemonic for the limping child. It was L is leg calf perthes, I infection or inflammation, M is malignancy, P pain from trauma, S is skiffy, and S is silly. It's somewhere else.
It's not the hip. What do you mean silly?
It's silly because from somewhere else. Because
Yeah, from
you know,
somewhere else.
Yeah,
Okay,
yeah, yeah.
got it,
There's
got
not
it, got it.
particular.
This is a really good cheat sheet to keep in the peds, ER, or urgent care, and just kind of always have that in the back of your mind, like when that kid comes in, what you could be considering as a diagnosis, and it's handy. Okay, with I like this question too. We get this every year. With ceftriaxone treatment, is IM preferred over IV administration?
Yeah, it's a good one. Most people just don't have an IV in, so they put IM there because it means it's just so much more accessible to people who work in clinics where you don't put in IVs. IM is just fine, but if you happen to have an IV, it is okay to give it IV.
You may.
Which is much less painful for the patient, for sure.
Yep. Okay, here's a little mini case study. A young man came in with chlamydia, second time this year. All tests negative besides chlamydia. Took Doxy, BID, 7 days, no change of penile discharge. What would you do next?
This sounds like maybe not a hypothetical.
Asking for a friend.
Yeah. Didn't you answer that one?
I
you?
did.
Yeah,
I
okay.
said, what did I say? Oh, probably need more information, and your differential diagnosis would include. And then I put some possibilities of what you should look for. What are your differential diagnoses for penile discharge, right? What could this patient possibly have going on? I put the Medscape differential diagnosis link in here. Rick or Chip, what would you be on your diagnosis?
So they took their doxy, they still have discharge, it didn't work, but they were positive for chlamydia. So there could be
Yeah.
something else going on, I suppose.
And they've been treated for chlamydia at this point.
Is that all they've got? I don't know, but did they get anything else other than the doxy on their index
Yeah,
visit?
Like, did they get their ceftriaxone? Yeah.
This is all we know from the
Yeah,
random anonymous
yeah,
posting
yeah.
question.
I might continue the doxy for longer.
Yeah.
I mean, 7 days, you could go longer.
Mm-hmm.
There are other, non-gonococcal types of urethritis that I think you need to consider, which I think is what you're getting at.
Like uriplasma.
Yeah, there are other things. So there might be some unusual organisms as well.
Yeah.
Yeah.
Also, you should ask if they put any foreign bodies in there. I've had that before. I'm just letting you know. If there's a hole, you can stick it.
Ugh.
Okay, anyway, moving on.
It's a good motto.
You guys must be tired. Didn't laugh at the penis jokes. Okay,
I laughed, Martha.
thank you.
Very well.
Would you still treat patients with vaginal itching, thick yellow discharge, and negative wet mount as candida? It's a negative wet mount.
Yeah, so you think it's candida, but then your wet mat comes back negative, so do you still treat them?
wouldn't
Well,
treat them.
again, I would still think about what else it could be.
Yeah.
I mean, wet mounts aren't perfect, so, if it's a person that's had it before, they say this is exactly the same. I don't think there's a lot of harm in doing a topical azole treatment, and trying it if you think that's what, wet mounts, no tests are perfect, so you always have to, interpret a test in your clinical context. So if everything to you is screaming candida and the wet mount comes back negative, I don't think there's a lot of harm in trying to treat it, but I think you still have to open your mind to what else it could be.
And a
could
pretty
be
low
really-
risk treatment too.
Yeah.
It could be really bad herpes. I've seen that. It gets the skin sometimes get flaky if the patients are obese or there's skin
That's not
folds.
the description of a candida discharge either. It's
Yeah,
not,
that's
it's not
true.
odorous and it's cheesy,
Yeah.
kind of cheesy.
Yeah. If you really do think it's candida, though, I did put a link to the CDC website that talks about non-candida yeast infections and people who get those types of things. And there are some flavors to this whole candida discussion that might be a consideration in this particular patient.
There is this one tablet diflucan treatment, which may kill a lot of stuff.
Yep.
Yeah, that's right.
I don't know if I would use the word flavors in the discussion
Yeah,
of
okay,
this.
not flavors.
Thank you.
You're right. It's kind of gross.
Okay, can you clarify, oh shoot, this was on an actual slide number 33, sexual assault treatment.
Yes.
Are we crossing out azithro and replacing it with doxy?
Yes.
Okay,
Yes.
okay.
It is doxycycline. Yes.
Doxycycline, okay.
Yes, that is correct.
Is there a role for TXA in, what were we talking about for this, vaginal
I
bleeding?
took that question to assume that it was
Yeah.
about vaginal bleeding, because that was kind of the topic of bleeding that we talked about this afternoon. And the answer is definitely yes. It's very commonly used in Europe for heavy menstrual bleeding, and often you are faced with patients who, you recommend an OCP or some kind of hormonal treatment. They don't want it. They're trying to get pregnant. They're not interested in that, or they have contraindications to OCPs. In which case, TXA might be a really good option for them. So you can do oral tranexamic acid. The brand name is Lysteta in the United States, and so that is an option for sure. Yeah.
Okay, can I give NSAIDs with oral contraceptives?
Yes.
Or, yeah.
Yes.
That's a yes.
Yes. Yes.
Oh, here we go. I know this is very rare, but isn't it important to mention heterotropic? Do they mean heterotropic?
Heterotopic.
Excuse me,
That's
heterotopic.
okay, yeah.
Heterotopic pregnancy. I've seen it once in practice, and the patient was very sick. Just in case you have an IUP, doesn't rule out ectopic.
That's true. So heterotopic pregnancy is really rare. It's the one patient population you have to think of it in is
IVF.
patients with IVF that are undergoing IVF. They can have heterotopic pregnancy, meaning that they have an IUP and an ectopic pregnancy both. It's a pretty rare scenario. I do mention it in the advanced boot camp lecture. I have advanced pregnancy topics, and that's mentioned in there. I didn't bring it up in this particular lecture because of just time limitations, and it is pretty uncommon. The good news about people who are going through IVF is they have a doctor who cares about them and the outcome of their pregnancy. So in those cases, if you had a threatened, if you were faced with a patient with pain or bleeding, you would likely be reaching out to their specialist who might, remind you, hey, let's just make sure about this. But it is out there, and especially with IVF being as common as it is, you have to ask about people, using assisted reproductive therapies and to see if there's a possibility for that.
They may not disclose, and I agree. It's just so
Yeah.
much more prevalent now than it was, 10 years ago.
Yeah, but it's a good point.
Okay, in eclampsia, does it matter if pregnancy did not go to full term due to fetal death or abortion? Can you still see eclampsia in the 6 weeks after fetal death or abortion?
And my answer to that one was, from as far as I know, I don't think it matters what the outcome of the pregnancy ultimately is. The factors that are at play in preeclampsia, which are really complicated and have to do with vascular endothelium and a lot of other things, what finally happens to the fetus is unrelated to the pathway of preeclampsia. So therefore, I still think that, eclampsia in the postpartum period is still at play, whether that there's a good outcome or not.
Well, that's when I had it. That's
Yeah.
when I was the sickest. I had delivered and I was hypertensive. I spent one short period in the ICU. I thought at one point I was having a stroke. My headache was so bad and I was dizzy and confused. I was calling Rick like 10 times a day saying, help me, what's gonna happen? And you're like, take some slow mag, which actually helped for all my arrhythmias that I was having, but it was horrible. And it was I was like, come on, I delivered the baby. What more do you want from me? I've suffered enough. So anyway, you guys are getting to know a lot about my health history. Okay, for menopause women with abnormal uterine bleeding and a hemoglobin of 8.1 at urgent care, should I send her to the ER for oral contraceptive use and ferrous sulfate and further instruction?
So the one thing about this question, it says for menopause women. So I don't know if that means someone who's postmenopausal who's bleeding.
I think different.
That's a different scenario than someone who's not postmenopausal. So postmenopausal with bleeding needs very urgent follow-up. I don't know they need to come to the ER for that, but they need very close follow-up.
Yeah.
And even in the other scenario, someone who's bleeding with a hemoglobin of 8.1, there really isn't anything in the ED that we have to offer beyond what the urgent care can offer. There isn't any intervention, et cetera. And as we talked about, an ultrasound, which may be needed, is not necessarily an emergent test. So I would not recommend sending that patient to the emergency department. I don't think that there's much that we're going to do that's different.
Yeah, unless they're going through a lot of pads, you're anticipating that they're going to continue to bleed, and then in which case we could do
Yeah, you can take a look
hormone
and see.
therapy and whatnot.
Yeah.
And I think, medically, legally, and Rick, you can give your opinion here, anytime that you're asking yourself multiple questions about whether you should send the patient, keep the patient, send the patient, you're having a tough day at urgent care, you're not sure about your diagnosis, what's the harm in sending the patient?
Yeah, I think that that's fair enough. I never discourage people from sending people they're worried about. If you're worried about someone, send them on over. We're happy to help. But I think that's a very fair statement.
Yeah. I recently had a Wilms tumor that came over that went to urgent care twice.
Yeah.
And they said constipation. I'm like, how'd you guys, big mess?
Well, it's hard, and in urgent care, you have much more limited resources, right? You don't have as many tests, you don't have an ultrasound, you don't have lots of things.
Well, I actually had talked to the provider because I was working inpatient. I wanted to get a little more history about what happened. And the first clinician that saw the patient, it was a couple of months back, they had a significant feeling that maybe they should go and get further imaging, but maybe the patient could also just follow up, and then they didn't. They just came back to urgent care. And this is a really rapidly growing tumor. I'll show you the images later. They're incredibly impressive in a sad way. And so even the second time, they were like, well, we're not really sure. And then that's when the kid came and got more imaging and found the tumor. So if you have a suspicion of something really bad or you're not sure, send the patient. Who cares? It's not like you're doing it for every single patient that you see.
Yeah. The only thing the caveat I would say, since we do see a lot of people that are referred, is about patient expectations.
Oh, that too, yeah.
Sending them to the ED, like I would caution against promising them that any particular thing will happen in the ED, because the next provider has their own judgment, their own decisions. And sometimes patients are really upset when they were told, I was told I would get an MRI in the ED, and then you get there like, listen, it's not going to happen, and they're just upset.
Oh gosh, and the same goes. You receive and you have expectations that the primary care person gave or whatever. It's painful. Same goes for the consultants.
Yes.
You don't want to overpromise that the consultants that you're going to be
Right.
consulting are going to be able to do something that. So under promise.
Yeah, under promise. let someone else be the hero. It's okay.
All right, what is your opinion on soft collar versus hard collar prior to clearance?
Yeah,
by
so in
CT?
a minor trauma, the standard is to use these hard collars. There's different types of hard collars. The ones that EMS tends to bring in tend to be the most uncomfortable. And then they have, different types of Aspen collars. You can exchange the collar to something more comfortable, but I wouldn't put them in a soft collar until they're actually cleared. If you're in a resource-limited setting, maybe, I worked in Haiti for a summer after the earthquakes, and there were no seat collars. So then we were using saline bags or just something to let the patient know not to move their neck. But yeah, in the ED, I would say hard collars. I don't know if you guys have any.
Actually, so one thing that I'd mention with that is that in some cases you do have some negative effects with hard collars as far as like
For
it
sure.
increases JVP. So I mean you can increase intracranial pressure with it. So one of the big things, if you're going to use a hard collar, just make sure that it's appropriately sized. Which unfortunately most of the time that's hard to get appropriately sized because a no neck is still like a real neck to them. But soft collars can be a good balance, especially if you have someone who's like morbidly obese or has a neck. But again, like the Miami J is one that comes to mind that is like a semi-rigid collar. That's probably a good in-between if you have it. Yep. But if you're in a pretty resource-limited setting like I am, I don't always have that option. And so I think that's the balance. That's just the only thing I'd add to that.
You want to hear something crazy? When I was working in my former county hospital, when we did our mass casualty, and we had lots of patients that were having significant trauma, we used their shoes to stabilize them. I'm not kidding. It's actually really useful.
Yeah, it actually has a nice contour
So
for
yes,
the neck.
you have the contour. So if you really truly have like mass trauma and you're trying to figure out something, or you're in the field, unless they have these guys on, I mean, these would not be fun to put on your head. But yeah, flat shoes with the heel down in the crux here, and then a little duct tape, and you're good.
That's interesting.
Yeah.
I like it.
I mean, but don't be doing that just for fun. Like,
Yeah, don't test
Did
that
anybody
out.
get discharged on soft collar? I'd heard you talk. What do you think about discharging people on soft collar?
You talked about it.
Yeah, I don't.
tell it to the judge.
I don't think it helps, but if the patient's really adamant that they want the soft collar, I think it gives them a better look for when they want to
Yeah.
sue.
Have you anybody watched Doc Martin? The pharmacist in Doc Martin loves the soft collar. She did the soft collar for the whole series.
Yeah.
Here's a question about ROGAM. Is it indicated at any stage in pregnancy, more specifically very early pregnancy, 6 to 8 weeks? I had thought up-to-date reference not always indicated in early pregnancy, looking for clarification.
Yeah, I posted a link to a reference that I found. I haven't found any source that definitively says that there's some like cutoff where you should or shouldn't give it. I mean, I think so. My answer is yes. I think it's indicated in any stage of pregnancy where there could be fetal-maternal blood exchange. I think the issue in early pregnancy is that the blood volume of the fetus is so low that the risk is lower, but it's not zero. So they used to have microdose of ROGAM. It was 50 micrograms in like the first few weeks because the blood volume of the entire blood volume of the fetus is so low that you didn't need that much ROGAM. But there's two different indications for ROGAM. We're talking about when there's hemorrhage that's happening, but there's also the indication for ROGAM where people get it. If they're Rh negative, they do get it later in pregnancy, just prophylactically, irrespective of any fetal-maternal hemorrhage exchange. And so that might be what the reference is, which is that it's given later in pregnancy for that reason, not early. But in early pregnancy, if there's some chance of blood exchange, I would still advise the ROGAM.
Last two questions. For back pain and spinal epidural abscess risk factors, are you getting local level MRI or full CT lumbar? Well,
Or like C-spine, thoracic, lumbar, yeah, like the whole thing.
I thought that they were specifically asking. Oh, so they
Yeah.
want the whole spine.
They like,
Sorry.
would you do do
Yeah.
you do the whole spine, or do
Yeah.
you just do the spot where the, yeah.
And I've been burned by this before, right? You said get somebody with a fever, they have, their IV drug use or whatever risk factor that they have, renal failure, other things. You shoot, you don't catch it, or you catch just like the tip of like T1, and even if they're not having symptoms in the cervical spine, because it's hematogenous spread, it tends to go in multiple levels. So I like to get it at multiple levels. One thing is, I think they mentioned it down there, you get it with contrast. The contrast that you get with MRI is different than the contrast you get with CT. It's gadolinium.
Yeah.
And gadolinium, and I've had this situation come up a few times, one of the risk factors for getting a spinal epidural abscess is renal failure. One of the contraindications to getting an MRI with contrast is renal failure. So anybody with a GFR less than 30, oftentimes radiology or somebody will call and say, hey, we can't get this study because this patient will be at risk of a condition called nephrogenic systemic fibrosis, NSF, where they just turn into like a calcified stone. It's a bad condition. The thing to know about it is it used to happen with the old types of gadolinium, the old formulations of gadolinium. The new formulations of gadolinium that they're using now, really you haven't seen this. It's almost case reportable. And if you ever get into that situation, you're trying to order it with GAD, and radiology is saying no, the association, the American College of Radiology, and the nephrology, I think it's KDIGO, the Nephrology Society, just put out a joint statement this year, 2021, stating that if you have high concern for epidural abscess, et cetera, go ahead and use the GAD. The benefit of getting the imaging far outweighs the risk of this very, very rare entity.
Okay, last question. What are the litigious areas involving antibiotics?
Ooh.
I like that one.
Yeah, it's a whole EMA
Yeah, I
talk.
thought we talked briefly about them. Most commonly, I would think would be giving somebody who's allergic, but you don't know it. I mean, I remember when I was a young doctor, I gave somebody penicillin for something, or ampicillin for something, and it was a middle-aged man. And you ever get these JJ? Anyway, I thought to myself, did that chart say allergic to penicillin? We went and get the chart, sure enough. So we called on the phone, no answer, and basically we sent the cops. It turns out the guy was a federal judge. So I was about to kill a judge. I don't think that would have gone well,
Yeah, that's another litigious thing for killing the judge.
Killing a judge, yeah. Allergies, I would think it would be at the top of the list.
Fluoroquinolones and all of their terrible side effects, yeah. And,
Yeah,
then,
but-
and using it in a situation where you didn't have to use it, right? Yeah.
Those black box warnings that we talked about, what was it? UTI, sinusitis, bronchitis. The time I see it used most often inappropriately is the bronchitis, COPD exacerbation. They're on chronic steroids. Yeah, they're on chronic steroids, and they come in with a acute COPD flare. You treat them because some COPD patients get antibiotics, even if they don't have a pneumonia. You treat them for bronchitis, and then they go ahead. One of the first litigated cases of fluoroquinolone toxicity was a gentleman, older gentleman, was on steroids, got fluoroquinolones, and then got bilateral Achilles tears. That was a problem. So I think that's a pretty high risk group.
Yeah.
Any others?
Yeah.
Bactrim.
Yeah, I mean, these drugs, you have to know about their side effects, because if somebody has a bad thing happen to them, even a bad C. diff colitis, and something terrible happens, they're going to look back to say, was this indicated?
Right.
Why did you use the drug? What was the indication? Could you have used an alternative class of drug? I think those are potential areas for liability. I think that for the most part, we're pretty safe in using antibiotics, but knowing these little areas, and it's important. So.
I would say on Bactrim, somebody with renal failure on ACE inhibitors or any kind of potassium sparing anything, Bactrim can prevent the secretion of potassium in the distal tubules, and so your K can just shoot up. So being careful with Bactrim in patients with renal failure would be important. The fluoroquinolones, there's some. But I think those are some of the danger ones.
The drug-drug interactions, if they're on other
Oh, right.
medications, and
Yeah. They're on Coumadin.
you bypass your EMR's warning about some drug-drug interaction, something bad happens. Yeah.
Yep. Well, that's it.
All right. Thank you guys for staying. We really appreciate it.
Thank you. We'll see you
tomorrow
tomorrow.
morning. Have a great evening.
You guys are troopers. Thank you.
Total
Way to go.
troopers.